realize the importance of knowing the cardiac anatomy for effective and safe RF ablation as well as surgery for curing cardiac arrhythmias.
Maze in this one, yeah.
Yeah.
And
we
we have two eminent faculty, Dr. Vidyadhar, who is a leading surgeon, who's been setting up a program for maze surgery, especially in rheumatic heart disease, which is a neglected area in this country. And we should really thank him and congratulate him for taking this lead forward. And second person who's going to be the faculty for this session is Dr. Andriy Rukos, who's from University of Minnesota. He's got a lot of experience in ablating flutters and fibrillation in the left atrium in patients with structural heart disease. Either it's a prosthetic mitral valve or hypertrophic cardiomyopathy, so on and so forth. So we can't think of a better faculty than these two. And may I request Dr. Devabrata to, along with Raghav, if you don't mind, can you just take over and run the program? Dr. Devabrata Bera is electrophysiologist at NH Calcutta, and Dr. Raghav Bansal is a leading EP from Ahmedabad.
Can we go live? So we are ready with the very warm welcome to India, and we'll get started without any delay. Thank you, sir. It's over to you, sir.
Good morning, everyone. We're going to be doing some dissection today. I'm going to try to focus on the EP side of things. From interventional standpoint, non-invasive. And we're going to start with the outside of the heart first, and then as we go, at some point, we'll stop and show you how AMAZE is done, and the details of that. And then we'll look at relationships of anatomy that every electrophysiologist should know going into the heart to decrease complications and increase your efficacy in trying to treat these arrhythmias. Okay, I'll start with the outside of the heart. This is a heart here that we have here two hearts. The first heart has still all the great arteries in it. It's got the vein. We have the atria are still there. The whole heart is there, and let's start first looking on the outside of the heart to see, the structures to orient ourselves. So first of all, there is, when you see the front of the heart, the heart sits in the chest like this. We call it RV and LV. Obviously, the RV is really an anterior structure. The LV is a posterior structure in the chest. And the first thing you see here is the RVOT area. The main RV free wall. This would be your RVOT free wall. This would be your PA coming up to the pulmonic arteries. Yes, rotate this way. Okay, good. So let's just do that. Okay. Sure. Yes, and there's another chair. Sure. There. Okay.
Sure, thanks.
That's easier. So, we were saying your RVOT, your pulmonic artery coming out to the where it will divide into the right and left PA. You could actually see the relationship here. The aorta would be hiding right behind the PA in here. I'm not sure if we can see the fold here, the transverse. Yes, sorry, I keep rotating. But I need to see too. Just a second here. I'm trying to see if we can get into the transverse. I went through there we go. Yeah. So this is the space between the great arteries. When we do epicardial ablations, you can access the heart.
Should we
here.
mention
This
that
would
we
be
are
your
looking at
anterior
bovine?
pericardium over this area. This would be your anterior surface. This would be your posterior axis. So the heart is sitting like this in the chest. This is the chest wall in front. And when you do an axis, you can go anterior or posterior axis for epicardial. And you can map the entire LV surface. It's sitting in the pericardium. You can actually go up and engage this from this side or this side. This is called, that's why it's called the transverse space in the pericardium. Take this out. The outside the relationships just to keep going to see what we can record from where. So this would be your RA appendage, hugging the front of the heart. Remember, this is your RV to RAAV groove. And this area, this is why you can actually still ablate ventricular arrhythmias both on the right and left side. We'll go to the left side in a second. But this is where you can actually ablate structures in the RV AV groove from the appendages. The appendage, it's actually very prominent here in the pig, in the human is a little bit less prominent, doesn't hug as much the ventricle. And you can actually ablate pathways from the appendage if you have a pathways going from the appendage to the V here. So not all pathways, they're very rare, but not all pathways go straight over the AV groove. Some of them can connect between the appendage and the ventricle. To go over the major vessels still, this would be your SVC. And I'm thinking
That's the whole.
yeah.
Maybe you can pass this.
Actually. We have I think we have a
I think there's a
clot.
clot here.
Yeah, sitting here. So this is how a clot would look like too. So I think we could just follow it up. There we go. So this is the back of the heart, the back of the RA. This is your SVC, and this should be the remnant of the
Probably the remnant of the IVC.
IVC. And then we'll look at the pulmonary veins here in a bit. But this would be your SVC and IVC. Things to think about here is when we do AFib ablation, you could see you can see the right pulmonic veins. They come out from the left atrium. Here, the left atrium is actually deflated. There we go. We're going to open the CS later, but so your pulmonic veins, the right pulmonic veins, would be the right superior pulmonic vein and the right inferior pulmonic veins, and they cross behind and they hug the SVC from behind. When we do AFib ablation, if you remember, we go in and pace into the right superior pulmonic vein. The phrenic nerve sometimes crosses here, sometimes the right phrenic nerve will be sometimes in between the right upper pulmonic vein and the SVC. And the reason we say we have to keep going sometimes into the pulmonic vein, the pulmonic vein kind of hugs the SVC in the back. And then if you pace, at some point, you're going to find the phrenic nerve somewhere here. Sometimes the phrenic nerve is very lateral and you can't get to it, but some variants, you'll find the phrenic nerve here. This is why we pace it. And RA tachycardias can also be ablated from the pulmonic vein, especially SVC tachycardias, because the SVC, the right superior hugs the SVC again. To keep going here, when you open, I think we'll talk about the SA node. But on the outside, the SA node would be on the junction between the ridge from the appendage to the descending SVC. But I think we have to open it here to look at the crista terminalis and look at the SA node. We're still going. I think this would be our. This is the pulmonic. There's plots here.
Yes, they are.
This is going, and that's the aorta.
Yeah.
So the left atrium, see the RA was kept open by this big clot. The LA is more deflated. See here if you can keep this out. Okay. Can Continuing here on the back, we'll have the left atrium, but it's very deflated here. You can see just a little bit of it.
That's one of the veins, I think, yes.
Yes. So this is the what is it? The pulmonic vein here we're seeing here is this very small and deflated. We should see it in the back. They're coming from the right lung and left lung. This is our left atrial appendage. As you can see, again, like the RA appendage, the left atrial appendage hugs the LV on the outside. And let's stop here for a bit and, discuss recordings. So, and discuss actually a little bit the LV summit. This is where we can look at the LV summit. So your LV summit is basically the trigone where between the bifurcation of the left main. So we can open this up later and discuss it a little bit more, but we need to see it here to realize why we're getting recordings where we got them. So this would be your LV summit here. Right there. So this is the PA. The LV summit is you see the left main coming here from under the appendage, and it crosses. They give you
Henry, 1 minute, if I may interrupt. See, when you see this, can you ask the camera to be in one position so that I don't know how to say this. Either he should be behind you, or how does that work? Because when you rotate, it's totally, we are not able to see those structures.
Okay. So we need. Okay.
This is better.
I wish my screen is behind me, so I can't tell what I'm showing. Yes. Okay, I see. There it is. Oh, I see.
Yeah, we will
We can
shift
just
here.
shift that. Let's just shift. Okay.
Hold the heart and you can come to the side of the camera, like the camera, your eyes should be in the same plane as the camera. Then probably we can see better.
Yeah. And this way, I think we both can see the screen and know what we're actually showing.
Correct.
We have lost the connection. Is it through a laptop? We have. Okay.
Yeah, 1 minute here, we're connecting. There we go. Are we on again?
Yes.
Okay, perfect. So we were discussing the summit of the heart. We're going to go back and visit it when we open the heart a little bit more. But this actually is basically the heart. Okay, this is an inverted. So the summit of the heart basically is sitting right under. So yes. So this would be your summit of the heart. See, I am removing the left atrial appendage and going in. That would be your summit. So you can see the left main coming down and dividing under this is a lot of fat over it. You'll not see it very clear here. Dividing it into the left circ and the LAD. So that trigone here, that area would be your summit. This would be your summit right here. This is why we had this discussion yesterday at the end of the day in the evening, whether you can ablate the PVC sitting here in the summit from the left atrial appendage, because the left atrial appendage hugs that area very well. As you can see, you're also hugging the main vessels of the heart. So you want to make sure that if you are pointing down and you burn in the left atrial appendage, you're not burning the left main proximal LAD area. So that's why you need to do an angiogram before you burn through the left atrial appendage. When we put when Darshan yesterday actually put the wire into the venous, one of the venous tributaries is called retropulmonary vein, and that's because it crosses exactly there behind the pulmonic artery. So there's a vein that goes right here into the tissue and feeds it takes the blood away from the summit. So this would be why Darshan was successful yesterday is not only I think it was a good approach because the left atrial appendage, you can imagine here, there's fat between it and the summit area. So you have to go through fat to get to the summit area. You have to go through pericardium to get to the summit area too. So you're ablating by proxy. Delivering RF through the wire into the pulmonic. That's why you call it retropulmonic, because it travels right in between, in the tissue, right in between under the two great vessels. Into the summit, delivering RF through that wire delivers the RF straight to the muscle, doesn't have to go through anything. Obviously, you have to be careful not to burn the left main or the proximal LAD when you do that. Some left circs divide and cross over that corner coming down from the great cardiac vein to the AIV. So also you have to make sure that the proximal circ is away before you do any of that. I know Darshan did an angiogram yesterday too to look at all these things. But these are the two approaches that we discussed yesterday. I felt like this was a good, relevant point to show you the difference between ablating from the left atrial appendage versus ablating straight into the muscle, into the retropulmonic vein tributaries. Other things to look at here is what do we record from where every single time. So what happens, you know, when we go into the pulmonic artery, and you can record the far field atrial appendage, left atrial appendage, because it's sitting hugging here. In the human being, you can actually record that atrial appendage signal from the aorta, because I'm putting the needle here. You see it budging out. I'm actually in the aorta towards the left cusp of the aorta. And this is why when you put your catheter here and you go up enough in the aorta, I'm not sure if you guys are seeing it budging out. So that's why when you go into the aorta and you go up into the aorta, you can record an atrial signal. When you're doing ablation in the aorta, you can record an atrial signal in 3 places, or two main places that you need to know about because they could be dangerous. If you don't know it, you can be ablating the area that you don't want to ablate. Number one, the left main. So if you cross into the left main from here, and we'll try to do that later on when we open everything, you are interfacing with the left atrial appendage. You're going to get actually one of the best atrial signals you can get in the aortic area. I've seen cases complicated where people go, they think they are in the AM continuity. That's because they see an A and a V. And they think they are in the AM continuity, but they are in the left main. And we've seen cases where they ablate into the left main thinking it's the AMC because of the atrial signal. The other area that you can get an atrial signal is higher up in the aorta here. The other implications for EP is that if you go into the PA here, especially on the left PA, so we had 2 days ago an issue with TEE having a lot of artifact on it, so we could not rule out a clot. Going with ice into the RA, into the RVOT, you can go up through the PA and go to the left PA. So this is right PA, we're gonna cross here, left PA is going this way. And the left PA, as you can see, hugs the top of your left atrial appendage. So if you put the ice and point it down, you can actually have an excellent picture of the left atrial appendage, and you can actually rule out left atrial clots in an AFib procedure ablation, AFib ablation procedure. So those are like considerations to take on the outside of the heart. What we do, what are the implications for EP? The same actually in the one thing I forgot to mention is you can get also right atrial appendage recordings from the right side of your PA or right side of the RV free wall, not as prominent in humans as here, but you can record it actually in the PA, far field right atrial appendage signals. I think I'm good from the outside of the heart here. We covered a few things. Let's look at the CS branches here. That's a good point. So as
We lost the transmission. We lost the transmission. Can someone check the transmission, please, from AV side? Like the yesterday's case that Dr. Darshan as well as Dr. Sachin had shown, it's always a good practice in patients with outflow PVCs to take your catheter as forward as possible in the CS. Turn around so that the distal CS pole is more or less where the AIV takes off. And there are certain clues that it is not at that site, because yesterday if you look at it, it was a far field signal. If it's a near field signal versus far field signal, if it's a far field signal, don't ablate there. You may be very early, but the signal is very far field. It's not adjacent. There is fat, there is transmural structures. You should not ablate. Similarly, when you come from the pulmonary cusp, early is not enough. You should have something like a pre-potential with an isoelectric interval. That's very common and consistent in the pulmonary cusp. So if you see a very early signal in pulmonary cusp, but it's looking far fieldish, it's not from the pulmonary cusp. It's what you're looking at is the summit potential through the pulmonary artery. So you should not deliver RF there. Even if you deliver classic responses, it will take about 20 to 30 seconds before the PVC gets suppressed. That means you shouldn't be continuing there. That's your heating by a distance, at a distance. Muthaiya, we are not able to see anything here. Can someone fix the AV, please? Any comments meanwhile? So, couple of things. One is you should irrigate both through the sheath and the distal lumen. So, some of these 5 French will discuss this.
Oh, we're back?
Yeah, we are back. I can see you. Please go ahead.
Hi, am I live?
Yes, please. We can't hear you. We can't hear you. Your audio is off. We can't hear you. Can you unmute, please?
These are pulmonary, the pulmonary veins. Yes, yes.
You can start.
Yeah.
Okay. Can you guys hear me?
Yeah, now we can hear you.
Okay, perfect. Okay, so let's get back to business. So we were talking here about the front of the heart, the summit area. Actually, I'd take advantage of this heart. This heart has been the focus here.
Yeah, this one.
As you can see it, a little bit. Yeah, there we go. Focus. Okay, good. So as you can see, this heart has been deatrialized. So they removed all the atrial tissues already before we start. And you can actually see on this one better the summit area. So I'm going to flip here to the anterior This is your RVOT, this is your RV, this is your interatrial start, interatrial groove in the front, interventricular groove in the front. This is actually your PA. This is your aortic valve. And actually here, you can see the exit of the left main coming down to the LAD and dividing into the CERT. This is actually right here, your summit area. This is the summit, that bulge here, the triangle between the arteries dividing and the coronary sinus driving here and coming down into the AIV. This is your remnant of the left atrial appendage. So as you can see, it is hugging the summit. This is why, again, you can ablate summit PVCs from the left atrial appendage right here. And you can ablate, obviously, through veins going into this area between the two major arteries, right under the muscle. And this is also here, you can see here also why you can ablate the summit area from right under the left coronary cusp, because it's basically the tissue going anteriorly from the left coronary cusp. We'll do a little bit more when we open the heart, but one thing actually we're about to show you was the coronary sinus. The coronary sinus, this is the dilator going from the SVC to the IVC. And if you look at the bottom here of this tissue, go ahead and okay. Let's see here. You can engage. You can see the coronary. You can see the coronary sinus right here. So most of us know we call the coronary sinus the fifth chamber for a reason. You see how big that is? It's actually the fifth chamber of the heart, truly, before it becomes the great cardiac vein. And we call this the vein of vasa Eusenz. We call it a valve of Eusenz would be here, dividing the coronary sinus from the great cardiac vein. I know Venkat calls this the vein of nuisance because it gives you a lot of hard time when you're trying to engage the coronary sinus and deliver a CS lead sometimes. But this is the coronary sinus before becoming the great cardiac vein. You can also imagine that how difficult this is to repair if you tear it through during an extraction. You already have a surgeon shaking his head next to me when we do this. So this is why you have to be careful. We'll talk later today about LVD extractions a little bit. But this is why you have to take this very, very seriously. This is harder to repair and harder to catch than an SVC tear during an extraction. It's harder to follow here, but you can see the pulmonic veins right here. I was trying to look to show you where the vein of Marshall would be. Usually the vein of Marshall would cross up from the CS in between the pulmonic veins and the left atrial appendage. So it would be, let's turn this way. So the vein of Marshall would be leaving the CS from here and getting up in that groove between the two. So that groove here, right under, is where the vein of Marshall takes off and goes up on the surface of the heart. If you have a persistent left SVC, this would be the vein that will go all the way up from between and connect and become a right-sided, a left-sided SVC. So the vein of Marshall would be your left-sided SVC if it didn't atrophy as the heart forms. I'm going to hand over the heart here so we can go over the outside aspects of the heart as when you go in, how you start thinking about maze, how to start planning your procedure.
Sure. So, so what's going to happen is, because we are going to open the right atrium to talk about this intracardiac anatomy of the right atrium, there are two lesions that I would like to show you that we do. So the complete set of lesions that we do for biatrial maze includes certain lesions on the left atrium and the right atrium. So I'm just going to show you two lesions that we do on the right atrium here. So one, here. So there is one lesion which connects the SVC to the IVC. My hand is, I think, this way. Yeah, okay. So from the SVC to the IVC is the first lesion that we do in the right atrium. Yeah. And this is the right atrial appendage. So there is one more lesion that goes from the right atrium connecting to this line right across the lateral wall up to the line connecting the two vena cavae. And the rest of the lesions happen once we open the right atrium. And another lesion that is done from outside is the one on the coronary sinus, and we do it somewhere between the right and left extension. So somewhere in the middle of the coronary sinus, we ablate this area using a cryoprobe. So those lesions we'll show on the left side. Yeah. Okay. So these are the external surface. Of course, surgically we create incisions here. These two are actually surgical incisions. The one which connects the SVC to the IVC, and I mean, we don't go all the way to the, or rather, SVC to the IVC is a surgical incision, plus the right atrial appendage to the SVC IVC lesion is a surgical incision as well. But can be done with a bipolar bipolar coagulation as well. So we do it. Yeah. So for us, the view is something like this, because we are looking at the heart like this. So I literally lift the heart here. And from the top, we are looking at the coronary sinus here. This area is the crux area, this area. So just left of the crux is where we ablate the, we put our cryoprobe on the coronary sinus. Somewhere here. Yeah, epicardially. Yes. So I'll hand it over to you again.
That's, I think that's the open the RA. It's time to do open the RA. So here we're going to try to cut from.
Easy with the scissor or something.
Do you have scissors by any chance?
Scissors?
I think it's nicer with scissors. Don't want to have accidents live.
The flow of blood, right? So you're gonna cut between SVC to IVC.
IVC, yeah.
Okay. Go ahead.
So you want me to cut across, right? Yes. Yeah, we can. You can take it up.
Okay.
This one full of clot.
Okay. We're declotting the RA a little bit here.
Do we have some gauze or something? Yeah, thanks.
Okay. So this is gonna need a little bit of light here because there's a lot here. So this is how organized clot looks like. It sticks to things. Okay. Oh,
There's more.
right there. Okay. Well, we can start looking here at the interatrial septum. I'm not sure.
We can't see. Can
I think we're gonna
someone
need-
focus
yeah.
it properly?
We're gonna need lights too. I think this is time to look at the light.
Can you illuminate that area, please? Throw light into the, yeah.
Oh, too much. Okay, let's see here. Let's turn the heart the other way. Show. Okay. So as you can see here, you're looking down. I'm not sure if you can, the video pause.
This is better.
This is better. Okay. So I was
We'll
gonna
start with this coronary sinus.
Yes. So this, as you can see here, is, let's just cut this off. So, so we open the back of the heart. You're looking, remember, you're looking at this from the RA standpoint. Okay. Okay. Good. So this, as you can see, is the opening of the coronary sinus right there. See that? Okay. You can see it? So this would be the
Andre,
opening of your...
can you just briefly tell the audience when you have to ablate within the coronary sinus for AFib or deep in the coronary sinus? What are the steps?
Sorry, I did not hear.
Sorry, could you please repeat your question?
When you have to ablate deep in the coronary sinus, sometimes you find AFib triggers in the coronary sinus.
What are the steps to be taken here?
Atrial fibrillation triggers in the coronary sinus.
He's saying, he's asking, what do you do when you do the ablation of the coronary sinus? What structures are you taking care of?
So we place our cryoprobe on the coronary sinus, and at this point in time, when we are doing this ablation, the heart is arrested and the coronary sinus is empty. So what it does is, when we place this coronary cryoprobe right on the coronary sinus, it pretty much ablates both the walls of the coronary sinus and the fibers going around the coronary sinus, and without getting anywhere closer to the circumflex which runs in the AV groove here. We don't go inside the coronary sinus, but we are ablating from outside itself.
How do you do the catheter ablation in a beating heart, Andre?
Catheter ablation of?
Inside.
Inside the CS.
Yes. So,
What will be the direction of the catheter?
yeah, so obviously the similar to engaging the catheter, from the IVC. So you're going here from the IVC, you curve your catheter, and then from the IVC
Your IVC
here,
is here.
yeah, IVC, there you go. That's the remnant of the IVC right there. And then this is why we just lock your catheter back into the coronary sinus right there. And this is basically there you go. There's an ablation catheter.
Yeah.
There we go.
No, my question is mitral isthmus lesions and others we ablate from the coronary sinus, right? What are the steps?
Deep inside the coronary sinus.
So it's anyway, I don't know whether it's important to make sure you take a shoot and you're staying away from circumflex.
Treat a mitral isthmus line. Now I got it. Okay.
Yeah.
So actually we can look at it here from the outside of the heart. The mitral isthmus, we will answer that when we open the left atrium a little bit more, I think. But the mitral isthmus line is basically a line between your left inferior vein and your AV groove. So what you need to do, you can see here the big coronary sinus crossing over that structure. You can ablate, when you ablate from the inside, you can imagine how thick of a structure it is, because the coronary sinus here is connecting this side of the pulmonic vein to this side of that pulmonic vein. So what we do to complete it, and we can open that coronary sinus actually in a little bit, is we ablate here so this is the pulmonic vein. And what we could do is open that structure a little bit.
So basically, the catheter has to be facing the atrial wall. It shouldn't be
Yes.
deflected this way. It has to be facing the atrial wall to do the disconnection.
Yeah,
And
it
you
should
need
be
to take a
hugging-
shoot to make sure
Yeah,
you're staying
there
away
you go.
from circulation.
So now what we did is we opened the coronary sinus, the great cardiac, coronary sinus before it becomes the cardiac vein, right there. And this would be the tissue right there. So this is atrial tissue here. So what you want to ablate is, let's tilt it down a little bit.
Yeah, yeah.
Here, okay. So this would be the area, this is the coronary sinus here, and this would be the area that you're ablating facing the left inferior pulmonic vein. Basically, this is the atrial tissue. So this is all live atrial tissue with connections that you need to ablate to complete your mitral isthmus line. And as we said, this area here goes up in between the appendage and the left pulmonic veins to give us the vein of Marshall. This is why sometimes the vein of Marshall will offer you a bridge of connection between the upper part of the atrium and the CS, so it can bridge the line that you're trying to ablate. And this is why sometimes you'd have to ablate the vein of Marshall to also cut this connection and make that line complete. But most of the time, you'll be able to complete the mitral valve, mitral isthmus from this area. We have to put the catheter, and you have, as you can imagine, you have to point not towards the free wall of the CS. You have to point it down towards the AV groove to be able to ablate this. You'll see that actually in heart transplant patients, because those heart transplant patients are, the entire posterior cuff is connected to the left atrium, and you'll end up with a small sleeve of muscle between that square of the anastomosis for the heart transplant and the mitral annulus. So it's also important. You'll find quite a bit of mitral flutters if the atrium is fried, and you have to ablate actually that area from both inside and outside to break these flutters too. I hope that answered your question, Dr. Nariman?
Yes, go ahead.
Okay, perfect. Okay, so let's go back to the RA.
So most of the problems happens when your catheter tip is facing the free wall of the coronary sinus. It should never happen. It should bend and the vector should be hugging the left atrium. Then you're fine.
Great amount of blood here. Just take it off. Okay. So I'm trying to here uncover the crista, and this is actually.
We have 20 minutes left to complete because the other
Yeah,
one is a
so-
transmitted talk.
Yeah. So the crista terminalis, if we opened a little bit of, the crista terminalis is hard to see, but this, yeah. So this is it's hard to see here with the clock. So this is the edge, like you see this edge between the SVC, that little thickening here is your crista terminalis, where the AV node sits. The upper part of the crista terminalis will give you your higher heart rates when you're in tachycardia. The lower part of the crista terminalis will be your there it is, this thickening here. Will be your lower heart rates. Okay. So this is, go back to the coronary sinus. We have the Todaro. So this you'll see in here, to rotate down. And as you can see, your tendon of Todaro extending over to the tricuspid valve. This is the front of your coronary sinus, tendon of Todaro, tricuspid valve. This is to your triangle of Koch, where if actually you can put you see this, you can put this into the aorta, and it will be bulging where the top of the tendon of Todaro, where, see here, where your his bundle is on a cross. I'm gonna, again, you see that? You see the, I'm not sure if you can see the bulging of it right there.
Right.
Okay. There's some delay. Okay. So let's open this up. Take the atrium out. See if we can see.
Can you ask Dr. Vidyadhar to have a thing about Waterston groove before you resect? I think now the thing is distorted.
Yeah. Mohammed.
Can put the flap
Unfortunately,
back and show the Waterston groove.
Yeah.
Okay.
Okay, just give me a minute because it's a little difficult here in the specimen to but the Waterston groove, so if you, this is the here. So this is the left, can you focus please?
Yes,
So this is the left atrium here.
right.
This is the right atrium, right? So between the two is the Waterston's groove, which is usually covered by a lot of fat, and we dissect into it to define it well. Somewhere here between these two structures. This is the LA.
So you see how closely the anterior portion of the anterior portion of the RSPV to the posterior wall of the right atrium.
Yes.
Lot of problems happen if you don't recognize that you are recording a far field potential in the RSPV. You go on ablating without realizing it's already isolated. So this anatomic proximity is the reason for that.
Yeah. Sure. So should we proceed with that? Yeah, go on.
Okay. Let's continue here. So let's try to open the.
We have 10 minutes left, so you can.
Yeah, it's been. What we're gonna do is we're gonna open.
Yeah. Let's just.
Everything is plotted out.
Yeah.
Okay, so we're gonna open here the RVOT. Okay. Okay. As you can see here, so this is the RVOT. This is I'm not sure, this is two things. This could be a pseudotendon. Here, this is one we describe pseudotendons. This is too thin to be the moderator band on its own. Where's the picture? Can you? Yes, there we go.
Yeah.
Yeah, unfortunately, it's just
Oh, we lost
tons of clot. So this could be a poor day because we can't see from a lot of clot here. Yeah. Okay. So usually
I'm sorry.
so this is the pulmonic valves, the three of them, 1, 2, and 3. This is the left, right, and anterior. I think the anterior is 3 here on the
Yeah.
on the free wall here, and right and left. So these are the sinuses. This is the RVOT. You can see the difference here between the two. This usually here, this thickening, I can feel it more. You see that ridge is where the right bundle traverses into the RV. It's called the muscle of Lancisi. It's a thickening in the muscles here, and then you got the right bundle usually carries the right bundle down. And usually here, I'm not sure we have the moderator band here at the apex. Oh, that might be, no, that's not it. Because we have a lot of clot here, it's gonna be hard to see the moderator band. I'm not sure if we have it with this is a small heart too.
Should be the conal papillary muscle, that will be the marker for us in the diaphragmatic surface.
Yeah, but it's usually here somewhere, but it's just so much clot in this.
Yeah. It should be
So this
coming
is the
this way,
fat
something
muscles.
like this.
Yeah, it goes between here and then goes straight
way.
to down, yeah, and it carries part of the right bundle. But here we're I don't think there is a good moderator band on this one. Yeah. Oh, wait a minute. Is that it? This little one?
Should be coming from
Yeah,
here
it should
to
be
the
coming from
papillary.
high up. Yeah, I don't think this
Yeah.
this heart has a good moderator band. And this, what I told you guys, this might be a pseudotendon. It's actually just the chordae, part of the chordae
This may be
system.
an gland. I don't know if big hearts have a moderator band.
Yeah, they don't have good ones. If anything is smaller.
It's not there in this as well, yeah.
Yeah.
Yeah,
Okay.
but roughly the position will be somewhere here, like this.
Yeah, and we can see here the muscle of Lancisi.
Yeah.
The septal leaflet, when we put, we say we put his bundle leads, and we were discussing yesterday. What happens is, this is another implication here, is if you going across, you see this leaflet here, it's a lot of clot, you can't see it. But let's say pretend this is the septal leaflet, which is more
Yeah, I
anterior.
can- yeah.
And there you go. If you're delivering the lead and you happen to pin this, because the hiss is there, you happen to pin this on the septum, so you can cause one of two things. You can go through the valve and pin it to the septum and cause TR. This is one mechanism for his bundle leads or left bundle leads to cause this. Or what you could do is you can just catch one of the chordae and do it and hinder the septal leaflet from going in. And this is when Dr. Vijayaraman yesterday was saying that it's important to, when you put, if you had put your lead here, there is tricuspid tissue between you and the wall, so you don't see injury when you push the lead before you screw it in. That's why it's important to, when you push the lead here, when you're right on muscle, you're gonna see an injury before you screw the lead in. And that would guarantee you that you're at least, the tip of your lead is on muscle and not pinning the septal valve into the wall.
I hope
Makes sense.
all of you got this. With the increasing CSP, you can literally pin the septal leaflet and cause lead-induced TR. If you want to avoid that, it's very important to make sure the lead records a good current of injury even before you start screwing in. This is what Dr. Vijayaraman described, and so that you're sure, you may still record all the pacing, everything through the leaflet, but we want to avoid that.
Yes.
Please go ahead.
Okay, so I think we're good with this side of the heart. Let's look at, just finish try to open the LV and look at the septum. The LA here is gonna be, should we open the back of the LA and then go over the maze briefly here?
Yeah. I think
Because we
it's
mentioned
gotta be
most of the things on the outside of the heart.
This LA is all chewed up, yeah. 1 second.
Is doing a surgical posterior box. I wish the clot was sitting in the LA.
Well,
Wouldn't that like that?
just gonna try and open this.
Yeah.
See, but it's just gonna be difficult to talk about maze in this one.
Yes.
Yeah, I think we'll skip the maze part because it's gonna be difficult to describe in this LA. It's too small. We can hardly see any structures, so I think we'll skip that.
Okay.
Yeah, we'll go, yeah. Yes, yes.
Yes. So here,
Meanwhile, we have just 5 minutes left. If there are any
Yeah.
important questions from the floor
I think, yeah. If,
to
as
the
anyone wants, I
faculty,
think,
please.
if anyone have anything specific we can show, I think that we'll use those last 5 minutes to show that.
Yeah, go ahead, Raghav.
We talked about Bachman bundle and something too.
So I wanted to ask about the intracardiac EGM correlate when we are ablating inside the coronary sinus. So if when we are along the free wall or when we are along the atrium, so what would be the intracardiac EGM correlate for that?
The question is, Andre, is what is the intracardiac EGM correlate targets for ablation within the coronary sinus? intracardiac electrograms within the
Sorry.
coronary sinus. What are the targets?
And
For mitral isthmus ablation from inside the coronary sinus,
okay, so finishing the isthmus from the coronary sinus, you're asking. What's the target
Let
electrogram?
me just take this. So the number one thing you should realize for left-sided isthmus, the V is phenomenally very large. It's 9:1 is the ratio when you're actually on the annulus. So you should clock and come out of that plane and get a bigger A. And in two projections, if you have a vector in your catheter, the vector should be facing the atrium and not poking the free wall. And it should be recording a very big A and a very minuscule V. Those are the targets for this.
and the
1:2:1 also. 1:1 itself means you are predominantly atrial on the left side.
Thank you, sir. The other thing I wanted to ask regarding the right ventricular anatomy is that when we are looking at it from inside the right ventricle, so there is a supraventricular crest, and then there is a septomarginal trabeculation. So how septomarginal trabeculation is different from muscle of Lancisi? Is it the same?
We didn't get the question. Can you hear, Andre?
I could not hear very well here. There's been a lot of echo. I think the
Say that again. I'm sorry.
yes, it's very similar. Yeah, it's the same. We just gave it a name. There's a parietal band. So there are two structures in that area. There's a parietal band, which is a band that crosses on the posterior aspect LVOT and anterior aspect of the RVOT, and crosses and gives you. That's why when you see PVCs coming from the parietal band, that's higher. That's crossing from medial to lateral in the RVOT. And that band gives you PVCs that will look too anterior or too posterior. So if a PVC in the middle of that parietal band, it would some of the PVCs will exit anteriorly through that to the RVOT free wall, and some of them will exit posteriorly through the RVOT septum. Hence, your V1 will change. Your rest of the limb leads will stay the same. The muscle of Lancisi is the same as the marginal band going through the septum. So it has the same name. We just gave it a private name, muscle of Lancisi, because he described
So
it.
you start recording a right bundle potential, and the potential to V will gradually start narrowing. That is the rough surrogate for the moderator band. And as you come to the parietal band, you counterclockwise rotate the catheter to go towards the free wall. That happens quite inferiorly and distally. One branch will go to the conal papillary muscle, and the other one will go move laterally. So if you don't have the facility for an intracardiac echo, these things become very important.
Thank you, sir.
Aortomitral continuity from the inside, please. Then we'll just have to close in the interest of time. The question is, can you just show the aortomitral continuity? Can you hear us? Muttaya, can you call them and ask them to show the aortomitral continuity? What is the problem? They're not able to hear us?
Yeah, we opened the LV on this one.
Yeah. So this is the LCC, this is the NCC, this is the
Can you make it full screen, please?
Oh, sorry.
Can you make it full screen?
Yeah, now
Okay, can you hear us, guys?
Yes.
I'll have to hold it for you, please.
We wanted to see the aortomitral continuity.
This was like this. Yeah, okay. Yeah, all right.
Well, just trying to put the thing in the RCA. That's RCA. RCC. Sorry.
Yeah.
Okay.
You can hear us? Yes.
You still can hear us?
There's some problem with the AV.
So,
They wanted to show, can you just bring in the aortomitral continuity from inside?
sorry. Where's the left lane?
You're audible.
Yeah.
Here, here.
Left is there.
Yeah. Okay. But yeah.
Yes, left. And no, left. Non. We didn't cut.
Yeah, we cut right anterior.
Yeah.
So this is your right.
Well, the right should be here. Yeah. Okay, sorry, we're trying to engage the RCA.
Yeah, that's the RCA.
Just in it.
Yeah.
Daljit, can you hear us?
This is left.
Yes.
Henry?
So, so basically, we're gonna try to show you here.
Okay.
So we went through the left coronary cusp, we cut the front of the LV. This is your right coronary cusp. This is the posterior structure here is the non-coronary cusp. And what we cut here is the left coronary cusp. And you can see the RCA coming off here under in the AV groove it's gonna cross under the right atrial appendage. This is the non facing the interatrial septum. And here we can open we cut through the LCC wide open, and this is the opening of the left main and LAD. Do you see it here? So we're going to the LAD, left main and LAD down.
Yeah,
this is the area of the summit. And this is the tissue that we ablate in the area. Do you see how thick it is? That's why you can't get to the summit sometimes, because this is the cusp and this is the tissue. See how much
Andre,
thickness
can
it
you
is?
hear us?
Now you got audible.
Now we can hear you.
Yeah,
So-
we wanted to see the iotomitral continuity. That is the request from here.
There to my continue.
AM continuity.
Yeah, here.
AM continuity, yeah. It's actually, it's
Yeah.
easier to see. Yeah,
If you hold this part, just hold one end, yeah.
go ahead.
So this is your anterior mitral leaflet. And this entire portion is this.
Rotate it.
No, that's fine. That's fine. I'll do it with my left hand. Yeah. So,
Yeah, okay.
so this is the anterior mitral leaflet, and this white area is the aortomitral continuity. Okay? Yeah.
Got it.
Correct.
Yeah.
Yeah.
Well, probably
Right.
we need more important
Yes.
is radiographic
So he's
anatomy
putting
for
his-
us. The
Is the tip on it?
That's
So
the-
it's mostly fibrous, but sometimes has muscle under it.
Correct.
Okay. Thank you so much. I'll just ask Raja to give concluding remarks, and then if there are any questions, in the interest of time, we need to close. Raja?
Sure.
I don't have any specific remarks, but generally I want to say that as we have seen with multiple cases, a good understanding of anatomy is very crucial to being able to ablate arrhythmia as well. And it's a very good exercise to do this kind of thing periodically, either with, we do it with cadaveric hearts along with anatomy. Otherwise you can do with animal hearts, with porcine or sheep hearts like this. And it's important to form a good intuitive understanding of anatomy, integrating information from dissection like this, radiographic anatomy, and from ultrasounds, echocardiograms, etc. Any specific questions? Any particular one or two questions we can take? I think otherwise we'll close the session. Yeah, Dr. Vivek.
Sometimes when we are doing VPCs and RVOT, the morphology changes, and he was mentioning something, and I missed that.
I'm glad you asked this. This is very common in outflow tract PVCs. When you seal the exit, for example, when you have, this is the reason why activation mapping is much better than pace mapping. So when you get a good pace map of an aortic cusp PVC, it will be in the RVOT, and you ablate that, the exit will change. But it tells you someone, I think Ulas pointed out yesterday, the morphology changing. That is a very good sign to tell you that you are going to go for this is a protected muscle bundle. Outflow tract, there are protected muscle bundles which connect between the outflow tract to the RVOT. So very often when we go by pace map, we ablate those areas and the exit will keep on changing. That we tend to think it's a different VT, it's not. So before starting the burn, try to do activation mapping. If it's in the posterior wall of the RVOT, always map the left cusp before starting the burn, because you may have a very discrete potential preceding the local activation.
What I meant was that couple of times times what has happened is that you start, the clinical ECG as a positive in lead 1. When you take the patient to the lab, the lead 1 is negative. So he was mentioning something like this, that it switches between the two sides. So
We can
I
ask, I'm not,
Yeah.
this is what I meant, I thought it's probably lead position. We can let Andre come down on the thing. Well, thank you, Dr. Vidyadhar and Dr. Andre, and we'll close the session and we will move on to the next session. May I request Dr. Raja to stay behind, and we'll have Dr. Ashish and Dr. Pugarendi Vijayaraman to chair the session because Amit Vora is not able to join. Sorry for pulling you in the last minute.
Thank you, Dr. Narasimhan. I guess the first talk on this session is going to be Dr. Selvaraj, setting up a 3D map for atrial arrhythmias.
So good morning, everyone. And so I'll start off quickly since we're a little behind on time. My talk is going to be very basic compared to most of the other sessions we've had. We've had some very excellent cases today, I think, which illustrate some of the points that I want to cover. But this talk is really aimed more at trainees and early career EPs, just to discuss some of the basics of what we do when you set up a map. And to start off, I just want to say initially that something is also about what role you think the EP should have in a 3D mapping procedure, because I think again sometimes what happens is if you're a little overwhelmed and dazzled with all the technology and the colors, and you tend to think sometimes that your role is only to stand at the table, move the catheter, and then just ablate where someone draws a line for you. That's not the correct attitude to develop as you train. You should take ownership and responsibility and participate in the whole mapping procedure, right from choosing a reference, choosing the window of interest, and annotating each point. So that's something important. And we've had and one way to know whether you're doing this is how much importance you give to colors and how much importance you give to signals. So again, I think we saw this in multiple cases yesterday where people had a 3D map, but they didn't show us the 3D map colors first. They showed us electrograms, they showed us entrainment information, and it's very important to pay a lot of attention to signals and entrainment and incorporate all that into your interpretation of the map. For example, we've been discussing about how right superior pulmonary vein and SVC are in close contact. Similarly, the septal part of the right atrium, you get activation map showing early activation. You can't immediately go just seeing the colors to start ablating here. You have to, one is understand the anatomy and know that this could also be from the left atrium. And you can see the timing of the colors. Based on the timing, you should assess whether this is well ahead of the P wave to justify that this is a right atrial onset. And even though the timing here was 30, 40 milliseconds ahead of the P wave, you look at the signal and you can see in the signal that there's actually a far field component, which is what is being annotated, whereas a near field component is late. And seeing this should tell you that when we go to the left atrium, you again see a double potential, but now the near field component is early and the far field component is late. So this kind of thing of always paying attention to the signals and other information is important. In terms of setting up in hardware, you have to decide what catheters to use. Although the role of multipolar catheters is less now with using mapping, they are still useful in a variety of situations. So there might be a role to still use duodecoupler, for example, in the right atrium when you're doing a right atrial flutter. It of course helps with checking block later. It also helps with an initial impression of what the tachycardia circuit is, and also helps sometimes with tachycardia changes in between during ablation, which sometimes happens. Using sheets is extremely useful in any of the complex ablations, also in relatively straightforward flutters when the atrium is dilated. It makes a big difference in saving a lot of time and giving you more accuracy and better contact when you're doing the ablation. Our workhorse is the Agilis sheath, but we also have newer sheaths like the Visigo, which have an incorporated electrode allowing you to see this on 3D maps. And of course, we've had a lot of discussion on multi-electrode mapping. This has become the default mapping electrodes in most labs. And we have the pentarray and very impressively the octarray, where you can map a chamber very quickly because it has a large coverage area and a lot of electrodes. But typically in our setting, these also add a significant cost to the procedure. So this is something that we need to think about. And also like it was mentioned by Dr. Dikshit yesterday, sometimes with the inherently increased number of electrodes, mapping points, and automatic mapping that come with these, you lose control over the procedure because previously every point you validate and take, and now you're not able to do that. That should also make you more skeptical and check what the system is telling you. So we generally, one of the major advantages with all this multi-electrode mapping and what the major change over the few years is that we produce very high density maps nowadays. We create much more detailed maps in much shorter times. But this is not all rosy as we tend to think. With this kind of thousands of points, it becomes difficult or impossible to verify or annotate or re-annotate points. So that is something to this. And also, sometimes people tend to think of these as equivalent, which I think they are not. So you say, we used to take 1 hour to create a 400-point map, whereas now in 10 minutes you can create 1,000-point maps. But the 1,000-point map is not necessarily better than a 400-point map. I tend to think of this in a ratio of about 5 to 10. I would say a 400-point map done as a point-to-point thing with individual verification would be equivalent about a 2,000 or 4,000-point map when it is done with a multipolar catheter. And even though we tend to equate high-density mapping with multi-electrode mapping, it's not always true. It's been a pleasant surprise with the automatic mapping algorithms now that both these maps are done with a single catheter, with just a mapping catheter. So like I said, we have at least I work in a setting with a lot of where we work with financial constraints. And with a single point catheter, we can create maps with 1,000 or 2,000 points in half an hour. And these are very accurate. You can see a nice figure of entry like this in a ventricle, or an atriotomy-related flutter in the right atrium. And the density of the maps looks almost like a multi-electrode mapping, but this is done with single electrode with just a mapping catheter. And if you're not able to use especially when you're not able to use a multi-electrode catheter and create very high-density maps, you can supplement your information with entrainment. So there are some people, of course, who shy away from entrainment and say you can alter the tachycardia, terminate the tachycardia, etc. But I think it provides a lot of information and things which you will need a very good high-density map to sort out. You can sort out very quickly with entrainment. Here you can see there is a line of double potentials, line of block here in the free wall of the right atrium. You see a wavefront which is ascending posterior to the line. And the question is whether the return path is coming anterior to the line or going all around the isthmus. By doing an entrainment anterior to the line and at the isthmus, you can see that the post-spacing interval is very long from the isthmus. It's short here. Tells you that the whole circuit is here around the atriotomy scar so that you can ablate either from the atriotomy line to the annulus or here, because there's color crowding here, you can do it from the lower end of the atriotomy to the IVC scar. So imaging, again, we've seen multiple cases how this is very useful. In the atria where there is abnormal anatomy, dilatation, doing a pre-procedure CT and merging it can be very helpful. ICE again is very useful, used as a default now in many cases in the West. Again, for us with cost constraints, I think we have to think of the relative advantages of using ICE. It can be very useful to define isthmus anatomy, can help with the transeptal access, and has various advantages, but again, we have to think of the cost issues. So to start off, in atrial arrhythmias, you have to decide on the chamber to map, and just once you place the CS, looking at the CS activation itself can give you a clue. And these, of course, when you see CS activation going from distal to proximal, you're very sure this is the left atrial. But again, for trainees, know that proximal to distal doesn't always mean it's right atrial. Although this is right atrial, this could also be a perimitral flutter, which is going in a counterclockwise direction. Whenever you see CS activation not following one of these, of course, it's a left atrial arrhythmia. And when you have a chevron pattern with the mid CS being early, you know that the wavefront on the posterior wall is a descending wavefront, whereas if it looks like this, it's an ascending wavefront on the posterior wall. So the CS activation can give you good clues. And of course, the other one slide should be missing here. Yeah, so I think one slide is missing here. But the next point, next way to identify the chamber where you want to map first is to look at the post-spacing intervals. So you could do, typically we do entrainment from 3 sides, right atrium, proximal CS and distal CS. And this very quickly tells you what is the area of interest and which chamber you want to start with mapping. Once you decide, you have to set the window of interest. And often in atrial arrhythmias, if there is either a 1:1 or 2:1 conduction and you cannot clearly see the P wave boundaries, like here it's 1:1 and you can't see the P waves because they're falling within the QRS. So before you start while you're setting up the map or before you start the procedure, you have to do something to try and identify the P waves well. Now this could be carotid sinus massage, you can give adenosine, or what is also easy is to do a quick ventricular burst. And with ventricular burst, you can get AV block for a couple of beats and you might be able to see the P waves well. Once you see the P waves, we look at the morphology in the 12 leads to see the morphology and try to assess whether this is focal or reentry. And also we try to decide what the relation of the P wave is in reference to the reference timing that we are choosing. And in terms of choosing a reference, CS of course is the most common fixed intracardiac electrogram that you have in the atrium. In the atrium, the disadvantage compared to the ventricle is you cannot easily choose a body surface reference, you have to choose an intracardiac electrogram. So spend some time in choosing an ideal electrode that you want to use. You don't want to use something which has big ventricular electrograms. You don't want to use something with fractionated atrial electrograms where on a beat by beat basis it might annotate different parts of the electrogram. You want to choose something which is sharp and is annotated on this. Once you choose an electrogram, let it run for a few beats and make sure that the annotation is falling in the same place on every beat. And sometimes where we are not able to place a CS, it's what we have done is place an active fixation pacing electrode and connect that to the system, and that can provide a relatively stable timing reference. Another option is to use an esophageal catheter also to record signals from the esophagus, and you can use that as a timing reference in such cases. Once you have chosen a reference and we are able to see the P wave like this, we have to identify and take some measurements. And usually what you see is what is the P wave onset in relation to your reference, where is the P wave end in relation to the reference, and you have to know the cycle length. Once you have this basic information, you can decide how you want to set the window of interest. So for a focal arrhythmia, of course, you don't need to cover the whole cycle length with your window, but you should ensure that your window starts a sufficient interval before the P wave onset. Now, the sufficient interval would be at least 50 milliseconds, probably about 100 milliseconds is better. And for re-entry, we cover the whole cycle length, of course. In the atrium, sometimes it can be very tricky to identify whether something is focal or re-entry, and sometimes it's preferable to map everything as if it is re-entry, because even though it's a structurally normal heart and you see a good isoelectric interval, we've been surprised sometimes with idiopathic scarring, and it turns out to be re-entry. So it's better to map everything as re-entry. Now, when it comes to re-entry, you could put your windows to go from P wave onset to onset, go from P wave end to end, or to go from mid-diastole to mid-diastole. And one of the key things I want people to understand is that the window itself doesn't really matter. It's not that one is the correct answer. How you see the colors just depends on where your reference is within the window. If your reference is late, the window is going to look one way. If you change your window a little differently, so reference is red, then the window goes the other way. But finally, these two are the same maps, and it should not make a difference in how you interpret this. So again, this is the same flutter shown above with a different window and shown below with a different window. So the window of interest doesn't matter. The way you set the window doesn't matter. What we're looking here is that in the posteriorly, there's a descending wavefront, anteriorly, there's an ascending wavefront, and then you see through what isthmus it goes through. But of course, most people prefer to use the DePonte method. And I think the key takeaway from this paper, here the idea is that you set the window onset between the end of the P wave and the beginning of the next P wave. Now, the key takeaway from this paper was that because otherwise people used to take whatever is the reference, you split your window equally around the reference. But instead of doing that, which is very arbitrary, what I think they suggested is that you have a window which is based on the P wave itself, not simply based on where your reference is. That way you develop, when you see colors, whether you're in the slow part or whether you're in your rapid activating part of the atrium. Here, like anything which is in the, like you have red or purple, it's in the mid part of the diastole, and other areas it is. But I think the disadvantages in following this paper is, one is thinking that this is the only correct way to do it, and there are certain other disadvantages with using this. One, for example, is that sometimes you might have flutters which don't have a very clear, relatively isoelectric part. The whole thing is a wavy baseline. You cannot easily use this method. Or you can have a P wave which is very long, and the different interval between the end and the onset of the next P wave could be very short. So if you put your window start at this beginning, what can happen sometimes is a focal tachycardia can look like a macro reentry. So we had this case long back where if your window is set incorrectly, you don't go adequately before the QRS onset here in a VT, early points can get misannotated as late. And then if you just look at the thing, you see that you have early meets late, and then you have the color bar goes all the way from the covers the full cycle length, and you can get misdiagnosed this as re-entry, whereas if you re-annotate this by pulling the window adequately before, you can see that it's actually a focal tachycardia. A lot of the cycle length doesn't have any activation points. So this is an alternative window which was suggested in this paper where they marked as conventional window the DePonte method, and an alternative window which goes from the end of the P wave to the end of the preceding P wave. So here the window starts with the onset of the slow conduction. So one advantage is also that way, that you will, if you have an arrhythmia which could be focal or re-entry, there's no issues because the whole of diastole comes on one side of the window. You're not splitting diastole into early and late. So the other issue is about window length. Once you've set the window onset, you want to know how long you set. Most people use 90%, but I've seen sometimes people suggesting 80%. I use 100%, and this was after hearing Dr. Nakagawa once who was suggesting this. And if you think why people don't want to use 100%, it's because one is that there is small variations in the cycle length that can happen on a beat-to-beat basis. But again, in a reentrant tachycardia, the variability tends to be very small. Actually, a variability of more than 15% itself is one sign that your tachycardia is focal and not re-entry. So reentrant tachycardias tend to have a fairly fixed cycle length. But if you have when you have small variations and you have a window occupying the whole of cycle length, what can happen is you can have an electrogram appear both as early and late, and then the worry is that you don't know whether to tag this as early or as late. But this looks like a concern when you think of a color map as a linear map. But you have to remember that in re-entry, the color map is a circle. So you're not going to worry whether a point is yellow or green. So the same way you don't need to worry whether a point is red or purple, because they're just adjacent to each other. They're not far away from each other. When you take a 90% or 80% window, what happens is some points are going to fall outside the window. So these are essentially orphan points without an annotation time. When you manually annotate, when you see these, you can put your timing here, and depending on whether you put it on before the window or after the window, these will be annotated as red or purple. In an automated system, these can also be totally ignored and left out. And that is another issue with the DePonte method, because here the place where you're going to lose electrograms is in the critical part of the isthmus, which is where you don't want to lose any electrograms. You want to see the timing of every point. Whereas if you go with the alternative method, you'll be losing some points in the beginning of the diastole, which is of less concern. So in terms of setup, the other thing, so many of these issues can be avoided with using the histogram, which is a very useful tool available now. So you always keep a histogram on, and the histogram tells you whether you've collected points throughout the window and where you have more points in this. And when you have fairly equally sampled points in a map, when you have valleys in the histogram, that's a surrogate for isochronal crowding and tells you that that's an area of slow conduction. So seeing these valleys visually tells you that's an area of slow conduction. That's going to be a critical area to ablate. So had a few, I think I'll stop at that because the other ripple maps and coherent mapping will probably be covered otherwise. So just to summarize as I finish, so don't think of 3D maps as something that is done automatically for you and your only role is to go and ablate. I think it's important to critically understand and evaluate the map, integrating all the information that you have. And there was a series of articles by Dr. Samuel Asirvadam in Circulation Arrhythmia in 2010-11. I would advise trainees to read this because there are very, very few articles on basics of 3D mapping. So that's a good series of articles to read. And those cover the basics, but this is again an area which is constantly evolving. A lot of newer tools are there, and you have to be also familiar with all these newer tools that have evolved. Thank you very much.
That was a well done lecture, Raja. I mean, I think I would agree with you on most of the points. There are a lot of new tools that we use, the multi-electrode maps, especially the Octaray, and that adds, while it's a little bit efficient in collecting points, but it adds complexity to understanding it. The problem is a lot of it is automated, and if there are mistakes in it, it takes a little extra time to unwind everything. So paying attention to all of the initial process and the basics of 3D mapping is critical. And I still agree that entrainment is a critical part to understand complex atrial arrhythmias. We see that quite often post-AF ablation. And the third thing, one pointer is that many atrial arrhythmias tend to change. Can be a roof-dependent flutter, and you put all your eggs in that, and then during the ablation itself, it may change to another flutter. And so constantly reevaluating a strategy, in-training will give you a quick answer to what you need to do. Thank you.
Thank you.
Yeah, so let's move on to the next speaker, Dr. Avinash Verma, who will discuss the high density mapping in the atrium.
Yeah, I gave, it was not working there, so. Yeah, it works? Okay. Good morning, everyone. I would like to thank Dr. Narasimha Sir to provide me this opportunity to present this talk. So the topic is utility of high-density mapping in atrial flutter. Dr. Raja just elucidated the importance of doing or the gathering of high-density points. So what are the advances in 3D mapping? The conventional 3D mapping that we were doing was substrate-based map and activation-based map. Initially, it started with just one electrode map or a single electrode map, which was the ablation electrode, and that was also used for mapping point acquisition. Now, this was different back then in 1999 when it started, because it was just the ablation catheter that was also used for mapping. There were no dedicated mapping catheters. Now, as the complexity of arrhythmia that we addressed with 3D mapping grew, then came the importance of collecting more and more points. The initial maps which were created were with less than 100 points, so 70 points, 80 points, 100 points, and they elucidated the flow of current more so by the propagation map. It was too less to elucidate the critical isthmus area and many more structurally important or relevant substrate-based information, which was not possible because these were not dedicated mapping catheters. They were just the ablation catheter single point. The impedance-based EnSite was the first to launch this multi-electrode mapping capability where any electrode of a decapolar catheter could be used for gathering electrogram. Again, it is a multi-electrode mapping, but it was not dedicated mapping catheter and it was not a high density. In 2014, the major breakthrough happened when the automatic acquisition module was brought. So if you want to collect 2,000 points or more, then you cannot do it manually, point by point. It's too labor intensive. I mean, you can do it, but you'll be probably spending 2 hours just annotating all those points. So continuous automatic annotation and point acquisition is a must. Even more important than multi-electrode, as Sir said before, that you can do continuous automatic acquisition and a high density map using a single electrode, but it will be a high density map and not high resolution map. When you want a high density and high resolution map, you have to go for dedicated mapping catheters like the ones that Dr. Raja showed. So these are dedicated multi-electrode mapping catheters. What's unique about them is you see the inter-electrode mapping distance of 2 millimeter or 1 millimeter. You see the electrode size, which is just 0.46 mm. Again, sampling frequency cannot be equated with the spatial resolution. If the spatial resolution you want very crisp information in, let's say, a re-entry area or a scar area which is just 1 centimeter wide, you cannot use a 10 mm spacing catheter or a, a circular mapping or a decapolar catheter to get the information. No matter if you take 100 points there in that 1 centimeter square area, it will still be not high resolution. It will be high density, but not high resolution. So that is why whenever we talk about high resolution mapping of these critical isthmuses, we used Pentarray, which is particularly 262 and not 555. So 262 will give a better sampling resolution in between these electrodes than a 555 Pentarray catheter. Similarly, the Advisor HD grid catheter is very good because of the same reasons, that it gives you a very good sampling resolution also along with sampling frequency. So dedicated multi-electrode mapping became possible with automatic continued acquisition and annotation modules. Now these annotation modules are also equally important. What to annotate, because now you're leaving all your annotation which you were supposed to do to the computer. You cannot do it by yourself. So there were many parameters used. dV by dt was used, wavelet was used, far field, near field was used. All these parameters can be used and mostly can be relied upon. Still, you will have problems in those areas where the signal. So there will be some areas of continuous signal where the signal will be around 100 to 200 millisecond wide. Now in that area, if you try to just rely on the local electrogram, it's not possible to rely on that. And there comes the importance of relying on, or importance of a ripple map or a speckle map, which is a non-annotation based depiction of the electrogram voltages. So that is the solution for that kind of problem, because even manually, you will not be able to annotate all those points. Let's say an electrogram signal is 133 milliseconds. Where are you going to annotate? It's easier to say that the sharpest point could be annotated, but I'll show you electrograms which are sharp all throughout the way, 130 milliseconds. It's very difficult to annotate even manually. There we rely on other mapping techniques. So confidence mapping module is the mapping module of the CARTO, which is the automatic mapping or continuous mapping acquisition module, and AutoMap is the Insight version of the same. And it works by this. You set up all the filters which you want. So the filters will be cycle length based filter, stability based filter, density based filter, internal point rejection, which is tissue proximity indication filter, scar based filter, and all these filters will be applied to each point, each of those 2000 points which you want to collect. And then those points will be collected. Now this point will be collected and then comes the annotation. So if it doesn't qualify all these filters, it will be rejected. The annotation doesn't come. And then comes the annotation. So all these filters are there. Cycle length filter is important. Lat stability filter. Like this is one of the tools which we have to get rid of the outliers. So many times your map will be fine and there'll be some noise somewhere and it will be annotated by the system as something else. So it will be an island of, let's say, red color, and there'll be 4 or 5 specks of green color there, and it will look very odd that what is that. So lat activate, if you have your lat stability put on and you make it 3 mm or less, then it gives you a very good activation timing coherence in that area. So you won't be having a lot of signal outliers in that. So these are the ways by which you can automatically increase the quality of your acquisition. electrode position stability, tissue proximity indicator is also important. So if you want to use the tissue proximity indicator and remove the internal point rejection, you have to spend some time in creating the base impedance map, which is not fast. So it will take some time to create the base impedance map, maybe 5 minutes. And once the 5 minutes are over and you have created a base impedance map inside, then you can go for tissue proximity indicator based mapping, and it will remove all the internal points and rejection. False filter is important if you are doing a single point map, particularly important if you are doing a point by point map, but again it will be difficult to do a high density mapping with that. Point density and respiratory gating are further filters that can be applied. So there are a lot of clinical evidence also based on these things. Now, none of these studies are big studies, or in most cases not randomized studies, and retrospective observation studies and some prospective observation studies. So, and most of these studies of high density mapping are targeting the atrial channels or the atrial arrhythmias. So in this paper, they showed the acute success rate in around 100 patients with 97% success rate of acute termination with only 20% use of entrainment mapping. Like sir was saying, particularly Dr. Hiroshi's lab, they also use a lot of algorithms and rely less on the entrainment mapping, and it has its own pitfalls. So entrainment is good for finding out which chamber to map, but not very good in getting deep inside and finding out where is the critical isthmus. You can do that, but there are risks that you might terminate or convert that arrhythmia into something other. So there is 65% 1 year AT-free survival that was noted in this study. So high density mapping for ablation of atypical flutter procedural characteristic related to the outcome. It shows the importance of high resolution mapping, not just the high density mapping. If you get the critical isthmus point elucidated well by doing a high resolution map, then the freedom from AT-free survival is quite good, up to 75% AT-free survival and very less recurrence. On the other hand, if the critical isthmus is not being elucidated, or you are unable to find the flutters, or there are some unmappable flutters, there will be some arrhythmias which you will not be able to map. Either these arrhythmias are evanescent, they go away while you are mapping, or if you see your lat histogram, you find that there is always a certain portion of cycle length missing. Now, it might be limitation of the mapping technology, or it might be limitation of your reach. But there are, if your lat histogram shows lot of valleys with absolutely no points, then that is not a mapped flutter. You might have taken some points or maybe 2000 points, but that is not a mapped circuit. So if you have such kind of circuits, then also it shows more recurrence. And there have been some studies with, all less than 50, 60 patients. And you see that the acute procedural success rate, if you do high density mapping, is close to 80%, 80%, 90%, in some studies 100%. And complication rate is also fairly good. And the recurrence rate is close to 20 to 30%, which is as good as we can achieve with the present technology. So it's quite good. And like I was saying that not all SD is same. Sampling frequency is not equal to spatial resolution. So now this paper also elucidates the same thing. So you can see the HD grid and precision versus a circular mapping catheter, which is just a lasso catheter with not the inter-electrode spacing distance equivalent to HD grid. So if you use that, and particularly if you use a velocity system, your frequency, the acute success overall, it falls from 78 to 50%. If you see the recurrence in 1 year, it goes high up to 62% as compared to 25%. So high resolution mapping along with high density mapping is better if you are dealing with the atrial arrhythmias. Now these are some examples of the cases that we have done. Now this is with the legacy CARTO XP system, a typical counterclockwise flutter, and the total number of points were 82 points. Now this cannot give you, this can tell you that there is a counterclockwise wavefront that is going on, but it cannot tell you anything more than that. This is the current high density mapping with a dedicated mapping catheter, around 2,500 points, and it's a much better thing. It's a much better map. Now, just elucidating where we can use all these things, some cases. So this is an interesting case. A posterior septal pathway ablated, and he presented with this arrhythmia after 2 months. And it's a young person around 32 years of age, and he presented with a flutter post-ablation of posterior septal pathway. So it looks like typical counterclockwise flutter, and when we put the halo, it looks exactly like typical counterclockwise flutter. Atrial tachycardia 2:1, the QRS TCL is around 370 millisecond, and the entire TCL, the halo, covers around 70% of the tachycardia cycle length. So everything looks like a typical counterclockwise flutter. Now, when we map it and we see this with a high density map, you'll see that there's a wavefront collision here. In the lower part or the inferior part of the right atrium, you can see that near the CTI area, the wavefront is actually going from the CS towards the lateral wall rather than the typical counterclockwise. So there's a wavefront collision happening here. So it's not a typical counterclockwise flutter, even though your multi-electrode or a halo catheter might make you believe so, or the ECG might make you believe so. But it looked like that because practically 90% of the wavelength was going through that. So it looked like a typical counterclockwise flutter, but it was a localized micro reentry near the scar of the previous ablation site of the ablation for the posterior septal pathway. So there was the ablation, and you can see that there was a localized reentry, and just that green point, single point ablation terminated the tachycardia. Of course, after doing that ablation, we created the CTI line just to be sure that it doesn't lead to more. But it was just a single point ablation that terminated the tachycardia from that point. So again, if you come to more complex arrhythmias, like 11-year-old boy DORV VSDPS with dextrocardia post-operative, presenting with incessant atrial tachycardia of 260 millisecond. Here comes the importance. Now, it's a dextrocardia with DORV VSDPS. All the anatomy is distorted, and you don't know where the surgeon has created the scar. So over here, you have to rely on the multi-electrode map. So this is a 10,000 point map, high density, I would say extreme high density map of the right atrium in a small boy. And you can see that we are covering the entire cycle length in the lat histogram. And over here, you can see in the coherent map, the velocity vectors, that how the wavefront is converging with the, so this is the scar area. So all this pink area is the healthy area, and this is the wavefront converging here in the scar area, and this is the place where the surgeons cut the atrium. And it is exiting from there, and this is the critical area of slowing where the tachycardia was terminated. And there was a large scar in the posterior morphological LA also, and in the atrial septal side, but that was all passively activated, and there was no re-entry happening at that point. So majority of the RA activation was multi-front, and the only place where we can find this isochronal crowding was near the inferior and lateral RA, where the circuit was the critical part. So ablation in this area led to termination of the tachycardia. Now this would not have been possible by just not doing or taking few points. So you can see that it was multi-wavefront conduction in rest of the RA, and only at one point we were seeing that slow signals. And you can see that these continuous potentials in the critical area. And if you're getting this kind of potential, it virtually tells you that this is the site where it is going to be terminated. And in this also, you can see that these two are the lines of conduction block, and it goes here and comes out from this side. So this is another case. A 65-year-old male complained of recurrent palpitation and atrial tachycardia on EPS. Now this is a biatrial map. So we thought that this patient was having a LA tachycardia because V1 was positive. But we went inside the LA and mapped the entire LA, and there was nothing in the LA. And you can see it's a 13,000 point map, and the whole RA is scarred. So it is a primary right atrial cardiomyopathy that we are dealing. A high density map of the right atrium was able to tell you the scar burden, and the extension of the scar in the whole of the right-sided lateral wall. And when we run the coherent map on the right side, we can see that how the slowing of the current is there on the lateral wall, and here is the critical part of the circuit. So once we ablate in this area, the tachycardia terminated. So again, this is not entrainment-based mapping. This is mostly relying on the isochronal crowding and the slowing of the conduction as shown by the coherent maps, and using a high-density map. Now these are very high-density map, close to more than 10,000 points in each map. And these are the areas where you can see practically all the colors and all the isochrones are there. Again, it's a clockwise flutter. It looks like a clockwise flutter. But over here, and it's a primary atrial cardiomyopathy, right atrial cardiomyopathy. You can see that this scar is extending virtually across all of the right side of the right atrium. And you can see how the current is getting channeled through this channel, and this was the zone of the channel through which the re-entry was sustaining. And as soon as we ablated in that area, this tachycardia terminated, and not through the CTI. Of course, we did the CTI ablation later on. So this is another case where we see that after AF ablation, when we re-induced the patient, we induced another tachycardia, which was not in the left atrium. So we mapped the entire left atrium. So this is again 6,000 point. So one of the benefit of using multi-electrode mapping and continuous acquisition is that even after you have done all the procedure, you have done CTI, box isolation, and during the checking phase, if the patient lands up with another arrhythmia, you don't have to sweat too much to map the entire arrhythmia again. It just takes 10 to 15 minutes to map both the atrium with multi-electrode mapping and continuous acquisition. So this was again 6,000 point of biatrial map, which was made after the ablation, and it was found out that it was lower loop re-entry across the tricuspid valve. And if you see that in the tricuspid valve, this conduction is neither, so it is not a counterclockwise or clockwise conduction. On the other hand, if you see the IVC, you will see that it's a peri-IVC re-entry happening here, and the entire LA is being depolarized passively. And a CTI line terminated this tachycardia. Now this is again post. So this patient is post AF ablation, and AF ablation was not done by PVI. So this AF ablation was done in out of India center, and it was all cafe-based ablation. And this is what happens in a cafe-based ablation. None of the pulmonary veins were isolated. And if you run this map, you'll see that how the posterior wall is the site of re-entry, and all the wavefront crowding, isochrone crowding, and the slowing of the electrograms are there in that area. So this patient needed a PVI and the posterior wall isolation. So this is PVI done, posterior wall isolation done, and now this is the area which is quietened. Now you can say that it's extensive ablation, but this was the area that has to be ablated in this case. Again, the clockwise, so this patient again landed up with, in the reinduction phase, landed up with a clockwise perimitral flutter. And importance of mapping with a multi-electrode catheter is that you can quickly map any flutters that come to your way. So we quickly mapped this clockwise perimitral flutter, and we made the anterior mitral line. So we at our center are now using more and more of anterior mitral line. We have tried using posterior mitral line, but what I find is that using just the lateral mitral isthmus line, it's very difficult to get the isolation done, or the linear ablation done. So anterior mitral line is quite easy to make and easy to prove that it is done.
Avinash, you want to conclude?
Yeah. So this final.
We are a little over time.
Yeah, sir. Just a minute. So I just want to show one multi-electrode map in a RHD patient, mild MS, mild MR, and this lady presented with arrhythmia of it's a LA tachycardia that she presented with, and utility of HD grade catheter in mapping these arrhythmias. You can see that it's a very small area of scarring in the anterior wall that was causing this flutter. And this was the area of the re-entry that was there, and you can see that first lesion terminated the tachycardia there. So key points, and of all those cases that I showed, nearly 9 cases, follow-up duration 6 months to 3 years, there was one recurrence of case number 5, and this recurrence occurred after 2 years and managed on cardioversion and beta blockers. That was the post-MVR case. So the key points are HD mapping is essential for understanding the substrate and the circuits of atrial arrhythmia. Newer mapping catheters such as Pentaray and HD grade have increased the resolution of mapping, not just the density of mapping. Automatic continuous mapping modules are essential for any high density acquisition. Probable tachycardia circuits can be explored with lat and substrate information superimposed on a global wavefront map. And velocity vectors provide a new dimension and maybe later they will even come up with the values of these velocities, and it will give us much more information about the critical areas of the tachycardia circuit. Thank you.
Thanks, Avinash. Beautiful presentation. Your presentation as coherent as your maps. Thank you.
Thank you,
Just one question before I let you go. Can you distinguish focal tachycardia from a micro-reentry tachycardia by using these high-density maps? And secondly, you do a high-density map and then you showed a zone of slow conduction. What is your site of ablation? The entraining and showing from the zone of slow conduction, or is it the narrowest channel that is most easily doable? What becomes your ablation site on most occasions?
So, sir, regarding the second question, regarding the first question about focal versus the re-entry, if we first quickly take the map, most of the times it will show you, I mean, I didn't show you that last case, so it was post-Bental surgery focal atrial tachycardia. It's completely different. If you see your lat histograms, you'll see big valleys there. It won't be, so large part of your tachycardia circuit will not be mapped, and your maps will show that. You can also do entrainment mapping and show that this is a focal tachycardia and this is not entrainable tachycardia. But we usually do the mapping first and then do all the entrainment maneuver. If you try to do the entrainment maneuver before the mapping, then sometimes the tachycardia becomes unmappable. So if most of the times what we have found is that if we do the mapping first, we get the information. And many times, again, there was a intraseptal re-entry after a post-AF ablation, the second last case. If you look at that map, both the atria, the right lateral atria and the left lateral atria are delayed, just the septum is early. But in the septum, there is a whole tachycardia circuit, just in the septum. So it might look like focal to you coming from the septum, but when you do the high density mapping, it turns out that it was intraseptal re-entry that was happening in that case. So yeah, the map tells you where it is. And regarding the entrainment question, first we make the map, and then for ablation, if suppose it is in certain, for example, like in the RHD case, if there's a focal scar and we see that there is a isochronal crowding there and we are seeing the slow conduction channels there and we are seeing good electrograms spanning 50% of the tachycardia cycle length there, then probably that is your site. You can try mapping from, you can try entrainment from there, but what we have seen that many times it doesn't capture from there. So it is always not possible to entrain from those sites which are your sites of interest. But yeah, you can try doing that. But what I find is more useful is that if we are in certain area, like it's a clockwise mitral flutter, and I want to see that if it's a clockwise mitral flutter, me ablating in the lateral mitral isthmus is going to get rid of this flutter or not, then I can entrain from there and see that how much entrainment is there from that side and how close or not that side is. So it gives me some information about exclusion also, the entrainment mapping, but that we only do after doing the entire mapping.
Thanks. Sure.
So can I ask a question? So
Okay.
Avinash, excellent presentation and fascinating cases. Yeah, can we go back to the first case? If I'm not wrong,
Deba, I think that might take a lot of
just
time.
one question. The first case, the coronary sinus activation was distal to proximal, if we are not wrong, which doesn't fit in with either of the counterclockwise flutter, nor with the final diagnosis of micro re-entry. Possibly in the ablation of the posteroseptal accessory pathway, you have made a barrier where the coronary sinus entry was also, you have made a line so that the activation pattern was distal to proximal coronary sinus, if I'm not wrong, in the first case.
In the first case?
Yes. So
I don't think so. It was proximal to distal. We can see that, right?
Okay.
Sure. I think we.
I mean, we can discuss that.
Yeah, sure.
Sort
Thank
this
you.
out later. Yeah, sure.
Okay.
Yeah. Okay, I think we have two important talks to follow, and are they online? I think so. So, Dr. Minglong Chen, always a speaker to hear and learn from. He's going to speak on ablation of atrial arrhythmias in structural heart disease. So, good follow-up to the two talks that we had. Can we have Dr. Chen? Is this a recorded?
Good morning, dear EP colleagues. I'm privileged to be invited by Professor Narasimhan to have this talk in the in this symposium. I'm sorry that I cannot come because of other missions. And I think my given topic is the atrial tachycardia's ablation in patients with structural heart disease. But I think in China and India, we have a lot of patients with rheumatic heart disease. So I think the post-surgical atrial tachycardia mapping and ablation is very challenging in such cases. Therefore, I will focus on the post-surgical atrial tachycardia mapping and ablation in patients with rheumatic heart disease. I have no disclosure. So the first of all, we should know the prevalence of atrial tachycardias after the surgical repairment of any kind of cardiac disease. And theoretically, any atriectomy patient will develop the atrial arrhythmia, especially tachyarrhythmia. But after 5-year follow-up of the surgery, 10 to 30% of patients after the Muscat senior operation will develop atrial macro reentries. And nearly 1/3 of the patients, they underwent a Fontan surgery, will develop macro reentries. The majority of the arrhythmia circuits were right-sided and consist of atrial flutter, and the peri-atriectomy almost 50% of the patients. However, in patients with rheumatic heart disease after surgery, the subject is very complex, re-entering multiple atrial tachycardias, including different types of the re-entry. And I think before we further discuss the mechanisms and ablation strategy, we should know the surgical incisions access to the left atrium, because the almost 100% of the patients with rheumatic heart disease, they will have the mitral repairment or mitral valve replacement. So the access to the left atrium can be characterized into 3 types. Type 1 is the, look at here, is the right atrium free wall incisional line plus the septal line to the left atrium. And type 2, the line is from free wall all the way to the septal area, covering the upper part of the right atrium. So this is a longer incisional line. And type 3 is directly go to the left atrium, but this is posterior interatrial groove incision. But in some applications, because the appendage is excised, so they will have the suture line at the basal part of the appendage area. But please bear in mind, most of the patients, not almost all the patients, they have the bypass circulation, so they have the cannulation scars. And the other thing we should, bear in mind is that we should know the conduction pathways from the right atrium to the left atrium, and also we should know some intra-atrial preferential conduction pathways. So the leading conduction pathway from the right atrium to the left atrium is Bankman bundle, and followed by fossa vallis. So this is septal bundle, and we also have the coronary sinus precardial vein bundle. But these 3 bundles are from right to left atrium. But in some of the patients, we have septal pulmonary bundle, and also we have the vein of Marshall epicardially to be the conduction pathway from the upper to lower of the left atrium on the free wall. So the other thing that is also very important we should understand is the slow conduction and the circuit length. So look at here from this picture, you can see that the longer the circuit, the less dependent of the circuit is on the slow conduction area. So if the circuit is very small, so you need to have slower conduction areas, or you should have more conduction areas. So look at here. this is the upper loop reentry going around the superior vena cava. So the circuit is very small. Then we should have more slow conduction areas, or even if you have one small conduction area, so this area is much, much slower with the conduction time. But if you have a big circuit, so the slow conduction is less dependent. And even in some of the patients, you don't have the slow conduction areas. And the mechanism of the post-surgical atrial tachycardia can be characterized into three types. One is focal or micro reentry, and the other is the macro reentry, and this is very common. Macro reentry often will involve the left atrium, right atrium, and in some of the patients, they will involve both the atrium. So to initiate and maintain a macro reentry circuit, essential factors are required, including an inexcitable central obstacle and blocking lines to prevent collision of the wavefront. The activation conduction time going around the circuit is longer than the effective refractory period of the atrial myocardium. So these are the case examples. Look at here. This is a post mitral valve replacement, but in these patients, you can see that the patient developed the atrial tachycardia, but this tachycardia, you can see that is by 3D mapping is the localized reentry. You can see the electrogram is very much fractionated and long-lasting. And in some of the patients, because the macro reentry will via the bridge of the epicardial conduction. So from only the endocardial view, you can see that some of the patients we are mimicking the small reentry, but actually this is a macro reentry. So this case, you can see that it's the macro reentry going around the mitral annulus, but endocardial map, you can see that it looks like the localized reentry, but actually the activation is going around via the epicardial conduction. And here's a typical case of the macro reentry going around the incisional line on the right atrium free wall. You can see that the activation, the circuit is going around this conduction barrier. But you can see that from voltage map, this is the low voltage area, but actually this is the incisional areas. But look at the superior vena cava and inferior vena cava. You can see these low voltage areas, but these areas are the cannulation scars. So you can see the conduction channels between the superior vena cava and the incisional scar, and also the incisional scar to the inferior vena cava. So two conduction channels. And these two conduction channels often is the slow conduction areas, but you can see the electrogram here is a double potential electrogram. And look at the propagation map, you can see that this is a very typical case of the activation going around the incisional line. Actually, from the activation map, you can see this is the collision line, but this is the previous surgical incisional line. So going around along the right atrium free wall, going up, turning around, and move down to the inferior vena cava, and then going through the isthmus between the incisional line and the inferior vena cava. So this is a case of the macro reentry going around the incisional line. In our own days, we characterized into of the macro reentries after surgical repairment of the atrial septal defect. So you can see that when you put an incisional line on the atrial free wall, you actually are creating two slow conduction areas. One is between the incisional line and the TV annulus. The other is the end of this incisional line to the IVC. So these slow conduction areas can generate macro reentries, either going around the incisional line or promote the atrial flutter going around TV annulus. But sometimes these two circuits can occur at the same time. So this is the figure A reentry. But when the surgical line is set like this from the TV annulus all the way down to the IVC, all these circuits can be prevented. And if we do the catheter ablation to eliminate these macro reentries, we should do two areas. One is the isthmus between the incisional line to the TV annulus. The other is the end of this incisional line to the IVC. But you can also choose the cable tricuspid isthmus line. And if you do two lines, all the macro reentries can be gone. So here's a case of the incisional line all the way to the inferior vena cava. So this case, you can see that this is a blocking line. So from A to B to C, you can see all the double potentials. So these double potentials from narrow to wide, you can see this is a very wide double potential. And actually this is a macro reentry going around only circulating around the TV annulus. And also in our early studies, we found that even in some of the patients after the surgical repairment, the typical atrial flutter is going around the TV annulus, but the slow conduction area is not at the isthmus area like the typical atrial flutter. This is the typical atrial flutter. The slow conduction area is exactly at the isthmus area. But in the post-atrial atrial atrial flutter, the slow conduction is on the atrial free wall. So you can see that from D to E, the conduction time, E to F, the conduction time. So E to F, you can see the conduction time from E to F. So takes almost 50% of the conduction time of the tachycardia cyclers. This is the comparison between the typical atrial flutter and surgical atrial flutter. You can see that the surgical atrial flutter, the slow conduction area is at the free wall of the right atrium. On the contrary, the typical atrial flutter, the slow conduction area is at the isthmus of the right atrium. And also our animal study showing that how the incisional line generating slow conduction areas and promoting the atrial macro reentries. If you put a line far away from the TV annulus and also the IVC, you can see this alpha, this beta is longer than 1 centimeter. So it's hard to form these slow conduction areas. But if the alpha and beta is narrow, less than 1 centimeter, and these two areas will be developed as the slow conduction area, and will promote the atrial macro reentries. But if you do the line like this from TV annulus all the way to the IVC, so all these slow conduction areas are closed, and these are the proofs of the pathologic test. The other example is in some of the cases, the macro reentry can go around the septal line because the in rheumatic heart disease, if you want to make access from right atrium to the left atrium, you should have a line at the septal area. So this is a line. You can see that this is the free wall line. This is the septal line. Between these two lines, there's a conduction channel. So the macro reentry is going around the incisional line of the septal area. So when you do ablation, you can extend the line all the way to the SVC. So the atrial tachycardia terminate here. And this is the left atrial macular reentry. Also, after the surgical repairment of the mitral valve. So this is the atrial tachycardia. We do the super high density map. You can see that actually this is a macular reentry going around the incisional line of the left anterior wall. But you can see that here, this is the appendage area, but this appendage has been excised, and you can see the suture line at the ridge area. But when you look at the activation map, this atrial tachycardia is like the figure of 8 reentry. So you can see here. So this is the slow conduction area. The macular reentry is through this isthmus conduction going around the mitral annulus back to the anterior wall and to the isthmus area. But also you can see that this circuit can also going around the suture line of the appendage area. So actually this is a case of macular reentry of figure of 8. And when you close this slow conduction area, this is the channel conduction area, the tachycardia is terminated and cannot be induced again. And also in some of the cases, during this surgical procedure, they also do trial ablation to do the lines. This is a roof line, this is bottom line. You can see some of the patients, they because you leave a gap here. So this gap area is the slow conduction area. This is a case of the roof-dependent atrial macular reentry, but you can see that the slow conduction area is at the upper roof of the left side. And also this is a roof-dependent atrial macular reentry. So when you see the mechanism like this, it's very easy to terminate the macular reentry at the roof part area. So during ablation procedures, in some of the cases, so this is the case of the atrial fibrillation patients. Also, the after the surgical repairment of the surgical replacement of the mitral valve. So we will do the box isolation of the entire posterior wall. You can see that when we isolate the entire area of the posterior wall, so this is the automaticity inside the posterior wall, but the atrial fibrillation automatically organized to the atrial macular reentry. And then when we do the activation map, you can see that this atrial macular reentry is going around the mitral ring clockwise. So this is the mitral isthmus dependent atrial macular reentry. But actually the slow conduction area is at the anterior part of the basal area of the appendage. When you do a small linear lesion here, the tachycardia can be terminated. But some of the patients, the atrial tachycardia is very complex. So in this case, actually the macular reentry involves both the atrium. This is the right atrium. So you can see that the activation is going around the incisional line at the septal area, but the superior vena cava was involved, and also the isthmus area between the septal line to the IVC area. So we do the ablation at the isthmus area between the line to the IVC, but you can see that the atrial tachycardia cycle length is prolonged from 280 to 300. But when we do the left side map, but you can see that the left side map this left side activation is passively involved. And actually, because we have both the right side and left side, but this inferior area is not transmurally lesioned. So the activation is also can be going through this area, but the toning run point is move over up to the superior vena cava. So when we ablate the lesions extending the line to the SVC, so the atrial tachycardia, you can see the cycle length is prolonged and finally terminated. So this is the septal macro reentry sometimes involves both of the atrium. This is type 1, the biatrial tachycardia. So the free wall, two free walls, right atrium free wall, left atrium free wall are involved. This tachycardia cycle length is very much longer. Sometimes the cycle length can be 40 millisecond and 400 millisecond or 500 millisecond. But some of the patients, only the left side or the right side is dominant, but the septal area is involved. But some of the biatrial tachycardia only involve the septal area. So the cycle length is relatively shorter, but the mechanism here, the ablation strategy is quite similar. And the outcome of the atrial tachycardia post the surgical repairment or surgical replacement of mitral valve, the success rate, acute success rate is very high, almost 95%, but the long-term outcome is poor. So you can see here the recurrence rate and almost 40% on average of 2 years follow-up, and 2/3 of the patients can have the recurrence after 4 years follow-up. And ladies and gentlemen, this is the take-home message. Multiple atrial tachycardias may occur in post-surgical patients with rheumatic heart disease. And surgical incisional scar, ablation lines, disease scar, and anatomic barriers are the complex substrates promoting atrial tachyarrhythmias. High-density voltage map and entrainment pacing can help us to understand the mechanism. Super high-density map recently can also make the wavefront propagation, the true circuit, the slow conduction, and the bloodline visible. This can help us to make the decision of the ablation strategy. And linear lesions extending the line to the conduction barriers are the common strategy to abolish macro reentries, but localized homogenization is often used to eliminate focal or small reentries. Thank you very much for your attention.
Thank you. Daljit, do we have him online? Sure. Thanks, Professor Long. Very nice talk. Just two questions. One is, how many times for a single tachycardia you had to interrupt multiple isthmuses or make multiple lines to finally get a success? And secondly, the lateral right atriotomy seems to be the most common incision, obviously. So would you advise a surgeon to do a cryoablation extending to both the vena cava when he comes out of the surgery, so that we have less of these arrhythmias in the follow-up? Yeah, so if we get him, Professor Chen, can you hear us? Yeah. Okay, so I think we are short on time, and I guess Dr. Chen, are you able to hear us? Sure. So I think in interest of time, if we get Dr. Chen again, we can discuss with him. But let me request Dr. Dheeraj Gupta to tell us about what we are all worried about to get on this AF ablation in a big way is about the complications. Dr. Gupta, you can start.
I would like to thank the organizers, especially Dr. Narasimhan.
Can you have
for
the
his
volume
very
up?
kind invitation to contribute to the symposium. I've been tasked with speaking about how to avoid complications during AF ablation, and I'm going to do that over the next 10 to 12 minutes.
I think a little more volume.
First of all, I'd like to start by saying that the complications associated with AF ablation have become far less frequent over the last decade. This was a very good study published by Karam Benali et al., in which they analyzed the complication rates with AF ablation as published in 89 studies, randomized controlled trial studies, over a 10-year period from 2013 to 2022. And they looked at over 15,000 AF ablation cases and found that the incidence of complications with AF ablation had decreased considerably from about 5.2% over the first 5-year period compared to about 4% over the next 5-year period, so 3.8%, so considerable reduction in overall complication rate. But more importantly, the incidence of serious complications almost halved from 3.5% to 1.9%. Of the complications that did occur, the most common, almost half of them, were related to vascular complications, groin access. About 0.8% were related to cardiac tamponade requiring pericardiocentesis or sometimes even open surgery. 0.2% were strokes, and then there were a myriad of other more rare complications. Overall, the incidence of mortality was 0.05%. So 1 in 2,000 cases who had AF ablation were complicated with mortality. Now, which obviously is a very big thing, given that by and large this is an elective procedure performed in patients who are otherwise extremely fit and well. Now, how to avoid complications? I would like to do that by just 3 simple steps. First of all, avoid blind femoral venous and blind transeptal punctures as far as possible. Number 2, I would recommend that we choose your ablation modality wisely, but also the lesion prescription in terms of what you are trying to achieve in the cancer laboratory. And last, you should adopt a streamlined pathway that encompasses the entire patient journey. By far, the most common complications are related to blind vascular access, and we have shown that as long ago as 10 years ago, that if you were to use vascular ultrasound, you will eradicate the vascular complications. And we did that in a quasi-randomized fashion in which we have 2 EP labs. One of the EP labs, we used the vascular ultrasound for all procedures. The other one, we just did blind punctures as was routine. And we found that both major as well as minor complications were significantly reduced in those patients who had vascular ultrasound guided access. In particular, patients, when they went home, they required less analgesic medications and they had less bruising if they had vascular ultrasound guided access compared to blind punctures. Once the procedure is performed and we have given protamine to reverse the effect of intravenous heparin, we use this very simple figure of 8 suture, which is inexpensive. It takes literally 2 minutes to do, and it avoids you having to press on the groin. It also aids early mobilization and same-day discharge, which is now the routine following AF ablation at our center. So I would strongly recommend that you use this, especially now that we are using larger bore devices, whether it's for cryoballoon, whether it's for pulse field ablation, you're using much larger bore sheets, and it's so much easier to just use the single figure of 8 suture rather than having to press on the groin. for a long time or use devices such as femstone.
No, I really wonder for your ultrasound guided puncture because I mean, why do you do this ultrasound guided? Do I only anterior puncture? Yeah. No, I'm saying the venous puncture. Why do you insist on
Indeed, but complications continue to be the mostly looked at the so it doesn't matter even if you have the state-of-the-art ablation technology, the commonest complications continue to be those related to vascular access. But what we did was we analyzed the complications according to those centers where ultrasound was used routinely compared to where it wasn't. And what we found was that the vascular complications were 3 times more likely in those centers where ultrasound was not used routinely. So once again, whatever technology you use, you please make sure that you do not do blind femoral venous punctures. And indeed, by doing so, we have all but eradicated vascular complications at our center. We recently published our results for 10,000 cases over a decade, and what we found was that only 2 major complications occurred during this 10-year period. One, a retroperitoneal hemorrhage, and another one, a pseudoaneurysm requiring a thrombin injection. So by and large, vascular complications have been eradicated at our center by the routine use of vascular ultrasound, protamine, and a simple figure of 8 suture at the end of the procedure. Secondly, you need to choose your ablation modality wisely. Now, traditionally AF ablation has involved point-by-point focal radiofrequency application, which is absolutely fine, except that it is very much related to variation of practice between operators, also related to the operator volumes, operator skill, if you like. More recently, cryoballoon PVI has come in a big way. One of the advantages of cryoballoon PVI is that it is much more simpler, and the learning curve for a lot of the operators. Randomized controlled trials have shown that cryoballoon PVI is as effective as a point-by-point focal radiofrequency PVI. But obviously the cryoballoon has several advantages, especially the fact that the learning curve is much shorter, and so it doesn't depend upon the operators having to do hundreds and hundreds of cases every year to maintain their skills. And that is one of the reasons why cryoballoon PVI has become much more popular over the last decade. If you are going to use radiofrequency ablation, and which is certainly my favorite tool as well, rather than using a lot of variation in your practice, I would recommend that you use one of the standardized ablation indices, whether that is ablation index, as is used in the Carter platform, or lesion size index, as is used in the velocity or precision platform. Essentially, these indices integrate the various components of RF application, including contact force, power, time, and in the case of the lesion size index, even the electrical current that flows from the catheter tip to the tissue. And once you do that, your outcomes are a lot more better because the procedure becomes far more standardized. And the way we do it in Liverpool is we use general anesthesia, and we use a steerable sheath. Both of these things improve catheter stability. And then we use objective lesion tagging and make sure that we have contiguity between lesions. So increasingly, our post-ablation maps looks a bit like this, rather than the bit on the left side of the screen, which is the way they used to look about a decade ago. And we've shown that this protocol is reproducible. The so-called closed protocol is now the standard of care in most EP laboratories all over the world. And we performed the study VISTAX, in which we had 17 centers in Europe, and we showed that if you used a closed protocol PVI for paroxysmal AF, your success rates were almost 90% at 12 months. And also the protocol was reproducible across different centers, different operators, almost irrespective of their previous experience level. Traditionally, radiofrequency has been delivered in a power control mode. With this, the power generated is constant throughout the burn. And what this means is that if the catheter tip is poor, you will have inadequate RF energy transfer, and you might result in a non-transmural lesion. If, on the other hand, if the tissue tip contact is forceful, you can have excessive radiofrequency energy transfer, and you can have a steam pop with tissue disruption and possibly tamponade. On the other hand, with modern catheters such as the Q-dot catheter and the diamond tip catheter, these had 6 thermocouples at the catheter tip, which allowed accurate real-time assessment of temperature at the catheter tissue interface, and the radiofrequency can be delivered in the temperature control mode, and this adds an element of safety to RF application. And what this allows is for you to use much higher powers, like 50 volts or even 90 volts, compared to what was the case earlier. It means that the procedure time is shorter, the radiofrequency time is shorter, and also the fluid delivery is much lower in compared to using lower powers for longer periods. One very big advantage of using higher powers is that the lesions are much more superficial as compared to traditionally low power, long duration lesions, which means possibly less collateral damage to surrounding structures such as the esophagus. And we have shown that if you use 50 volts, so-called high power, short duration ablation for AF ablation, it's equally effective as using lower power ablation, but is obviously much quicker and very effective as well. The other thing I would like to say is that as far as possible, try to limit your lesion prescription to pulmonary vein isolation only. No extra PV ablation has been conclusively shown to be better than PVI alone, and this is in spite of over a decade of multiple trials looking at various lesion prescriptions. None of them have actually stood the test of time, and so try to limit your lesion strategy to PVI only. And we have shown that if you do good quality PVI with a closed protocol, even in persistent atrial fibrillation, your outcomes are likely to be excellent. And this was the PRAISE study in which every patient had daily ECG monitoring for the duration of the follow-up, and we showed that the 12-month results with persistent AF were greater than 80% with just PVI only. Last but not the least, one should adopt a streamlined pathway that encompasses the entire patient journey. This is essentially the protocol that we follow in Liverpool, right, starting from a hospital-wide anticoagulation policy, which means uninterrupted anticoagulation throughout, which means we don't have to do a pre-procedure transesophageal echo to exclude the left atrial thrombus. As I said, we use a vascular ultrasound in all cases. We then give protamine afterwards prior to sheath removal. We use a figure-of-8 suture, and most patients go home the same day. Many trials have compared uninterrupted NOACs versus uninterrupted vitamin K antagonists in AF ablation, and essentially all of them have shown that uninterrupted NOACs are at least as good as vitamin K antagonists, if not superior, and hence this is now increasingly the standard of care all over the world. All of these changes have contributed to making AF ablation far safer than it used to be as recently as 5 or 10 years ago. As I've shown, the vascular complications have all been eradicated by the use of vascular ultrasound and by avoiding bridging with heparin. The incidence of tamponade has been reduced by decreasing the amount of ablation one performs for AF cases, and also increasingly, especially in low volume centers, using cryoballoon rather than radiofrequency. The incidence of stroke and TI has again been almost eradicated by the use of continuous oral anticoagulation peri-procedure, and also the fact that now we maintain an activated clotting time of greater than 300 seconds throughout. So much so that AF ablation is now one of the least complex and the most predictable EP case in most Western laboratories. We know how much each PVI case is going to take, and so we can list accordingly. And if you see how the AF ablation has evolved over the last 10 years, as recently as in 2013, we used to use conventional radiofrequency. Median procedure time were about 3 hours. We used to schedule about 2 cases per day. Most patients used to stay in hospital for 1 or even 2 nights. 5 years ago, the case mix had moved from pure radiofrequency to about half cryoballoon, high power, short duration radiofrequency. With this, the mean procedure time was reduced to about 2 hours. We started scheduling 3 cases per day, and most patients would stay home, would go home after 1 night. And now, most recently, the case mix has changed even further. We've started using pulse field ablation for AF ablation, in addition to very high power, short duration RF ablation. Mean procedure times are around 60 to 90 minutes. We do 4 cases per day, and almost invariably, patients go home the same day. So to conclude, AF ablation is now one of the safest EP procedures. We use vascular ultrasound to guide venous access, and we limit the lesion sets to PVI only. And most importantly, we maintain consistency in practice across the operators, almost have an assembly-like approach in the EP laboratory. I thank you for your attention, and I look forward to discussions.
Any question? Sir, I would like to ask one question. Sir, initial complications like pericardial tamponade and tracheal fistula are more fearing complication for any one of us who started practice of AF ablation. Is there anything in your experience that some set of patients like hypertrophic cardiomyopathy or hypertensive heart disease, where the tamponade were observed in more number of patients compared to routine atrial fibrillation, or any specific subsets you noticed the tamponade prevalence more than other? So you could not.
I think you're muted.
Are you muted?
Can you hear me?
Yeah.
Good. Well, thank you, and good morning, everyone. Well, thanks for the question. So certain variables that predict the incidence of tamponade are patient-specific and technology-specific. Patient-specific typically tend to be, so women have a higher incidence of tamponade than men, and also low BMI has been associated with higher rate of tamponade, possibly because these patients often have thinner wall left atrium. In terms of procedure, radiofrequency has a higher risk of tamponade as compared to cryoballoon for the reasons I mentioned in my talk, but also cases where extensive ablation has been performed, especially epicardial ablation in the coronary sinus, or very extensive linear lesions have been created, there's a higher risk of tamponade. So as long as one chooses one's lesion prescription to pulmonary vein isolation only, then the incidence of tamponade should be as low as is possible. Of course, the trickiest part of the procedure in terms of the risk for tamponade is a transseptal approach. I do not have the time to go into that in some detail. Obviously, if one has access to imaging like ICE in the US or transesophageal echo in the UK, it makes it much easier. But in the absence of imaging, I think operator experience makes a big difference.
Hi, Dheeraj. Good afternoon. How are you?
I'm very well. How are you doing?
So just another, I saw your slides how your approach for and use of technology has changed over the years. And now that you've included PFA, what percentage of your ablations are PFA, and how does the cost factor into in UK?
Yes, well, thank you for that question. Well, an increasing proportion of our AF ablation cases is PFA. The reasons are twofold, really. First of all is efficiency. Typical procedure times with the PFA are now less than an hour, so we can easily schedule 5, sometimes 6 cases in a day, which you couldn't really even dream of doing with any of the other technologies. So when the waiting lists are so long, as they often are in the UK, patients have to wait 12 months to get their AF ablation once they're listed. So this is a huge advantage for us in terms of bringing the waiting list down. The second advantage is more theoretical, really, which is the improved safety of the technique. As you know, pulse field ablation being more cardioselective, it almost eradicates the risk of esophageal injury and phrenic nerve injury, which is a big advantage. Although, as I've also shown, the incidence of those complications has become very low anyway. Now, in terms of the cost, you're absolutely right. There are cost pressures at the moment. Typically, our consumable costs for pulse field ablation in the UK are about £2,000 more per case. So that is a big difference. And we've just recently submitted a late-breaking session for European Heart Rhythm Association looking at exactly that, the cost efficiency of pulse field ablation compared to RF and cryoballoon for first-time PVI. Obviously, the results are embargoed at the moment. I cannot give too much away. But yes, that is an issue. I think the cost of PFA will come down as more and more players enter the marketplace. And then I think in the coming years, pulse field ablation will become the dominant energy source for AF ablation.
One follow-up question to that. In terms of PFA, there are so many different competing technologies. Which one are you using and which one you think will be the winner in the long haul?
I wish I had a crystal ball so I could see in the future, but at the moment we use the Farapulse, which is obviously the one which was approved first in Europe. So we've been using it for 2 years. We've used it in about 300 cases at Liverpool. It does exactly what it says on the tin. It does very quick PVI very efficiently. The problem with Farapulse is that it is at the moment reliant on fluoroscopy, a bit like cryoballoon. So for people like me who are used to using a 3D mapping and CARTO, and my fluoro times are like 1 minute or 2 minutes per case, now suddenly to have to go back to using fluoroscopy is a big problem. So you end up having probably 10 minutes of fluoroscopy per case. So with the Medtronic Affera balloon, we have just started using that. Now, I think that has a lot of advantages over Farapulse, especially integration of 3D mapping, the fact that you can toggle between radio frequency and pulse field ablation, that again is a huge advantage. Out of the two, I think if cost pressures are not put to one side, I think something like a large footprint focal catheter like the Affera balloon probably has more promise compared to other technologies.
Thank you, Dheeraj.
Thanks, Dheeraj. Excellent talk. I had 2 questions for you. One is, how safe is a high power short duration like 50 watts with the conventional power controlled ablation techniques with or without contact force? The other is that people who do AF but infrequently, like me for example, there tends to be lesion overstacking sometimes at certain places. So which are the areas which are more prone to be causing tamponade while doing a PVI?
Hi Vivek, good to see you. In answer to your questions, paradoxically we have seen and shown that using higher powers for shorter duration, the procedure is shorter. I would only say one thing, that when you are delivering radio frequency at any powers, one should keep a close eye on the generator impedance graph. So we should look at the way the generator impedance is dropping. If it is dropping precipitously, once it drops more than about 20 to 25 ohms, you should stop, because that usually is a precursor for a steam pop. So if you do that, then using higher powers will only make the procedure quicker, not riskier. Now, in answer to the second question was about the using. Sorry, I forgot the question. Was it about the higher power
So if you are doing AF infrequently, you tend to have sometimes lesion overstacking at certain places.
True.
So which areas are more prone to be causing tamponade?
Sure. The one area where you're much more likely to cause tamponade is the roof of the right vaka, which is the roof of the right upper pulmonary vein. The reason is simple. That's when your catheter is actually at right angles to the left atrial roof. And when the patient takes a breath, the roof really comes down towards your catheter, especially if you have a rigid sheath. So we have seen in one respiratory cycle, the contact force can change from 5 gram to 60 to 70 gram with just one respiratory cycle because of the way the roof comes down over the catheter. So I'm always more careful while delivering radio frequency there. The rest of it should be fairly straightforward, especially if you avoid contact force of greater than 20 grams.
Thanks, Dr. Gupta. I think Dr. Narasimhan wants to.
Hi, Dheeraj. Thank you so much. Wonderful talk as usual. One thing is, this is a very pertinent question, what Vivek asked, is just for those brief 10 seconds, let it be under apnea. The anesthetist can just hold the breath when your catheter is at the roof, and intermittent lesions at those, when you see this huge variation in the contact force, ask them to hold the breath.
True. Very good point.
Thank you. I think after this we'll be finding AF ablation safer. Thanks a lot. Let's move on to with some changes in the program. I think we'll request Dr. Vidyadhar Lat to make his presentation on surgical management of AF.
Thank you, and good afternoon to everyone. Thanks, Dr. Narasimhan, Dr. Daljit, and thanks, Ashish, for this invite. I've tried to present this topic as a journey of a maze, and I hope you like it. So we'll start with the indications. I think maze is a class 1 indication for surgical ablation of AF. Particularly the AF which is associated with structural heart disease, and it is a class 2A indication in surgical ablation of AF in the absence of structural heart disease, which we used to refer to as standalone AF. And the third point is, I think, also very important, that there has to be a very multidisciplinary heart team approach to atrial fibrillation, with a lot of dedication and passion if you want to get good results with your patients and if you want to keep them AF free for the longest time. So these three gentlemen from WashU School of Medicine were the pioneers of the Cox-Maze procedure. Professor Cox, who was a cardiac surgeon, and then Professor Bono and Schussler, who were the cardiologists and cardiac electrophysiologists. So they performed some brilliant mapping experiments in a very good canine model, and they came up with first the mechanism of the atrial fibrillation, and this pretty much is the mechanism in persistent and long persistent AFs, where there is presence of multiple large macro reentrant circuits which are around 5 to 6 centimeters in diameter. They are present in either or both the atria. They are able to sustain themselves. So atrial fibrillation causing more atrial fibrillation, it's a self-perpetuating arrhythmia. So the way the surgical solution evolved was Professor Moe in 1960s had shown that if you chop the atria into pieces, it stops fibrillating. So what Professor James Cox thought, that if we place the surgical incisions close enough, we will be able to ablate all these macro reentrant circuits, but then we have to create a pattern whereby the cardiac impulse can move from the sinus node to the AV node in a normal fashion. The atria are activated, so we don't have a lot of atrial inactivity because the atrial transport function matters, and there is a AV synchrony, and this is the set of lesions that they came up with. Of course, the maze went through its phases of evolution in the form of version 1, version 2, and I should put it this way, the perfect set of lesions was the Cox-Maze 3 lesions. And I'll just quickly go over all these lesions here, as you can see. Now, the Cox-Maze procedure was a cut and sew maze, where they used to actually incise over the atria and then suture them together to create these conduction blocks. So you can see there is an incision going all around the pulmonary veins. Then there is an incision going across to the left atrial appendage. The left atrial appendage is ablated. Then there is another incision going from this encircling line. Actually, this goes to the mitral. This is the mitral isthmus lesion, which goes all the way up to the mitral annulus. Then there is another lesion going to the Waterston's groove here. Then this is the lesion on the right atrium going from the SVC to the IVC. Then along the atrial free wall to the tricuspid annulus, this is your cavo tricuspid isthmus being taken care of. This lesion is going to the anterior tricuspid annulus, and they used to ablate even the right atrial appendage. So and they actually had some septal lesions as well, but these are now abandoned because they are not important anymore. And they published their they published their 15-year results in year 2000 in 346. Mind you, most of the work that happened initially was in atrial fibrillation, which was not associated with structural heart disease, what we call standalone AF. Of these 346, 100 patients were standalone AFs, and their results were absolutely brilliant. They cured AF in 99% of the patients, 2% required long-term antiarrhythmics, 15% needed pacemakers. The transport function was preserved in both atria. The freedom from long-term stroke over 15 years was a staggering 99.3%, and I think this is a very important objective to achieve. And they also showed that compared to patients who didn't get MACE, there is definitely a diversion in the survival curves, and there was improved 10-year survival in patients who actually underwent MACE. Now, there were other centers in North America who started doing this procedure, the Cleveland Clinic, the Toronto General, Mayo Clinic, but as you can see, none of them could duplicate the results of this group. There were a few reasons for this. The cut-and-sew Cox-Maze 3 procedure was a very complex procedure, demanding surgical technique, lengthy operative time, lengthy time on heart-lung machine. So there was a lot of morbidity related to bleeding complications, renal dysfunctions, hepatic dysfunctions, cardiac dysfunctions, and the results could not be reproduced by other centers, and which is why it was not universally adopted despite excellent results. But mind you, there was one more reason. The Cox's group, Professor James Cox's group, was a very coordinated group and worked in a very concerted, passionate manner towards treating their atrial fibrillation patients over years and years on end to get these excellent results, and this point should not be missed. So clearly there had to be a paradigm shift. We needed to make it a little more user-friendly, simpler, and the paradigm shift came in the form of use of energy sources to create conduction blocks using instead of the surgical incisions. So various energy sources have been tried: radio frequency, cryo-energy, microwave laser, HIFU. But the one that actually is currently recommended is the use of radio frequency bipolar coagulation in combination with cryo-energy. And this procedure, which was again pioneered by the same group, is referred to as the Cox-Maze 4. Radio frequency, bipolar radio frequency, and cryo-energy continue to be the popular modalities. They are recommended by the STS guidelines and expert consensus. The reason being they are highly efficacious, one, in making transmural lesions, and of course they do not cause any collateral damage, because in the earlier times when we used, in earlier times when we used our unipolar catheters, there were some reports of collateral damage to the esophagus causing left atrial esophageal fistulas. Of course, the results were not as good as the cut-and-sew maze, between 80 to 90% success rate, but the trade-off was big. It was safe, reproducible, and more acceptable to the surgeons. Also, this technique could be done in a minimally invasive fashion through a right interior thoracotomy. Now, the deterrent was, of course, the device costs. The radio frequency devices, which are currently available in India, the Medtronic Cardioablate is a one-time use device costing 75,000 rupees per case, and the cryo machine, the initial investment is around 16 lakhs. Now, back in the days when Maze was creating a buzz around the world, there was one gentleman, and he's my professor and mentor, who was trying to find a solution, a cheaper solution to treat his patients of rheumatic atrial fibrillation. And as we all know, rheumatic atrial fibrillation is what we are all the time treating, and these patients belong to the lower socioeconomic strata. So Professor Patwardhan and Professor Sai in Netherlands were actually the first two individuals to use RF energy to perform Maze surgery in 1996. And Professor Patwardhan actually used some locally available devices to create these Cox-Maze 3 lesion set and started offering Maze surgery first in Sion Hospital in Mumbai, and then when he shifted to KM Hospital in Mumbai where I was training, that's where he continued his work, and I had this excellent opportunity to work with him. We also did a few number of studies during that time, and That's where I adopted the technique. Now, this was the hardware. This is a basic bipolar cautery, which is available in any standard cardiac operating room, and the bipolar forceps that we use is also available, comes with the cautery. And the second machine, actually, Dr. Patwardhan's wife was an ophthalmologist. He came across this cryo machine in an ophthal OT, which works on compressed nitrous oxide, and it actually freezes up to minus 60 degrees centigrade. And we use the retinal probe, which has a 6 millimeter active tip. And we actually ablated a few appendages, left atrial appendages, sent them to our histopathologist. And we tried different settings to make sure to understand what should be the settings to create a full thickness or a transmural lesion, because one of the disadvantages we didn't, or rather, the commercially available units that we have, whether it is the Atricure or the CardioAblate, these machines give us a biofeedback based on the impedance, whether our lesions are complete or not. Of course, these basic units didn't have that kind of a feedback, but we looked in the lab and we noted that we could create transmural lesions. And we actually published our 5-year or rather midterm results in year 2003 in our first 84 patients. And in the first year, we had around 85% conversion rate. Of course, there was an attrition rate of around 8%, and our sinus rhythm, we saw around 78% of our patients in sinus rhythm at 5 years. Surprisingly, none of our patients needed pacemaker, and that is something I don't have answer to. With this technique, our pacemaker use is very, very low. And we published our technique in the Heart, Lung, and Circulation in 2004. So, as a protege of the innovator, I have what my experience has been. It's a very simple technique, easily reproducible, and I always urge my fellow cardiac surgeons to kind of adopt it. The equipment is inexpensive, which is easily available. There is no additional morbidity and mortality and adds only 20 minutes additional operative time. I do my maze in 99% of my patients, whether they need double valve, triple valve, whether it is a redo, a second redo, I still go ahead passionately and do the maze procedure. But the caveat is, this is to a certain extent, with experience you get better. It is a little operator dependent because there is a lot of visual inspection that goes with it. And of course, it's not suitable for minimal access approach. I have offered I offer this in 99% of my cases. I've made a small change because I feel it doesn't have that biofeedback of impedance. I think sometimes there are gaps in the lesions that we correct. So now what I do is I ablate twice over. Every single line that I do, I ablate twice over to ensure that. And I have been closely following my last 43 cases. I've done more than 200, but last 43 cases I've been closely following. And we were able to restore sinus rhythm in 95% at the end of 1 month. And 90% were in sinus rhythm at 1 year and around 85% at 3 years. This is an unpublished data, ongoing study. Hopefully I should be able to come up with the paper soon. But what I have learned through my experience treating rheumatic atrial fibrillation is biatrial lesions have given best results. These rheumatic patients are, or particularly the persistent and long persistent rheumatic atrial fibrillations, they are long-standing diseases. There are multiple drivers in both the atria, and any lesser lesions don't seem to work as good as a complete biatrial set of lesions. So where are we? What have we learned from Cox's maze? It has been around for 30 plus years. Of course, the best results were with the cut and sew maze, but it's a highly complex surgery. I have done it only twice in my career. Cox's maze 4, which is surgical ablation using radiofrequency and cryoenergy, is currently one of the best options, gives almost close to 90% of conversion rate, definitely widely applicable and can be done through minimal access. Patwardhan's technique I propose as a technique made for India to treat our poor patients because there is no equipment cost involved, it's easily reproducible, and there is no additional mortality and morbidity. Standalone AF, of course, virtually most of the standalone AF is being treated as catheter ablation currently, works very well for paroxysmal AF. I'm not too sure about persistent and long persistent AFs being treated by catheter ablation. There is some improvement happening. There are hybrid approaches coming through. Just to touch base with hybrid approaches, these are the 3 hybrid approaches that are currently available. The first one being thoracoscopic ablation, followed 6 weeks later by EP study, and then the EP is touching up gaps in the lesions and adding more lesions based on the EP study. And I think this is very important because even the maze fails every single time. But what it makes easier later is that particularly in persistent and long persistent AFs, the failures can be treated by mapping them and by the electrophysiologist and touching up those areas where these arrhythmias are perpetuating. The second approach, or rather the hybrid approach, is thoracoscopic ablation based on intraoperative mapping. And last is the convergent procedure, which is evolving currently, where the surgeon ablates the posterior left atrial wall through subxiphoid approach, followed by thoracoscopic occlusion of the left atrial appendage, and few weeks later, the EP performs the pulmonary venous isolation with or without the cavo tricuspid isthmus lesion. Results are either superior or as good as the catheter ablation. Now, the future direction, where are we? Clearly, the impact of interventions on the AF epidemic is negligible. As you can see, only 9% of standalone AFs actually get catheter ablation or MACE surgery. In our country, there is no MACE surgery happening for standalone AFs. Concomitant AF, less than half of them receive concomitant MACE surgeries, and the percentage is even dismal in our country. My message is, we must ablate. Our tools may vary, our methods may vary, but we should have that dedication and passion to treat this arrhythmia aggressively, and I think a team approach matters a lot. A cardiac surgeon teaming up with the cardiologist, cardiac electrophysiologist, and dedicatedly following up these patients, because every time they get a atrial tachycardia or any kind of atrial fibrillations or flutters, I think treating them at that point in time matters a lot, because these tachycardias are going to beget more atrial fibrillation moving forward. And moving to my concluding slides, a large part of our success comes from our patients who put their faith in us. I'm just going to end with this interesting story and trivia about the MACE surgery. So Captain Deere was a pilot from Cyprus. He had permanent AF. I mean, in those days, we used to use those terminologies. In June 1986, he contacted James Cox because he heard from somewhere that he was actively working on designing a surgery to treat AF. But he was refused surgery because this procedure was still being evolved. But Captain Deere was very persistent. He returned back in September 1986, and he refused to leave. And he said, I'm not going home without a surgery. At that point in time, there was a procedure that existed, which was called atrial transection procedure, and which was done for him. But this procedure was not very successful, and he remained AF-free for 5 months. Late 1987, he came back to Professor James Cox and his group, and he said, go ahead and do my MACE surgery. And he was the second patient who was operated for a MACE surgery. He developed atrial flutter. After a few years, underwent a successful cath ablation and remained AF-free for 19 years. Even this anecdotal case report or the second case in the world, we have to see that this group was working together to keep this patient AF-free for 19 long years, and which is why this group has the best results with MACE surgery in the world. So without the courage and perseverance of this brave pilot, I think the MACE surgery wouldn't have reached where we are. And it only confirms my belief that there are only courageous surgeons. There are no courageous surgeons, there are only courageous patients. Thank you.
Any questions from the floor? Yeah.
There is no question you are a very courageous surgeon. But let me know why the surgeons spread across the country are not as courageous. What are their concerns? Why this is not so popular?
Okay, so interestingly, in 2020, Dr. Patrick McCarthy, there is a nice paper by him in which they actually surveyed in America to find out why surgeons are not doing maze. And they actually came up with a whole bunch of, can I go back to my slides? Can we go down all the way beyond? Thank you. Yeah, I'll show you that. I have that slide. Please go for, wait a minute, go back. Go back, please. Yeah, can we open this slide? So these are the barriers that were cited. Some surgeons said no barriers. Some said additional cross-clamp time. Some said my patients are too big a risk. Some said no additional remuneration. Others said not comfortable. Inadequate equipment, inadequate staff and support, belief that AF ablation worsens AF, belief that AF ablation doesn't work. So these are more than, there must be some genuine reasons, but most of them are, I think we just need to change our attitude towards that arrhythmia.
Yeah. So looking at the numbers, it is the additional cross-clamp time.
Yes.
So, what is in general your cross-clamp time compared to the others?
Sure. So, the cut-and-sew-coccyx maze needed an extra cross-clamp time of 1 hour, and which is pretty long. As a surgeon, you will understand why. But with the energy sources, and I am talking about the Patwardhan technique, and I have used my Medtronic cardio ablate also. It adds only 20 minutes to your cross-clamp time, and that's fair. And with the current cardioplegias that we have, I think we can easily add 20 minutes of cross-clamp time to our surgeries.
Thank you.
So Vidyadhar, some of your lesions are endocardial, right?
Yes. So the bipolar cautery, and thanks for asking this question, with the bipolar cautery, we avoid going all the way to areas where you have important vascular structures. So those are the areas where the cryo energy is used. Like, for example, the left atrial isthmus lesion or the mitral isthmus lesion. With the bipolar, we go up to the mitral annulus, but we stop short of the mitral annulus. And the remaining portion from that line to the mitral annulus, we use the cryo energy because in order to avoid damage to the circumflex artery, which runs behind the mitral annulus. So also on the coronary sinuses. And when we get closer to the tricuspid annulus, the anterior as well as the posterior annulus, we use the cryo energy.
Yeah. Good morning. Myself, Dr. Naresh. I'm cardiac surgeon here. First of all, congratulations on your wonderful talk, and you're doing a great job on surgical ablation for AF. Small question I have. The lesions you're creating with the bipolar, may I know what's the time duration when you're creating a lesion? How much duration you are going to create the lesion in the endocardially and while creating the, and are you using the same bipolar and for all the lesions, or exactly you did not mention which lesions are creating with the bipolar and what lesions are creating with the cryo?
Okay, so let's go to the left atrium first. So the left atriotomy is a lesion by itself, yes, going from the right superior to the right inferior pulmonary vein. Now from the right superior to the left superior pulmonary vein, we use the bipolar cautery. From the right inferior to the left inferior pulmonary vein, again we use the bipolar cautery. Then we go over to the left atrial appendage, we ampute the left atrial appendage, and through the left atrial appendage, I box off the lesion on the left side. So I encircle the left-sided pulmonary veins. So that creates a box encircling all the pulmonary veins. Then there is a lesion going from the left-sided line to the appendage. Then one lesion going from the inferior line or the line encircling the inferior pulmonary veins to the mitral isthmus, stopping just short of the mitral annulus where we use the cryocoagulation. At the back, we buzz the coronary sinus just to the left of the crux with the cryoprobe. Then we finish with the mitral valve, left-sided, whatever valvular surgery you do, come to the right side. The first lesion is, of course, an oblique right atriotomy. And through the oblique right atriotomy, there is a line going from the SVC to the IVC, which is done by bipolar coagulation. And from this line, you create another lesion going to the posterior tricuspid annulus, which is the cavotricuspid isthmus, stopping just short of the tricuspid annulus where you buzz with the cryoprobe. Then through the left, or rather the right atrial appendage, you create another lesion going to the anterior tricuspid annulus. So it's 10 o'clock and 2 o'clock pretty much. And that's where you again ablate with the cryoenergy, and that pretty much takes care of everything.
More or like a Cox-Maze 4 where chart is there that we have done 2 or 3 cases actually. The contact period is just you need to create only endocardial lesion?
No, so the bipolar works by pinching the tissue between the two active tips, right?
Yeah.
So it's going to burn between the two. So that's the big advantage. It is not going to burn anything outside of it. That is one. Second is the Patwardhan technique is, that's why I said it's a little operator dependent, but once you have seen it, basically you see if there is transmural, and the voltage changes from 35, 45 to 55. So depending on the wall thickness, you have to adjust the voltage. So that comes with a little bit of experience, and I adjust the voltage accordingly, and you can see the blanching occurring. And the cryo probe at whichever contact point, you keep it at least for 2 to 3 minutes. Nothing lesser than that. That's where you have to be a little, patient. And which is why cryo application is only in certain areas. If you were to do maze only with cryo ablation, it will take longer than 20 minutes for sure.
I am Dr. Sachin, electrophysiologist here. So is there any technique that you thoracoscopically you can ligate the appendage rather than using all the tools? Is it
Yeah,
safe?
so now thoracoscopically there is a device that is available, I think, which can be, but I don't know if it's available in India as of now.
No, without the device, is there any possibilities there to
I have not looked into it, honestly.
because that will save a lot of cost for the patient and it's one-time procedure.
Yeah, sure.
I'm sorry, we're running late, but either way, I'm really should congratulate you for taking this daunting task. Because number one, most of the rheumatic patients cannot afford anything. For some of those people who are listening to us from the Western countries, I think there are a couple of people watching the YouTube. People who have been operated with mitral valve or valve replacement on a government scheme where the government completely pays for the procedures cannot afford warfarin. And we have seen patients coming with stuck valve. Though that is the magnitude of the problem.
Yes.
So, and again, if I would like to reiterate, both Cox-Maze as well as randomized trials from Japan have consistently shown the freedom of stroke is dependent on restoring sinus rhythm. It's not the isolation of the left atrial appendage, but maintenance of sinus rhythm is what is important to prevent stroke. So this is very, very repeatedly it's been reiterated in surgical literature. I don't know why we forget this, but it's an important aspect. Thank you for
Absolutely. Thank you very much.
Thanks, Vidyadhar.
Yeah. Now I request Dr. Dinakar to come and present. Doctor. If you may.
Good morning, everybody. I'm Dr. Dinakar. I'm going to present one of the atrial arrhythmias which has been performed here. So he's a 70-year-old male patient and with a history of diabetes mellitus and hypertension. He had sinus bradycardia from 2010 but was not very much symptomatic. At that time, the evaluation of with cardiac MRI and FDG PET were normal. And he received a dual chamber pacemaker in 2015 for symptomatic sinus node dysfunction. So he was doing well for the initial 3 years, and from the last 2 years he was initially having episodes of atrial high rate events in the device, which were becoming more and more frequent, with recurrent persistent episodes in the last 1 year. So he was initially tried with multiple antiarrhythmics, including amiodarone and sotalol, for the control of the atrial tachyarrhythmias, but they remained persistent. So during the evaluation for the cause of the sinus node dysfunction and the atrial arrhythmias, he was found to have ryanodine receptor 2 missense mutation, which replaced tryptophan has been replacing arginine, and but the significance of it as a pathogenic mutation is not known. So he's now planned for genetic testing in the family for the segregation analysis. Whether it will go into the pathogenic or as a benign mutation, we don't know. And he also had a history of, the family history of ICD in the first cousin because of documented ventricular tachycardia. So coming to the atrial tachyarrhythmias, so this was a ECG which was there in the OPD. So here we can see that it's fairly regular narrow QRS tachycardia, and there appears to be probably some P wave like deflections in the middle of the in between the two QRS. So we are thinking it's a atrial tachyarrhythmia which we will be able to ablate. So then so this was the echo which was showing dilated right atrium and right ventricle with essentially the normal size of the left atrium and the left ventricle. So so there was not significant TR, so that was not related to the lead, or there was no pulmonary hypertension which was causing this. So he was taken to the lab, and in the lab, once the CS catheter was inserted and we tried the induction maneuver, so the tachycardia was, atrial tachyarrhythmia was induced with a atrial burst pacing at around 290 milliseconds. And we can see that it looks fairly regular once in the initial part, but within the few seconds, what happened was that the tachycardia cycle length was varying almost from 360 milliseconds to 280 milliseconds. So how to map this tachycardia? So with a varying cycle length, so in another, with time again, it starts to disorganize, and almost it looks like an atrial fibrillation. So we have taken a multi-electrode mapping catheter. So pentarray catheter was taken, and it was showing very much of fractionated electrograms and double potential kind of things. So on the anterior wall of the right atrium. So by echocardiography and everything, it looks like the substrate is in the right atrium, but we cannot map by the activation mapping. So we decided that let's map by the voltage mapping and see how the signals look. So we tried to create a bipolar voltage map using the cutoffs of 0.1 to 0.4 millivolts. So much of the low voltage area is present in the anterior wall of the right atrium. And once we look at the pentarray catheter, there are multiple fractionated signals which are almost staying for a prolonged period of time, and they are fractionated and double potentials were there. So those areas were tagged, and the ablations were given with the impedance measurement, and almost when we have ablated at the junction coming close to the end of the ablation and where the healthy myocardium appears to be there. So there is initially organization of the atrial fibrillation into the regular atrial arrhythmia, and then there was termination into sinus rhythm, not sinus rhythm, to the atrial pace rhythm. So then we tried the induction maneuvers again, but the tachycardia was not inducible. And during the same procedure, the CTA line was also created. And this was at 4 months follow-up. Although patient was not having very symptoms, he had one episode of atrial tachyarrhythmia which lasted for 10 seconds. And other than that, he was free for the any atrial high rate episodes till now. So, thank you.
So was only in the right atrium you saw those
yes, sir.
High frequency?
So we didn't go to the left atrium because there was no another atrial tachyarrhythmia that was induced with even with the isoprenaline.
So you think it was a focal area as a trigger for atrial fibrillation, and the rest of the atria was passively activated?
So we thought it is the low voltage area which was the substrate that was causing the atrial fibrillation.
Thank you. We'll go for
Thank
next.
you.
Next, I would like to invite Dr. Shomu Bora. It is he's online, I think. Can you connect? Next case is by Dr. Shomu Bora, sir. Ajit. Okay. Yeah, sorry, a small change. Next case by Dr. Ajit Tachar.
Not in the industrial way, but they have dedicated ones which is we are underplaying and not doing as much as we can in the present day. But yeah, I do believe so. There are, especially the hypertension, LDH, diastolic dysfunction, going to heart failure, episode.
Sir, can you just open your PPT?
Yeah, it's.
We can see you, we can hear you. Just need to your.
I've opened the PPT.
Can you just close and come out and open it one more time?
All right, I'll do that. I'll close the PPT.
We're only seeing your Explorer, that folder screen, sir. We're not seeing the PPT.
Okay, so I'll just open the PPT again. Is it visible now?
No, I think it's your screen is stuck, sir, for some reason.
Can you see it now?
No.
Have a break.
Can you share your screen, sir?
Yeah, I'm sharing my screen. It says you are screen sharing.
Sir, we'll do one thing. We'll just present Shomu's talk and then we'll come back. Sir.
Yeah,
2
sure.
minutes.
Sure.
Sir, we'll just present Shomu's presentation. It's recorded live.
The guys are getting restless.
present the case of atrial tachycardia. This is a 32-year-old patient who presented with clinically incessant tachycardia, discrete P-wave morphology, suggestive of atrial tachycardia possibly arising from the right superior pulmonary vein. Ejection fraction was less, 30%, and the patient's medications were not effective. We thought of a process of possibility of a tachycardiomyopathy and hence took for ablation. Putting the catheters in, we could see that the atrial local atrial electrogram in the his area were early. They were 8 milliseconds earlier than the P wave, and the right atrial signals were there in a narrow cluster, so that there was no evidence of slow conduction. Pacing from the decapolar catheter at various locations, the return cycle length was changing. There was no fixed return cycle length, even with a fixed atrial pacing cycle length. That means that either it was an automatic focus or there was non-capture of the circuit of the atrial tachycardia. We tried to terminate the tachycardia by fast atrial pacing. However, it caused a longer pause, but however, it returned immediately. The P wave, however, the next time that it came, the P wave morphology was different. And as you can see that the P wave was negative in V1 and V2, which was the opposite in the clinical tachycardia. So change in the activation pattern was seen once we did that, and there it was changing over a longer period also. If you see that the P wave was negative in V2 towards positive, and the activation pattern in the decapolar catheter was also changing. However, his signals remained the earliest still as when compared to the P wave. There was also a change in the cycle length thereafter and the change in the activation pattern with a change in the P wave morphology during the course of the recordings. So when you have a change in the activation pattern, a P wave changes during a focal atrial tachycardia, you need to localize a focal point of it early activation and map around that area, because activation away from the source may change depending on atrial disease, the engagement of the conduction pathways, and anisotropic conduction. Also the location of the origin, if it is septal or perinodal, and sometimes from the ligament of Marshall, there may be a change in the activation pattern that may be because of the changing exit points. So otherwise you can consider multiple circuits if there is scarring, and in these patients, if you have a changing activation pattern, 3D mapping needs to be done with care, because you need to be aware as to which points you are taking, because that may give you a mixed picture. And the window settings of changing cycle length also needs to be considered. So automaticity, if it is there, it may have a changing cycle length, especially a focal automaticity, which is very fast, especially from the pulmonary vein with varying exit to the atrium, may present with a changing cycle length of the tachycardia. Many times it turns out to be a non-focal tachycardia with a scarring and different tachycardia circuits engaging in tandem, and consider changing exit sites with delay with or within the circuit that may cause this changing cycle length. So example of a focal from the right superior pulmonary vein, wherein it's very high frequency output from the right superior pulmonary vein, which gets translated into the left atrium at a lower length. So there is a change in the cycle length of the atrial tachycardia. However, in this case, we wanted to go to the left side because now we know that the septum is early. The P wave morphology looks like it is from the left side superior pulmonary vein. So we wanted to go to the left side and see what was there on the left side. But it was difficult to do the septal puncture. We needed to tent the septum, and while tenting the septum, we noticed that there was a termination of tachycardia which was not happening even with burst pacing. And when we tented it for a longer time, the tachycardia terminated for a longer time. We checked it multiple times only to find the same result. However, the access was not there. So how do we go to the left side? So we thought of doing a cautery, and once we did put a cautery on the tip of this, exposed to around 2 to 3 millimeter, we can see that the tachycardia has actually terminated, not to start again. We repeated the same. There was some burst that was there, local activation, fast atrial signals, and thereafter there was quiescence. So there was a septum that was dissected, and the sheath remained there inside. There was no effusion otherwise. but the patient remained in sinus rhythm, and we tried inducing the tachycardia, and it was not inducible thereafter. The echo before and after showed that there was a atrial septal edema thickening, and the tip of the catheter, the septal puncture needle, shows some coagulation there. So post-cauterization of the atrial septum, the patient remained in sinus rhythm. There were a few atrial ectopics. The patient was continued on beta blocker, and there was improvement of ejection fraction. So cautery can be used to access the left side. Depends on the tip area and the watts delivered. The energy would be delivered in the local area to bring about hole into the atrial septum, in a difficult atrial septum. But there can be some coring, and there can be a thromboembolism. So though it has been considered safe to do a septal puncture using cautery, the shift has been to do it with radiofrequency needle under imaging guidance. So our case was an accidental ablation that occurred from a focal septal origin, which was possibly within the atrial septum itself, and we could actually burn that area by cautery while attempting to do an septal puncture. By embryology, as different what Dr. Anderson has described, that the atrial septum superior part is because of enfolding of the left and the right atrial tissues, continuing from the pulmonary veins on the left side and from the superior vena cava on the right side to form the superior part of the septum. And that may be the source of this focal automaticity in this patient. Another case wherein we ablated the tachycardia from the non-coronary sinus, again a focal atrial tachycardia, perinodal. And what you can see is alternate beats being lead to positive and negative with a change in the cycle length also in this scenario. Again, demonstrating that septal origin or perinodal origin may have different P-wave morphology. Lastly, this patient who had a different P-wave morphology even in sinus rhythm and during tachycardia, varying P-wave morphology, especially if you see in V1 and V2, it varies from positive, negative, negative, positive, and everything. Though the echo was normal, everything else was normal, we were in a fix whether to do an EP study. And when we did an EP study in this patient, we couldn't localize anything. There was no area of scar, and there was changing activation pattern. So patients who have a changing morphology, you need to be aware. These patients can have automatic tachycardia arising from maybe the mid areas, septal or the perinodal region. Medical management by beta blockers, but automaticity with changing cycle length, ivabradine may also be considered. Mapping and RF ablation and these kind of patients with changing P-wave morphology, you need to localize the site in comparison with the P-wave, reach the earliest site wherein changes are less likely to occur. Careful mapping and doing proper acquisition during 3D mapping system for activation and window settings need to be checked. RF ablation with multiple automatic focus may be difficult. Thank you so much.
Shomu, so what is the understanding for changing cycle length of an automatic tachycardia?
What people have described as it is a faster focus arising from some other place, and it is going into the atrium at different cycle lengths. So it's classically from the pulmonary vein high frequency power, high frequency stimulation triggered activity that goes out into the atrium. The second part would be that you have a slow conduction area with a double loop re-entry if it is a scar, or the conduction itself has been described to have an alternating change. But if you have a changing activation pattern also, then you have a problem, because the activation change would suggest that there are different exit sites also.
Okay. Sure. I think once again we are short on time. Is Ajit ready?
Yep.
Okay. Let's launch.
Okay. Does this come there now? Yeah, I think it comes there now.
Yeah, we can hear you. We can see your slides. You can.
That's great. So let's go. Thank you, Narasimhan sir. Unfortunately, I could not come there in person. So I'll just elucidate a few very basic principles that we need to keep in mind while ablating an atrial flutter, a non-CTA atrial flutter, using a case. So this is a 26-year-old male who came with dyspnea. He had hypertrophic cardiomyopathy, biventricular dysfunction, and EF of 25%. He had been well till few weeks back, and he was in what looked like either an atrial tachycardia or an atrial flutter, which obviously is coming from the left atrium by looking at those P-wave morphologies from V1 to V6, which are all positive. So he was taken up for an ablation, and in the lab we had the same tachycardia. So the basic standard things, you put a duodeca in the right side and a decapolar in the CS. You can see that the activation in the CS is from distal to proximal. So that is likely to be a left atrial arrhythmia, but you still don't forget the basic things. As expected, the right atrial entrainment was manifest, so no point looking at the post-spacing intervals. The high right atrial entrainment, it maintained the same activation pattern, but the PPU is very long, so obviously no point looking at that also. The CTH entrainment changed the activation pattern, so obviously no point looking at the post-spacing interval. The proximal CS entrainment also changed the activation pattern, so no point measuring the numbers. And finally, the distal CS entrainment preserved the activation pattern, but it was still out. So all we know is that we don't know any wiser than we are no wiser than the ECG. We know that this is an atria coming from the left atrium, and we also know that it is a flutter rather than a focal tachycardia because it is easily entrainable from multiple areas. So we know it's a left atrial flutter. Now, this particular one was not mapped with a high density catheter. So I'll give a few pointers on what to look for when you don't map with a high density catheter. This was mapped with a 20-pole duodecapolar. So now, this is the activation map. Now, if you look at the activation map, we had covered this flutter cycle length was 280. We had covered 270 in the left atrium. Obviously, it's coming from the left atrium. Now, if you look at this, the anterior left atrium, this is the posterior left atrium. You can see some gray areas. The gray areas are what I have called scar. Now, the first thing I want to make emphasize here is that there is nothing like scar. There is no fixed definition for a scar, especially in a diseased left atrium. It is what you think is a scar. Technically, scar is an area which you cannot capture at high output, but even the definition is, very subjective. But I put a scar here, and it makes a beautiful shape. It makes a beautiful pattern of a circle going up a scar. Whereas it makes a pattern of there is a spontaneous activation or simultaneous activation in the whole right atrium. But the thing is in the details. You can see that there is an activation wavefront that comes here, and is there another circle here around these pulmonary veins, along with a circle around this scar? And is this area a true scar? These are the 2 points that I want to discuss. They're very basic points, but they're very important to understand these things very clearly. So let's look at it. First up, verify all your points with the electrograms. Now, especially with today's automated mapping, I'm not a fan of automated mapping because you get thousands of points, many of them are wrong. So verify all the crucial points with the electrogram. You know that the early point is a genuine early point. You know that the mid point is a genuine mid point with electrogram timing. And you also know that the late point is a genuine late point. And because we took only 270 milliseconds, these 2 points are not overlapping and falling into the same window. So next up, this is the reentrant LAT map. Now, so that gives you the picture that, an early is meeting late, and that gives you the picture of a circle. But don't start with this map. Start with a standard map where you just assign points without making a LAT map. Now, once you put in a reentrant map, the system will somehow create a circle. Even if there is no circle, the system will try to create a circle. So don't start with a reentrant map. Just do a plain local activation map and then convert to a reentrant map if you think that there is a circle. The second most important thing is, what do you call a scar? Now, in this particular case, I have called 0.12 as a scar. The low voltage ID, the exact terminology might differ from system to system. I have called 0.12 as a scar. So these are the settings that I've used. I used a low voltage ID of 0.12, and I used the other important setting that he uses is an interpolation, 11 millimeter. That is between 1 point and 80 point, I've allowed the system to interpolate 11 millimeter. Now, especially if you're using not a high density mapping catheter, if you're using a duodecapolar catheter like I used in this case, one thing which you need to be careful before you proceed is bring it back to the least interpolation you can bring. Like here I made the least interpolation to 2 mm. Now 2 mm with a non-high density mapping catheter touching every 2 mm of the left atrium is not practical. It's going to take a long time. So one simple thing to do is bring the interpolation down to the least interpolation and then increase the interpolation to where the colors meet each other and make sure that the overall pattern doesn't change. You can see that here we don't have points across the whole left atrium, but you can see that the overall pattern has not changed. So take care of at least that much if you're not using a high density catheter. Whatever your interpolation, your overall pattern should not change. So this is 2 mm, that is 11 mm. There is no change in the overall pattern. The second thing is this thing of a scar. Now, I put 0.1 to as a scar here. Now here, I put 0 as a scar. So you should always start with 0 as the scar, which means you take all the points. But if you take all the points, you will find that it looks like it is going around this, but you can't see what it is going around. Usually you will expect reentrant circuits to go around a fixed boundary, which may be an anatomical boundary or a scar. So this map is far easier to understand because you can see there's a scar here. You can see there's a tiny scar here. You can see that there is a breakthrough point between the two scars. So immediately you are cued into thinking that, okay, I must go and look at this breakthrough point. But until you put in these two scars, you don't get this visual clue. But if you start by assuming a number for any of these scars, you will miss out a lot of information. So first start by putting your low voltage ID as 0 and then look at your map and put a number which you think makes sense. So in this case, you try multiple numbers and the number that makes sense here is 0.12. So use what you think is appropriate. Try increasing from 0, just go up slightly till you see a number that makes sense. There is no fixed definition to that number, especially in an abnormal part. So in this particular case, if I increase the scar definition to this much, so this is gradually increasing the scar definition. So the scar definition now reaches 0.15. Now, once I use a scar definition of 0.3, there is no map left. So there is nothing like which is appropriate. So this is 0.2. If you use a scar definition of 0.2, here this is 0.16. If you use a scar definition of 0.16, the map doesn't make any sense. So I want to emphasize that there is no fixed scar definition. What makes sense to you is the appropriate scar definition. And then you look at the propagation map. Once you've got these things clear, you look at the propagation map, and then you immediately get the idea that, okay, there is one scar here, there's another tiny scar here, and what drives this circle seems to be a gap between these two scars. But is that all that is there to it? No, there is something more to this. See, we talked about, it seemed to give the impression that there are two circles. One circle around the pulmonary veins on the right, on the left side, this is the pulmonary vein on the left side, and another circle on the right side through the scar. So you look at it again, it looks like there is one circle around the left pulmonary vein and another circle around here, which is mediated through this gap in this scar. So this circle seems to be okay. Now let us look at this circle. This circle, what is driving this circle? There is no scar here. No, it comes around here and it just turns around here. There is no scar for it to turn around. Even if I bring the scar definition all the way down to 0, there is still no scar here. So what is making this turnaround? If this didn't make this turnaround, this would be, you just need to ablate this particular area. But what is happening in this area? That will decide if it's a dual loop re-entry or if it is not a dual loop re-entry. So when that happens, pause point by point. There are two things you need to do. Pause the propagation map at each point and look at the electrograms at each point. So this is what I told about the scar definition. 0.12 seemed to be a reasonable working definition here. So using that reasonable working definition, now I look at the propagation map point by point. I start at one point. You can start at any point. So I started at this point where it is starting from the superior part near the left superior pulmonary vein. And there is one activation wavefront coming anteriorly, another one going posteriorly. Now just look at, this is just the next.
We are short of time, we need to conclude.
All right, okay. So, I will just tell this. This activation is stopping here, whereas this activation is breaking through here. When you see that pattern, go look at the electrogram where an activation stops. The electrogram where the activation stops shows this. Two components separated by more than 100 milliseconds, showing there is a line of block which is not present in sinus rhythm. So this is a functional line of block. So in sinus rhythm, there is only one component. So that's the second point that I want to emphasize. So look at functional lines of block and confirm that by looking at the electrogram. And then once you get this idea, entrainment was useless because entrainment couldn't capture. Once you get these ideas, you ablate what you think is appropriate. So these are the points that I want to take home. And I didn't isolate the pulmonary veins because I connected a scar to scar. He had an AF after 36 months. I had to go in back after 36 months and ablate the AF. So the things that I want to take home are use a scar definition which is appropriate. When you think there are functional scars, verify that by looking at the electrogram. And entrainment may not be always mandatory. Just connect electrically inert areas. Whether you want to do empirical PVI, it's a decision which you have to make on a case-by-case discussion. Thank you.
Nice case. We'll conclude this session. Next session, lead extraction symposium. We will have tea break of 5 minutes. We will reassemble within 5 minutes. Please.
Diagnostic method, and then you do. I do that. Then do it. It's unnecessary.
Friends, if you can join in, may I request the chairpersons for the next session to come over. Dr. Darshan, Dr. Krishnamohan, Dr. Sashikant. We need one more chair there. And Dr. Sai Satish. We have a internationally renowned faculty for this session on lead extraction. I would request Dr. Krishnamohan and Dr. Darshan to take over the proceedings of the next talk.
Thank you, sir. I think we're already behind time. So I'll invite Dr. Bridget. Is she with us online? Yes. Okay. We'll just wait for another minute for more people to come in. Yeah.
I'm here. Do you hear me?
Yeah. Dr. Bridget, I think we'll just start in another minute We can start. Okay, we can start. Okay. Dr. Bridget is very senior electrophysiologist who does a lot of lead extraction work. So I think we'll just get started with her talk and then we'll take questions after that. Thank you.
Thank you very much, and thank you very much for the kind invitation. I'm really, I feel very honored being able to talk to you. I'm a cardiac surgeon, by the way, and this makes it also sometimes a bit easier to talk about complications because I'm about able to resolve myself everything. But if we are talking about complications and how to prevent transvenous lead extraction, we have to focus one thing which is very important. Complications occur very rare in transvenous lead extraction in general. We are down to 0.5 to 0.6%, but if it occurs, it may be deleterious. So if we're talking about complications, most complications just begin with the implantation already. And if you see, I do have some aspects here, like vascular access. It is very well known that the cephalic venous access creates much less complications over time compared to the puncture. Furthermore, the choice of the lead is also decisive. If you have leads which are just grabbing into the venous system, especially into the coronary venous system, you shouldn't be able, or you shouldn't really perform any transvenous lead extraction with sheath in such leads. Furthermore, if we are looking at what is sometimes done over time with the leads, you see here was done some repair, which is something you shouldn't do because then you are the manufacturer of the lead if you do it. But also there are sometimes some sutures just put not at the sleeve level, but at the insulation, and this creates by itself an insulation problem. Furthermore, if we go to transvenous lead extraction, we have to make sure that we won't get into trouble while we do the operation. So I really recommend to have the lateral X-ray as well, not only the PA view, because then you can also see some misplacements like here, which is placed within the left ventricle. It was from the PA view, just something you wouldn't think about, but you saw really very easily that it was heading into the left ventricle, and this was affirmed later on by echocardiography. Furthermore, which is even I think much more common, is the misplacement in the middle cardiac vein. You see it here. It's very easy to find out this misplacement if you have the lateral view, but this is about not to be seen if you have just the PA view. There's some obvious things like here misplacement to the arterial lines. I think this is quite something you should see, but you have to have a chest X-ray and best a lateral view as well. Furthermore, it's important to point out that especially if you have CIED infection and especially in systemic infection, the dynamics of the disease may be really horrifying. This is an example of a 56-year-old male. He had a single tumor ICD 7 years just ago. He had dental treatment and got fever and shivering the next day. He was put on oral antibiotics from the GP and then was hospitalized after 2 days with IV antibiotics. The TTAE just was showing a 2-centimeter vegetation at the entry of the hospitalization, and within very few days it was getting up to over 5 centimeters, and you see here the vegetation is just within the whole atrium. It's about filling up the whole atrium, so the dynamics may be immense. So if you do see a vegetation, this is latest to send a patient to transvenous lead extraction. And even if there's no vegetation to be seen, if you have an infection in a patient with a CIED and bacteremia over time, then you have to think about just taking it out. One very important thing is abandoned leads. This is always the discussion how to do it. And I know that many colleagues just abandon the leads because they are not able in their centers to do transvenous lead extraction, and they do not want to put the patient on the risk for lead extraction. So this is an example of the 62-year-old male patient. He had a DDD pacemaker system implanted 15 years ago, and he required over time a single chamber ICD because he was having an atrial fibrillation over time, and he had an impaired left ventricular function. So the colleagues decided just to put a new ICD system from the left side and just abandon the leads. What turned out was a perforation of the part where the leads were just kept, and he was then set to multiple months of just conservative treatment, which is really something which is very dangerous because every time it may become a systemic infection, which is really also a lethal problem for many patients. Another example, which I think is even a little bit more impressive, this was a 35-year-old lady with a 4-year-old son. She got in 2005 back a single chamber ICD because of the Brugada syndrome. It was a Medtronic fidelis, which is known to be on risk for lead fracture. She got a box exchange in 2011. At that time, it was already known that the lead would have a shorter life expectancy. And finally, in 2017, in case of lead dysfunction, she just got an ICD and the right ventricular lead was abandoned. Since that time, she had discomfort and pain at the former pocket side, and you see what happened. She got a fistula. It were turned out with a small scar in 2020. Then she got a local revision. The lead was shortened, and you see the wound dehiscence and secretion even short time after the revision, and you see the scar is meanwhile really large in that very young lady, and the fistula reappeared. And this was just the case for many times. You see, over time, she got meanwhile third revision and fourth revision. Nevertheless, the lead was not really taken out completely, and so a reappearance of the fistula was always present. When she came to our hospital, she had this really very big scar here with, again, a fistula, and you see the chest X-ray, which is showing here, the abandoned lead, which was already, I think, many times they tried to just put it out by pulling, and so you see the lead has been destroyed in some way by the attempts just to pull. And this is something which should never be done. If a lead is abandoned, you should never pull and give a try, because then the inner lumen is destroyed and transvenous lead extraction becomes very dangerous. So in her case, we were thinking about what to take. We have two choices in general for these old leads, a mechanical rotational tool and the laser. In favor of mechanical rotational tool, it's a single lead, it's an ICD lead, it's a small and tall lady, so the flexibility of the tool is quite in favor. And she is a young patient where calcifications are very likely. On the other hand, we have a fragile lead, which was a Medtronic fidelis, and the lead has been pulled without inner lumen stabilization, which is in favor for the laser. In her case, when we opened up, you see here the findings. You see the lead remnant, fortunately, was long enough just to grab it and to see, and you see how the lead behaves. It's about stiff. It's the insulation is already fractured at many parts, and we were not able to insert an LLD properly. So this is something which makes all the procedure very, very hard. So in her case, after having this finding, we were, because of the fragility of the lead and the insulation defects, we went with a laser, and you see this is something which was, in her case, okay. But if we are able to use mechanical rotational tools, and you see it here, we have various techniques just to overcome some problems. One of the major problems is to overcome a very tight angle between the first rib and the clavicle, and this is very useful if you use the outer sheath just to stabilize the entry of the venous system. Another thing which we can do during the procedure to prevent any problems, especially if you have multiple leads, it may be that the leads are crossing over time if you just go further down. This is just to change the leads, and this is in favor just to overcome some problems if the leads are crossing. This is something you can really do very easily, not just staying with one lead, but to change in between the leads through the procedure. Further things may occur, as you see here, especially with a mechanical rotational tool. If you just prepare, it may be that the leads are crossing. You see, this is about cutting the lead if you just proceed. And so in those cases, we have to change the tool. This is now a laser, which is going through a little bit easier in this case. But if you have calcifications, it may become even necessary to exchange between those mechanisms as well over time. So something which I really recommend is also not to stay with the smallest possible sheath, because then you may enter into some trouble. You see here, we were trying to enter here this portion, and you see it with the insulation is a bit small because we pulled quite hard. Then we took a little bit larger sheath. We turned from a 14F to a 16F laser sheath. And you see, we had to do the entry again, and then it was much easier to overcome this problem which occurred here. And it is sometimes just getting some few millimeters further down, and you see the lead is just coming out because it was not fixed at the cardiac structures, but it was fixed by the very dense fibrosis at the epinephrine system, which is quite common. If we have an SVC tear, and this is one of the most frightening complications, and to be honest, if a complication occurs, this is related in 70% to SVC tear. We have some tools available like the super compliant bridge balloon, which may cover the perforation if you have placed beforehand a safety wire, and this is something I really recommend to do. This is a wire which comes from the femoral side to the right jugular vein, and it has to be placed before you do the operation, because afterwards, if the complication already occurred, you will not be able to place it in proper way. This is a picture I took 3 years ago. I had a patient with a perforation, and fortunately it was the last one I had, but nevertheless, we were able to not just get the perforation sutured, but we even didn't have to put the patient on the extracorporeal circulation, because you see the super compliant balloon was really filling out the whole perforation very properly. We were used to just have in a very bloodless portion of the SVC, we could just place the sutures very easily. And this is something I really recommend to do, especially if you have patients where you have a lead well time. I do it, to be honest, in lead well times over 2 years, but this is just really something you should apply to every patient you do, because you get a lot of time and you have a really proper hemodynamic stability, which is getting back within seconds. So thank you very much for your attention, and I will be happy to answer your questions.
Thank you, ma'am, for that wonderful talk. I just had one question. Every now and then we encounter patients who have devices implanted bilaterally and now who come with infection that's more like a pocket infection on one side. What is your strategy when you approach them?
Yeah, to be honest, you have seen perhaps the one patient where they have placed just an ICD on the left side and where was an infection on the right side. This was an old patient, and I was thinking about just taking everything out, but in his case, because he had not a systemic infection at that point, I was just taking out the pocket infected side, so both of the pacemaker leads, and antibiotic regimen, to be honest. I would also give some antibiotics over 1 week. In his case, there was no further CIED infection going on, so this was okay. And even leaving the ICD inside on the contralateral side, this may work in many patients. I'm not sure in all patients, but I couldn't recommend to take everything out at one operation in those cases. It's a completely different one. If you have systemic infection already, then you have to remove everything.
May I ask a question?
Sure.
Yeah. In the absence of the laser facility, is it permissible to do the lead extraction?
You see, I've shown you some examples where it's really valuable to have the laser available, especially if you have fragile leads or if you have multiple leads inserted. It's much easier in some cases to overcome those problems which may occur. You've seen it. Sometimes the leads are really fixed, they are adjacent to each other, and then it's really a high risk that you may have a lead fracture. I know that laser is very expensive, and especially if you have centers which are spread out widely. I think it may work in many cases that you just end up with a mechanical rotational tool in a very nice way. But if you know that you have fragile leads, if you know that there are that there may be some problems, as I showed you with the abandoned lead, which has been pulled already in a very bad way, then I would recommend to send the patient to a center where also the laser is available.
Is it advisable if one is inexperienced and he doesn't have a laser tool, upfront give it to the surgeon for the extraction?
Yeah, it's maybe better compared to just having any risk of whatever fears, because I could also think that in those centers they don't have a cardiac surgery available. So this is something I really recommend to have. So you have to have everything available at your hospital within very short time, which means the surgeon has to be on site with you, being able to perform everything, because even lead dwell time does not tell you anything about possible complications. I know that there is some risk scores out, but if you have a lead dwell time over 1 year, I would say it's really mandatory to have everything available. So if you have someone who's unexperienced, okay, I could think that if you have a lead which is inserted just 1 year, 1.5 years perhaps, then you can perhaps try it. But if there's any problem occurring, you should immediately stop and try to send the patient elsewhere. This is something which is really dangerous, and sometimes, even if the complication rates are low, but the complication rates are also low because you have, in at least nowadays, a very, I would say, small center selection, which is doing the extraction. I wouldn't really recommend to widen the spectrum of very small centers, unexperienced people. This is something which is not very nice. In doubt, it's always better to send the patient to a cardiac surgeon just for open heart surgery. But you see, transvenous lead extraction with a sheath is really less harmful to the patient, and means a very much shorter time of hospitalization and recovery time as well. So you should think about sending the patient perhaps to a center where everything is available with a laser or mechanical tools, in a setting where you have experienced people around.
Thank you.
Thank you.
Bridget, thank you so much for joining us, and truly appreciate. One common practice in India is when they are not able to pull out the lead, they cut the lead and at the pin level and leave it in the pocket. We strongly advise against it, but I would like your opinion on this.
Yeah, I can just, I'm fully with you, because just cutting the lead down is something which is really hard. I showed you the example of the young lady where the lead has been abandoned and also cut for many times. Sometimes the leads are really even cut down to the venous level, where you are about not able even to grab it and to get it for transvenous lead extraction. This is something which shouldn't be done at all, because then the patient is really, he has to undergo open heart procedure, which is in most of the cases definitely not necessary. So the recommendation would be not even to give a pull, give a try for pulling, but just to cap the lead. There are lead end cap kits available, and just to leave the lead inside. Best even submuscular, because if they are placed just at the subcutaneous level, they may get a perforation, or they may induce a perforation. But the recommendation is definitely not to cut down, especially not to cut down at the venous level.
Yeah, Bridget, one more question. Ashish Nabaria. Can you pass on some tips for extracting an old CS lead?
Yeah, this is something which is really also not very easy, because you're not able to pass through the coronary ostium with a sheath, with any sheath. I wouldn't really recommend to get into the coronary venous system with a laser or even a mechanical rotational tool. What I'm doing, if the lead is still stacking, and this is the case after about 15 to meanwhile about 20 years of dwell time, then you just have to wait and to manipulate sometimes the sheath within the right atrium, but never get down to the coronary venous system, because this is really paper thin. And most of the leads, they come back by time. If you don't get it back, just leave it in there. If there's no infection, you will be fine. If there's any infection, it has to be removed by open heart procedure.
Thanks.
Thank you, Bridget. That was a fantastic talk. And we thank you for your time and patience waiting while we are running a little bit late. So, congratulations. And we'll move
Thank
to
you
the
very
next
much. And I was really happy to have this discussion with you. Thank you.
Next, we would like to invite Dr. Sachin. Okay. So we'll call Andre for his talk next, please. Thank you.
Okay. Good afternoon, everyone. We reversed the talks, I think, for because Bridget was waiting online, so I'm going to talk about clinical assessment before lead extraction, and both from indication standpoint, from preparedness standpoint, before you take the patient to the lab. Okay. So basically, the seed implantation is increasing with time, including especially actually the ICDs. In the last 10 years or so, there has been an uptake more than 60% or so increase in implantation. And the leads also have been slowly reporting lower survival rates, ranging from 90 to 99% in 2 years, 85 to 95 at 5 years, and 60 to 70% at 8 years. And those are mostly related to the evolving design of the leads. They're getting smaller and smaller every time. There is a recent meta-analysis of 17 studies, close to 50,000 patients, showing that the failure rate is actually about 0.3% per year for the Quattro lead, close to 0.4% for the Endotac Reliance lead from Boston, and that's actually the highest for the Dorada lead at 0.45. On top of it, the incidence of seed infection is increasing with the number of seeds we're implanting. So we're seeing about 2 in 1,000 device years at the current rate. A seed infection clearly does increase the risk of in-hospital death, more than twofold. Just someone admitted with a hardware infection, especially seed infection, they'll have actually twofold increase in someone admitted with infection from any other source. The initial evaluation before extraction, there are two main indications, two main big categories of indications for extraction. There's the infectious indications and the non-infectious indications. For the when you're dealing with an infection, when the patient comes to the hospital, you need to really draw at least 2 sets of blood cultures before you administer antibiotics. This is extremely important, especially for our ID physicians. We send Gram-Stain culture for generator pocket tissue if it's available. We do a pre-procedural TEE is recommended for these patients, especially if you're suspecting a systemic seed infection. The TEE can be useful for patients with seed infections with or without positive blood culture. So there's this discussion whether you need to do TEE anyways if you have just a pocket infection, you don't have leading bacteremia. The Heart Rhythm Society kept a recommendation of 2A level for patients to get a TEE despite the fact they don't have bacteremias, even if they have a simple pocket infection. Because in one study, intravascular lead involvement was present in about 88% of patients presenting with just a pocket infection, so that's a pretty high rate. They also recommended sometimes using PET scan, which has a high sensitivity and specificity for device pocket infection. We all use ultrasounds and CT scans, and we rely on having a fluid around the pocket. But that has actually a very, very low sensitivity for picking up pocket infections. One thing that we do not recommend, and I've seen it multiple times and I've been called about it multiple times, is, hey, there's this swelling around the device. Can I aspirate the fluid? The answer is no. There's always no. Because if it's a seroma, which we've seen before, we've had referrals for extraction, and I look at the device, it looks like a seroma. We just give it time and monitor it pretty closely. These patients, you can introduce an infection and create an infection if you try and aspirate the pocket. Now, the risk of that happening is a little bit on the lower side. But just the chance of it happening, you'll change the patient from someone who potentially does not need an extraction to someone who definitely needs an extraction, and you increase the risk dramatically. So the recommendation currently is class 3 indication that a pocket fluid collection should not be aspirated empirically. The infection microbiology, the big winner obviously here, the most frequent one is the coagulase negative staphylococcus, followed by the rest of the gram positives and then some gram negatives. And the way we manage these patients depends a lot on the findings. It's very important to complete that evaluation before we take the patient for extraction, because it's going to impact, one, what we do during the procedure, and then number two, mostly, is what we do after the procedure. So if the patient has seeds pocket or systemic infection, we do blood cultures for infectious diseases consultation in the door. If the cultures are positive, we do TEE. If it's the valve vegetation, your antibiotic therapy is going to be longer, similar to endocarditis. If there is a lead in vegetation, it's somewhere in between 2 to 4 weeks. And if it's negative TEE, you can consider just a 2-week antibiotic treatment for just a pocket infection. Now, if it's negative blood cultures, the TEE, they kept it a little bit open as far as we use it on and off depending how old the patient or how frail the patient or he has any systemic signs of infection. But if it's positive, you go down to this decision tree. And if it's negative, you can treat it as only a pocket infection with an antibiotic treatment that's on the shorter side. Now, what bug you find in these patients also will affect your decision-making whether to extract these patients or not. And I want to stress on this. So if someone comes in with a bacteremia, but it does not have evidence of a seed infection, meaning the pocket is fine and you don't have vegetations on the lead. First of all, you look for a source. And this is a step that most people actually miss. We get a lot of consults saying, oh, we have bacteremia. The patient has a pacemaker, it needs to come out. But you look, he has a big abscess sitting somewhere in his thigh or in his leg. So he has a source. So we're looking here. This decision tree is made mostly for bacteremia of unknown source. So if you have a source, you treat the bacteremia and you see if it recurs. But if you have bacteremia of unknown source, there's no other reason for this bacteremia, then you look at the type of bug you're dealing with. If you have a Staph aureus, a Staph api, Propionibacterium of Candida, you need to remove the device no matter what from the first run of bacteremia. If you have alpha hemolytic strep, beta hemolytic strep, or enterococcus, you have the choice, because the data is controversial in this situation. You have the choice whether to remove the device or just treat it with antibiotics, see if it recurs, and then remove the device only upon the recurrence of the bacteremia. For gram-negative bacteremia and pneumococci, we know that you need to treat them because their recurrence rate is actually low. The predictive value of it is actually on the lower side. So for these, we know that you need to treat them with antibiotics first, give them a chance to heal with just antibiotics, and if they recur, then you remove the device. So with the indication of the extraction for the infectious side, It is recommended, like Dr. Oswald is saying, complete removal of the entire system, anything hardware. So just to summarize all these three first class 1 indications, if there's infection on any part of the system, whether pocket, whether leads, whether patches on the epicardium, the entire system, the entirety of the hardware needs to be removed, or else you're going to be dealing with fistulas like you're seeing and recurrence of infections. Even if you have endocarditis, signs of endocarditis without lead involvement, so if you have aortic valve endocarditis, the leads are clean, there's no vegetations on the lead, it is currently still a class 1 indication to still remove the device. So even if you don't have vegetation straight on the lead, the pocket is negative, you still need to remove the device. And for fungemia, the same things. The other thing to stress here is there's plenty of data currently that you will need to remove, not just remove the entirety of the hardware, you need to remove it within 48 hours. So this is a protocol we have now at the university. When someone gets admitted and needs an extraction, we treat this as an urgency or an emergency. We need to fit them in and extract the device within 48 hours of their presentation, because their mortality changes drastically if you wait more than 48 hours. You saw the example Dr. Oswald saw, where the vegetation is growing by the day from 2 to 5 centimeters. Their mortality increases drastically after 48 hours. So we always try to remove our devices within 48 hours of presentations if the indication is infection. Now the class 3s I would like to focus on is that it's not indicated if you have a superficial infection. We've had patients referred to us for extraction. You look, just the surface incision is infected, and you can see that because the pocket is pretty healthy and healed, and it's just at the skin level of limited cellulitis. Those patients you can actually save with an antibiotic treatment. We've done it many times, and you don't have to really extract the device. So that's a class 3 indication if there is no involvement of the actual device or leads. And for relapsing bloodstream infections, if it's relapsing, if you have a source of the bacteremia without involvement of the leads or the pocket itself, you do not need to remove the device. So this is what most people miss. They see Staph aureus bacteremia, they refer the patient automatically for extraction, but the patient has an abscess sitting in his thigh or sitting in his chest that's giving you these bacteremias. You don't extract the device without evidence of involvement of the device. Under certain circumstances, long-term antimicrobial suppressive therapy could be used, especially if the patient has a bad prognosis. So the individuals who are considered very high risk for extraction, for example, if you get a patient who is 85 years old, she's a stage 3 or 4 cancer, she's in a nursing home and she has a pocket infection, it's reasonable if it's not really affecting the skin too much, it's reasonable to use chronic antibiotic therapy. In most studies, chronic antibiotic therapy gives you about a survival about a year to a year and a half if you treat it chronically. So if the patient has a life expectancy less than a year, less than that, you can use chronic antimicrobial suppressive therapy rather than put them through the risk of an extraction, because you might shorten their life. So a patient very high likelihood of requiring surgical extraction with a higher mortality risk, inability to reimplant, loss of CRT with high-risk patients. Those are patients considered to be high risk. Not necessarily need to consider antimicrobial suppressive therapy for these patients, but when you remove the CRT, you have to be prepared. You have to involve the heart failure physicians when you remove the CRT, because they're going to decompensate, especially if they had shown a big drastic improvement when they had the CRT device implanted in the first place. And an ongoing risk of infection. So basically those patients, even if you remove the device and give them something new, they have a source of infection that's sitting there all the time that puts them at higher risk of infection. You have to think twice before removing the device in the first place. So for indications to remove the device and the leads without infection. So this is the non-infectious indications. So there are different separate categories, and you need to think about them differently. Currently, actually, they used to be most of them used to be class 2A indications, and now they moved up to class 1 indications in those circumstances. So if you have some significant thromboembolic events, a lead that keeps thrombosing and throwing PEs, that's actually indication for removal. If you have a planned stent deployment, and I can't stress that enough, please do not put stents over the leads. If you have someone who has planned, because it's a nightmare to remove you can't remove it basically. If you have a stent, we've had patients with stents in their baffles, that's a disaster. We have patients who have stents, subclavian stents, coated stents, because they have an AV fistula on one side. To treat the fistula, for those patients, we've gone as far as removing the entire system, putting the stents in if they're absolutely necessary, and then putting the stents through putting the leads through the stents on the new implant. SVC stenosis that requires necessarily related to the leads. SVC syndrome and life-threatening arrhythmias related to the lead. And those are extremely rare. Those we practically don't see that a lot. And most of the time, the life-threatening arrhythmias are happening because the lead is already loose. So those patients already don't need advanced extraction. I'll leave the class 2As for later. For preparation of the lead, obviously there's a preoperative visit for these patients. You have time. This is not an infected patient. You have time to sit with and discuss and have a long discussion about this procedure. We absolutely need to interrogate the device. We need to get every single lead detail possible with their parameters, their thresholds, what type of lead and what year was it implanted. And then all retained components around these leads. So some patients have capped leads, some patients have epicardial leads that go around. We get all the serial numbers before we really go into an extraction. This way, when you're in the pocket, you know which lead to extract, which lead to leave behind if you have to. We get all sorts of imaging. Absolutely, everyone needs a chest X-ray. You saw some examples, and I'll show you some more. Get a TTE echocardiogram to know what your function is, to discuss reimplant strategy. Venogram to know whether your shoulder is open or not. That's very big issue during the explant procedure, because if you have someone that has total occlusion of the ipsilateral vein that you're extracting, and you need to reimplant that lead, you have to grab the lead from the groin. So you have to do a double extraction strategy where you go through the groin, you hold the lead, you extract over it. Once you cross the obstruction, you release the lead from under, and then extract the lead, and after that, pass the wires through that obstruction that you just opened. Those leads, if you don't grab them from below, they can slip through the obstruction and you lose your access to the vein. So if you want to keep your access on the vein, you have to snare these leads from below. And then finally, cardiac CT, and I'll show you some examples. It's invaluable. We do non-contrast cardiac CT. Sometimes we do contrast and non-contrast for the same patient to define the course of the lead and risk stratify the patient. Why do we want to know every single detail about the leads before we go in? Because that changes your extraction strategy. This lead is known to be a nightmare. To see the exact same picture in both my presentation and Dr. Oswald's presentation tells you a lot. You can have a CS tear when you extract the leads in 15 to 17%. And if you talk to any surgeon in the room, having a CS tear is way worse than having an SVC tear. SVC tear is anterior structure. You can get to it fast. You can repair it fast. And if you have a balloon, safety balloon, which we use 100% of our cases, you can save someone with an SVC tear. CS tear, that structure is in the back. You can't repair it. It's open, wide open to the heart. And mortality from CS tears is higher than SVC tears. The 3830 lead has special consideration. It's a great lead to extract if it's young. It can be more challenging if it's older. We don't have 30-year-old 3830 leads implanted yet, but that lead, although takes a lot of delta, more delta than the usual lead, so a regular delta on usual lead, pull and push is about 5 pounds difference. You can extract the regular lead, and if you have a delta more than 5, you can start breaking those leads. For the 3830, studies have shown that the delta can go up to 7 or 10 pounds. So this is a beautiful lead to extract from that standpoint. The other problems with it is the tip can stay behind. It can break easier too, especially if it's kinked. So if you have angles on the lead, the conventional leads actually will be more favorable for extraction than this one. But for the younger leads, I've extracted leads 7, 8 years out with just rotating and pulling. So this is a beautiful lead to take out. Riara leads are a nightmare too. They have snow plowing, especially if you have exteriorization of the conductors, because you're pushing those conductors when they exteriorize out of the lead. All this builds up a lot of scar, so it thickens the lead. The effective diameter of the lead is effectively increased significantly over your extractor. So you can snow plow these leads, and a lot of times they come out in pieces. The fine line leads and longevity leads have a special problem with them. especially the fine lines, is that they're very thin, and their core is very flimsy and not very attached to the core. So if you're locking the lead from the inside and pulling on it and pulling and pushing, you can pull the entire core out and you leave the silicone sheath in. And that's a disaster if you're extracting an infection, for someone for an infection. Why? Because you really need to remove that silicone material out of the bloodstream. What you do with that is you put the locking stylet in, you go in from the groin, you snare the lead distally. You actually snare it hard enough to kink the locking stylet inside of it. So as you're extracting, the core and the snare stay together. And then as soon as you get close to your snare from the groin, where you cross the entirety of the lead, then you remove the snare, and you'll have only a small piece of that lead to deal with, and you can extract it much better that way, keeping the whole lead together all until you get to the tip of that lead. It's very important to know whether you're dealing with these or not. And for those, you never take the pin out. So the original pin keeps the lead together on its entirety. So for those leads, we don't cut the lead. We don't cut the pin. You leave the lead. You just shave it enough to fit into your extractor, but you don't cut it. X-ray is very important because you need to know this, for example. Is this something extractable or not? We dug deep into the vein. We've had sometimes a surgeon help us to take the tip, but sometimes you simply can't reach them. So you need to know whether you have a situation like this where you can't reach the lead at all, and you'd have to have either a hybrid procedure or a full surgical procedure to remove the lead. This is the one I just did the last week before I came here. When you see this and you see this beautiful rings, you should be scared. Although it looks innocent, this is the Starfix lead. So this was a 12-year-old system. He has a 12-year-old and a 10-year-old lead here with a Starfix lead. We just removed it, luckily, with no problems. All 4 leads were removed for this patient. But when you see something like this, you need to prepare yourself for a long haul. The CT scan is very important for our assessment of risk. We do a non-contrast CT scan, for example, like this, to track 2 things. One, whether these leads are within the lumen of the SVC or stuck on the lumen of the SVC. For this case, for example, clearly you see the lead floating in the middle of the SVC and they're not touching the lateral wall. The other thing we evaluate is how many leads clumping together. The more leads clumping together and sticking together, the higher your risk. So this is actually considered a low-risk case. This, on the other hand, you see the leads stuck to the SVC side, both on the inside and the outside. The inside is less dangerous, but the outside is what your really danger zone is. And you can see here much closer, there's the upper part of the lead stuck to the SVC. This one is extremely high risk. Not only does the lead stick the entirety of the SVC here, it's stuck to other leads, and it might have right here an extravascular course. This is why when we start our extractions at the U, we put ice, a circular ice from the groin up, and we start from the innominate, and we drag it down, and we record the entire track of the lead to see if that lead is extravascular. If you have an extravascular lead, you have to have a surgeon. What we do is we have a mini thoracotomy go on the side with a scope going in to watch actively how the extractor goes over the lead. And if the extractor starts signs of exteriorization, we stop there, we open the chest, and we do the rest of the extraction through the RA. So what we do is we open, we remove the rest of the lead that we liberated down to that level, and I leave a piece for the surgeon where they can take it from the RA, and we can put the extractor through that opening that they created and extract down from the RA in a hybrid procedure through the RV and take the rest of the lead out. It's much safer than cutting the SVC open in these cases. So preparation, we always talk about technical issues, define extraction approach, define post-extraction plan. That visit is extremely important to talk about all these things. And finally, I stress on this thing, and I'm going to finish with this, is you need to include family in this. It is a point, I always quote my patients about 1 to 1.2 risk of bleeding. There's a 0.5% risk of death on the table. Death on the table meaning you need to talk to the family to know that what they're getting themselves into. So especially for an elective extraction, you need to have everyone on board knowing the risks before you go in. Thank you very much.
Thank you, Dr. Henry, for your wonderful presentation. Now the topic is open for discussion.
with so many warnings and red flags that you raised, in your practice, how often do you extract redundant leads? Purely for redundancy, how often do you venture into this?
Great question. So the redundant leads, meaning if they're functional. Yeah. We almost don't, never, unless they're extremely low. So if they're less than 3 years old, we tend to extract them. But if anything beyond 3 years, we cap. We have a strict policy, functional leads that are older than 3 years, we don't touch. Because it is absolutely not needed risk that you're subjecting the patient to. So we don't. There are centers that actually extract everything. And that's probably where that question is coming from. We don't follow that policy.
There is a question from Dr. Shomu online. Basically, he asks, how would you know that a superficial infection is going deep towards the CIED?
Yes. So usually if we manipulate the pocket a little bit, and you see the color of the skin itself, it's not too dark, it's not too deep, there's no pus coming out of it. And then sometimes you see a good reason for the skin infection. Number one reason I've seen coming from other centers is why I banned that practice in our hospital is Dermabond. Especially if you don't apply it correctly, people come and put the Dermabond on the skin and it goes in between the two layers of the skin. You need to really approach the skin before you use it. And it hinders the healing and it creates a superficial skin. So to touch the color, if you're pushing on the pocket, you're not expressing anything out of it. The rest of the pocket looks good. You have a good reason on the incision site itself, then you know you're dealing with a superficial infection. But even if you're realizing this, when we treat them, we follow them not in a month, we follow them in a few days, just to make sure everything is evolving the right way. Usually I typically see them in 2 to 3 days if we make that decision.
Sometimes on the CT you see the RV lead perforating through.
Yeah.
So how do you approach those?
Great question. Great question, Darshan. So I used to worry about it way more than now. With more experience with this field, so I used to look at two things, the SVC relation and the tip. You'd be surprised how many leads are barely exteriorized through the RV apex and they do fine when you extract them. That has been less of a worry now because every time I see it, it never really got us into trouble. Unless the lead is expressly out of the RV. So if you see just the pin barely out of the RV, those are usually not too worrisome. Unless the lead is really through the RV with changes in electrical parameters, then you prepare your surgeon. Even with that, somehow we manage not to get in trouble with it by taking it. But our surgeon, by the way, is, like they said, is not in-house or in the heart, is in the room with us. So when we extract, during the time of the extraction, I call the surgeon in, they're sitting with us. So for these cases, we want them in the room with us too when we extract.
Okay. In case we have no other questions, I think we can end the session here. Tom, thank you, Dr. Lucas.
Yeah, the session closed because we are running too late, so the other talk has been now cancelled. Thank you. Now I think we'll break for the lunch.
We'll break for lunch. Because we're really running late, I would suggest we're going to shorten the lunch break for half an hour. We would like to assemble after half an hour.
The cobalt and chrome portfolio was developed because we wanted to drive innovation forward.
A lot of these features have been in development for many years, and we're now bringing those to our customers for the first time.
Cobalt and chrome bring an entirely new battery technology to the market.
40 joules delivered energy right from the very first shock and extended longevity.
The cobalt and chrome portfolio will be the first to showcase our intrinsic anti-tachycardia pacing algorithm.
We've done a great job reducing inappropriate shocks. We thought there was more opportunity to reduce unnecessary shocks, and IATP will help us do that.
IATP is a dynamic and self-learning algorithm that really looks at addressing why did ventricular ATP fail, and then tailoring or customizing that approach for each and every episode on each and every patient.
It's taking a look at each of these individual arrhythmias, figuring out how fast they're going and how far they are, and adjusting the pacing pulses and how frequent these pacing pulses should be delivered to maximize the likelihood that the arrhythmia will be terminated.
Managing heart failure in device patients is a really big challenge. A lot of these patients will go on to heart failure admissions, and there's really no great way of identifying those. That's frustrating for the patient, and it's expensive for the healthcare system.
So on the cobalt and chrome portfolio, this is the first time we will be showcasing the triage HF feature. By using some of the metrics that the devices are already collecting, we're able to incorporate this into an algorithm and give them a predictive model.
Triage HF provides information to physicians in a more streamlined manner, helping them direct their care to those patients who need it most.
Triage makes the process simple and automatic for our customers.
Cobalt and Chrome have reimagined connectivity, bringing that BlueSync technology to the high-power portfolio.
By having MyCareLink Heart on the cobalt and chrome portfolio, the patients now have a direct link to their devices.
SmartSync, utilizing the tablet-based programmers, brings the patient and the clinician a lot closer together.
We're now able to speak to them, show them what we see on the programmer so that they are actively engaged in the process of taking care of themselves.
The future is here no matter where you are, in the lab, in the clinic, or in the patient's home. We listen to our customers, and we have delivered innovation to help the customers meet their needs.
Because this is not only innovation from a device perspective, but it's innovation in the way we deliver healthcare and maintain health for our patients.
The future is here, and we have a great opportunity in front of us with Cobalt and Chrome.
cobalt and chrome portfolio was developed because we wanted to drive innovation forward.
A lot of these features have been in development for many years, and we're now bringing those to our customers for the first time.
Cobalt and Chrome bring an entirely new battery technology to the market.
40 joules delivered energy right from the very first shock and extended longevity.
The cobalt and chrome portfolio will be the first to showcase our intrinsic anti-tachycardia pacing algorithm.
We've done a great job reducing inappropriate shocks. We thought there was more opportunity to reduce unnecessary shocks, and IATP will help us do that.
IATP is a dynamic and self-learning algorithm that really looks at addressing why did ventricular ATP fail, and then tailoring or customizing that approach for each and every episode on each and every patient.
It's taking a look at each of these individual arrhythmias, figuring out how fast they're going and how far they are, and adjusting the pacing pulses and how frequent these pacing pulses should be delivered to maximize the likelihood that the arrhythmia will be terminated.
Managing heart failure in device patients is a really big challenge. A lot of these patients will go on to heart failure admissions, and there's really no great way of identifying those. That's frustrating for the patient, and it's expensive for the healthcare system.
So on the cobalt and chrome portfolio, this is the first time we will be showcasing the triage HF feature. By using some of the metrics that the devices are already collecting, we're able to incorporate this into an algorithm and give them a predictive model.
Triage HF provides information to physicians in a more streamlined manner, helping them direct their care to those patients who need it most.
Triage makes the process simple and automatic for our customers.
Cobalt and Chrome have reimagined connectivity, bringing that BlueSync technology to the high-power portfolio.
By having MyCareLink Heart on the cobalt and chrome portfolio, the patients now have a direct link to their devices.
SmartSync, utilizing the tablet-based programmers, brings the patient and the clinician a lot closer together.
We're now able to speak to them, show them what we see on the programmer so that they are actively engaged in the process of taking care of themselves.
The future is here no matter where you are, in the lab, in the clinic, or in the patient's home. We listen to our customers, and we have delivered innovation to help the customers meet their needs.
Because this is not only innovation from a device perspective, but it's innovation in the way we deliver healthcare and maintain health for our patients.
The future is here, and we have a great opportunity in front of us with Cobalt and Chrome.
Hello. Hello.
Friends, we go on to a very important session which is on sudden cardiac arrest. Despite what we do, that's what we want to prevent. And to chair this important session, can I just request Dr. Sagar, Dr. Kumar Narayan and Dr. Ulas to take over and be the chairpersons for the next session.
Good afternoon, everyone. We'll start off this session on sudden cardiac death, a very important topic. So, the first talk is by Dr. Deepak Padmanabhan from Jayadeva, who will talk to us on ECG markers of sudden cardiac arrest.
Thank you for the opportunity to present before you. This shall be a little bit of a whirlwind talk, and I don't think I'll be able to cover everything, but just let me know when I need to stop. The objectives of my talk are basically to talk about the problem statement of sudden cardiac arrest, the futility of using ejection fraction as the only predictor, what are the ECG-based markers for cardiomyopathies, channelopathies, repolarization abnormalities and their uncertain relationship in predicting cardiac arrest, what is the role of data analysis, and finally, clinical workflow integration. The problem statement, as we very well know, is sudden cardiac arrest is definitely more common as a percentage in people who have cardiac disease, but by the sheer number of normal people that we have, the very fact that it happens lesser in those people, but the burden of that is higher in the general population and is a devastating consequence. The ejection fraction in sudden cardiac arrest association in patients post-MI, if you look at the ejection fraction, it actually comes down way down. Before history of heart failure, patients enrolled as inpatients or outpatients. This is from the MUST trial. If we look at across the group, ejection fraction does not really form the only sole factor. And in fact, in 2018, Marwick et al. Used this decision tree to actually tell us what was the proposed decision process about when to trust and distrust ejection fraction. Kumar wrote a beautiful review in 2015 where he discussed about the sudden cardiac arrest thought processes on the basis of ECG, and fundamentally divided into two parts, the depolarization abnormalities and the repolarization abnormalities. Most of electrophysiology goes about in talking about the depolarization abnormalities, and as such one of the most prominent depolarization abnormalities that we see on an ECG is myocardial ischemia. Very important to know the changes of myocardial ischemia both in the acute stage as well as in the chronic stage, where there has been remodeling and persistent ST elevations suggesting an aneurysm, which are very big predictors for sudden cardiac arrest. Similarly, Q waves which signify prior myocardial infarction are extremely important to recognize because they portend an abnormal myocardium which can form the substrate for ventricular arrhythmias leading to sudden cardiac arrest. One of the more commoner causes and probably thankfully rare cause of sudden cardiac arrest evidently seen on the ECG is the presence of a pre-excitation syndrome where the accessory pathway can form the formae frustrae, the mechanism of which is slightly unclear at this point in time. Left ventricular hypertrophy with the strain pattern also indicates a predisposition to the same, as is the cardiomyopathy which is inherited, namely hypertrophic cardiomyopathy. Its prevalence is 1 in 2,000 to 1 in 200 to 1 in 500, but probably it's underreported, more so in patients who do not show this classical ECG with the repolarization changes. Critical to remember the differences between the strain pattern as well as ischemia, where the coving is very critical. One more important thing to understand or probably realize is the presence of fragmentation on the ECG. The Purkinje network is a high-speed network. There cannot be any deviations on that. If you see fragmentation on the ECG, we need to stop and think as to why it is happening, and it can actually happen because of abnormalities in purely the electrical conduction system, or it can be abnormalities in more than the electrical conduction system, namely the myocardium. The presence of the same bundle branch block abnormalities with and without the fragmentation is a portent for sinister outcomes. It's not necessary that this particular fragmentation is present in the mid part of the QRS. It can be in the terminal part of QRS, where in various cardiomyopathies we've seen it, namely ARVC. One of the common causes of sudden cardiac arrest in the young and still an enigma is the presence of mitral valve prolapse. A subselector for higher predisposition to sudden cardiac arrest is the presence of the T-wave inversion in the inferior leads and complex ventricular ectopy. Although the estimated risk is 0.14 to 0.22 events per 100 patient years, but the very fact that this can happen and can happen in very young people is something that needs to be recognized very early. Again, patients with fever presenting with ECGs suggestive of these complex ventricular ectopy with varying morphologies probably originating from the vascular system are also forming a good substrate for underlying perhaps myocarditis and thereby leading to sudden cardiac arrest. Going on from there to something that is more of a channelopathy kind of a problem where the channels themselves are abnormal, the ionic channels are abnormal, and when you start seeing this bigeminal pattern, especially on exercise testing, which can then form the bidirectional arrhythmia, is a marker for CPVT. It's not only tachycardia that is there, even bradycardia can actually start a abnormal rhythm. So the presence of even bradycardia dependent bundle branch blocks giving adenosine, and then you have the long pause which can itself predispose to sudden cardiac arrest. QT prolongation. I like to call QT as my fifth vital because along with temperature, pulse, blood pressure and respiration, it's one thing that can cause sudden death or predisposition to sudden death in a very short period of time. Correct measurement of the QT is critical, and even in T waves which are biphasic, knowing where to measure that QT gives you a great deal of success in being able to predict an abnormal event in the near future. QT prolongation has three types, the LQT1, 2 and 3 subtypes. Depending upon what the underlying ionic channel defect is, and a high index of suspicion to be able to recognize this is critical. It may not always be evident on the standalone ECG. Provocative maneuvers to bring it out may also be critical, especially with a high suspicion of the same. T-wave lability, QT interval lability is again a very important concept, especially when there is a slight tachycardia going on. Recognizing that as a marker for sudden cardiac arrest in these patients may also be very important. We all get very beautiful Holters these days. What we don't look at on these Holters is probably the heart rate variability and the QT analysis over a period of time. Concentrating on that, looking at the QT dispersion is a very important thing to understand what is the dispersal of the repolarization across the whole day and whether it predisposes to someone who's having likelihood or who is predisposed to having episodes of cardiac abnormality or ventricular arrhythmias. A lesser known but recently reported factor is the T peak to T end time duration. It is known to have some benefit in being able to predict malignant ventricular arrhythmias, but some more data is required on it at present. Provocation maneuvers to diagnose the channelopathies are various, including epinephrine, isoproterenol. Then you can actually give flecainide in order to pick this up. But one interesting thing is the actual increase in the burst exercise testing whenever we are considering screening for a patient with CPVT, where the routine treadmill may only show the arrhythmia late in the course of the exercise testing, but the burst testing may actually show very early. The J-wave syndrome spectrums include both the Brugada syndrome, where the T-wave is actually, the J-point is elevated, giving you a channelopathy secondary to sodium channel abnormalities, and going on to the less understood early repolarization syndromes, which actually pick a predisposition to sudden cardiac arrest, but what is the predictive value, what amount is going to happen, is something that is unclear at this point in time. To contrast it from other causes of a right bundle branch block, namely the isolated right bundle branch block, the Osborn waves, the pulmonary embolism right bundle branch blocks, as well as the myocardial infarction ones, is very critical to understand the substrate. Going on from here, this looks like a lot of work in terms of understanding what that QRS does, what the depolarization does, what the repolarization or the J point does. Perhaps we can simplify it for a lot of people, and that's where the use of ejection fraction assessment by automated AI algorithms comes in. If we are able to diagnose asymptomatic LV dysfunction, perhaps there exists a way for us to be able to screen these patients better and diagnose them better. Similarly, reduction ejection fraction across populations, both within the population in which it was tested and in population external to which it was tested, is also very important. Using these algorithms onto digitized mechanisms, like a stethoscope, for example, can allow us to diagnose these patients better. Using the same, diagnosing peripartum cardiomyopathy or the prediction for the same is also something that was recently tried and has shown reasonable success. Going on from there, ability to diagnose coronary artery disease very early beyond this room in the general population by practitioners who may not be very skilled at doing the same is something that we need to look into, and that itself might play a big role in being able to diagnose sudden cardiac arrest predispositions. Calculation of QT interval. Again, as I documented on that slide, calculation of the QT interval is very important, but it may not be a skill that is acquired by everybody. So automated ways of calculating QT interval, AI/ML directed calculation of QT interval, and use of AI/ML algorithms to diagnose genotype positive but phenotype negative long QT syndromes in QT1 and 2 are important ways to be able to screen patients who are relatives of patients with manifest long QT syndromes. At the very end, I'd like to bring about this concept of vascular age. This is probably something based out of an ECG, which may actually change the way we think about susceptibility to sudden cardiac arrest over a period of time. This is essentially an ECG algorithm that tells you what is your possible biological age as opposed to what your chronological age is. And it was recently checked in patients who undergone cardiac transplants. So if these patients who received cardiac transplants, if the donor had a vascular age which was high, these patients actually did worse. If the donor had a vascular age which was low and the AI-derived vascular age for this patient was higher, those patients did badly. If within a year of the transplant, if the vascular age which was detected by the AI algorithm rose, those patients had more rejections. So probably they are on to something here that needs further evaluation and investigation. Also, this will also help us understand better what the pathology of the disease is. Take, for example, this study, which actually showed us the PVCs that could predict heart failure and perhaps sudden cardiac arrest. But when you look at the explainability algorithm out there, it was not the PVC that was important. It was actually the QRS and the ST segment that followed the PVC that was maximally used by the algorithm to predict these outcomes. There are a bunch of algorithms available in the market as well as within our country. We need to evaluate them in our setup to make sense of what it is useful for. At the final end, we can actually create a risk profile for every patient if we are able to use this and look at how that risk profile changes over time to better help these patients understand what is going on. So unless we have a solution for all of this, the only solution seems to be to know CPR so that we can have herd immunity against possible sudden cardiac arrest. In summary, therefore, I like to conclude by saying it is the most easily recorded biosignal, that is the ECG. It gives us a global view of cardiac health. Experience-derived sudden cardiac arrest risk markers have been discussed here in short, but data-driven markers may exist. We need to see beyond the veil of human experience and democratize this screening, especially for a condition as serious as sudden cardiac arrest. And finally, before accepting anything, we need to analyze and validate the clinical applications of the same. Thank you very much.
Thank you very much, Deepak, for that very nice and quick overview and touching upon AI as well, which is becoming very important. So just a brief comment. I think you tried to cover everything, of course, but I think broadly we can talk about those markers which are very phenotype specific. If you are taking HCM or channelopathies, that is a little more clear cut at this point of time, and we know how to approach that. What is more difficult is the common SCD which occurs in coronary artery disease. And there are a bunch of markers have been studied, but none has really been proved so far good enough for clinical application. Absolutely.
My question is on commonly nowadays we see many patients, they ask about whenever there's a PVC, what is my risk of getting certain cardiac arrest? What is your input? Because PVC is very commonly we see in.
I'd like to consider PVCs into two broad groups, outflow tract PVCs and non-outflow tract PVCs. The moment you say outflow tract PVCs, you already know that they are benign or probably benign. We really don't know very well in long term what's going to happen. Non-outflow tract PVCs, I like to investigate them further for why they are coming, where they are coming, and perhaps looking at longer term monitoring for these patients, looking at what their coupling interval is of that non-outflow tract PVC, looking at whether it's starting off a run of some kind of non-sustained VT or complex ectopy. I think that is what will drive how we investigate that patient. Any non-obstructive, non-outflow tract PVC, I like to definitely get the structural evaluation done and rule out inflammation. But beyond that, the way to risk stratify that patient for sudden cardiac arrest is something that I don't really understand very well at this point in time. Maybe over a period of time, we may get algorithms that tell us how to understand these PVCs better, but in the absence of any structural abnormality, close watch, understanding what complex ectopy is, making sure that there is nothing like a mitral valve prolapse or a scar in the region of the non-outflow tract location of where the PVC is coming from, maybe are only ways to evaluate these patients.
So, Deepak, are there any questions? Okay, I have a question for you. See, the T-wave alternance in the context of the long QT is a marker of a higher risk, all right? What was that mechanism you quoted, the association with when the rate is a little faster? Why it should impart higher risk? What is that mechanism?
Sir, I'd like to think that whenever the long QT syndrome exists, it depends upon which type of long QT you're talking about. Long QT, it is not only the T-wave changes that are there. It ideally indicates an absence. It's a dispersion of repolarization that occurs throughout the myocardium. So when you have a faster heart rate, if your dispersion is higher, or when you have a slower heart rate, your dispersion is slower, that actually increases myocardial inhomogeneity on the repolarization, which is what I think is the marker for sudden cardiac arrest in these patients.
So that's what you think, right?
Yes, sir.
All right. Are there any more questions? So thank you, Deepak.
Thank you, sir.
So now, the expert in sudden cardiac arrest, the man himself, it's my pleasure to invite Kumar Narayanan. Now he's going to speak about what's new in SCD.
Thank you. Thank you for this invitation, Dr. Narasimhan. And I'll quickly go through what's new in SCD through the prism of the recently concluded Lancet Commission in which I had the opportunity to work. And I'm really going to talk about how SCD paradigms are changing. So SCD is estimated to be responsible for about close to 5 million deaths every year, and it rivals some of the top cancers across the globe in terms of contributing to mortality, which is why the Lancet felt the need to constitute a commission on this and to try and lay out what directions future research should take. So we have worked on it for close to 3 years, which culminated with the publication last year, corresponding with the ESC 2023. And if you look at one of the features, if you look at all the commission authors, over 30 of them, they are drawn from a wide variety of disciplines: cardiology, EMS, pathology, genetics. We had physician assistants, we had genetic counselors, forensic people, epidemiologists. I think the realization is increasing that especially at the population level, if you want to deal with it, SCD is really a multidisciplinary puzzle which involves a lot of different expertise involved in order to give the best outcomes to patients. And we conceptualized this in the commission through the SCD circle, where we really thought of it as before the event, pre-SCA, where you would like to effectively predict and then prevent the event if possible. Then a very crucial piece where probably the most advances have been done so far, peri-SCA or around the event, where we really like to maximize survival through efficient resuscitation. And lastly, an often forgotten piece, which is post-SCA, where we need to address the needs of the families of dissidents as well as looking at the effective management of survivors. So the first key message is that really we need a multidisciplinary approach and collaboration if we are to make a significant dent in SCA. And probably there is a role for specialized SCA teams, a direction in which some of the Western countries are already moving. The second point, if you see from a population level, if you really want to estimate SCD burden, it's very important to have properly done epidemiologic studies. And this is a situation where especially the developing countries are lagging behind. So another message is really the need to have well-conducted population-based registries. This is logistically difficult in many parts of the world, but something where we need to work towards so that we can get an idea of the burden and take policy decisions. Another fundamental problem with SCD research, which we have been grappling with for a long time, is that SCD, if you take it, is really a mode of death. It's not a specific disease, it's not a specific phenotype. So what we understand when we talk sudden cardiac death, we would really like to think of arrhythmic death from a cardiac point of view, something which we can prevent with an ICD. Unfortunately, the way the WHO definition of SCD is, it just talks about a person collapsing suddenly with no obvious extracardiac cause. So those are really presumed SCDs. And in the absence of a proper post-mortem toxicological evaluation, many of them may be neither arrhythmic nor they may be even cardiac. In fact, certain studies which have really looked at properly autopsying most of these cases, such as the post-SCD study from San Francisco, has shown that out of the WHO defined SCDs, almost 40% can be non-cardiac. So you can see how you can take this heterogeneous bunch of patients and try to identify risk signals in them. You're not going to really do a proper job. So this is a gap which needs to be addressed. This is made difficult by the fact that annually the global autopsy rates are falling, not only in the developing countries where it's much more lagging behind, but even in the Western societies, autopsy rates are falling, and this is something which is concerning and needs to be addressed. Because really for a better prevention, we need to better understand mechanisms and phenotype at a better level in terms of autopsy, in terms of having blood and potentially tissue for genetic analysis in order to uncover newer mechanisms. So another key message is that really there is a need to strengthen autopsy practices with better availability, especially in relatively younger people who are more likely to have a cardiac or an arrhythmic cause. And a lot more focused research on autopsy substitutes need to happen because practically autopsies are difficult in many parts of the world. So to decrease SCD burden, if we look at, we really have two broad arms. We have resuscitation aiming to improve survival after the event. It's not the ideal approach, but right now that is where we are probably the most efficient at, especially in some of the Western European countries. And then prevention, which we will discuss briefly. If you look at resuscitation, what we have demonstration of in certain specific settings, especially in sports-related SCA, if you take it, that if done properly and promptly, it can make a dramatic impact. And in some of these specific settings, you have survival after SCA ranging anywhere between 40 to 90%, which is very impressive when you consider the less than 10% survival which you have in the general population. And we haven't made much of an impact on this in the last decade or so. There are a lot of significant remaining challenges here because many SCAs are unwitnessed. The witnesses may not really know what to do when they witness an SCA. There is a problem with AED availability in many parts of the world. And overall, epidemiologically, VF as a rhythm is progressively coming down, which is what best responds to SCA. So just as we have fire extinguishers in many parts, we need to have the same mentality for AEDs and start making them available. So access to AEDs as well as regular training in the community for CPR, a lot of awareness needs to be raised for that. And we also need to improve the quality of our AEDs to include features such as geolocalization and communication with EMS centers. All of this technology already exists actually, it just needs to be implemented with political will. Even in terms of training for CPR, a lot of countries have developed apps now for citizen responders, which really connects people and alerts them in case of a nearby SCA, and all of these initiatives have been shown to make a big impact. So if you take the other arm, which is prevention, that is what ideally we should do it, but right now our aims at prediction and prevention are not very good. We have significant challenges. Some of the major ones are, as alluded by Deepak, most of the SCA occurs in the general population. The major numbers are there, whereas we are focused on really looking at patients with established heart disease and trying to predict in them. Even such prediction, our risk stratification at this point of time is very unsatisfactory. We are mainly focused on the LVEF, which we know doesn't have sufficient sensitivity or discrimination to identify the high-risk patients. And lastly, the solution which we have in the form of ICD and other devices for ICD prevention are also not very optimal tools. So we need certain solutions. One could be the use of big data and AI, some of which has been alluded to, especially in the general population, where we have a lot of data going to be coming in from wearable sensors in the near future. Looking at ways to improve personalized risk stratification, especially through the use of imaging and other techniques, and also to see if we can improve our tools in terms of prevention. So this has been alluded to, using big data and learning approaches, and also improving access to genetic testing and pharmacogenomics and epigenetics to improve our risk prediction. And lastly, I would say that we need to have now a little different shift in thinking, because long-term prediction and prevention has been rather disappointing. So we have to look at another approach which we have been talking about as short-term prevention or near-term prevention. This is really based on the fact that there are warning signs in up to 50% of patients prior to experiencing sudden cardiac arrest. And we have shown in a couple of studies that those who really acted on it and called EMS had up to a 4 to 5-fold better survival. And work is going on in this in terms of looking at how it could be more specific in patients with SCA versus without SCA. So really there is a call for changing the paradigm, where we have to think of near-term prevention or preemptive action, where we can think of a scenario where warning symptoms in association with timely data from connected devices, aided potentially by some automation through AI, could help us preempt the SCA in the hours or minutes before the event. So if there is a witnessed arrest, that's better, but hopefully even an unwitnessed arrest, through alerts from wearables or smart sensors, can then automatically alert EMS. Maybe we can look in the near future on drone AED delivery to overcome traffic and logistical obstacles in order to optimize our resuscitation. So we want to add a link to the chain of survival in terms of anticipation, in addition to all the other links which we are already existing. We also have to really think of dynamic risk. We have been viewing at risk as a one-time point. You take an ECG at one point, try to see what is the risk of SCA, whereas what is really more realistic is that risk changes over time. And this is just one example of it, where people took a 6-point SCA electrical risk score and they simply reassessed it after a few years, and they found out that in those in whom the SCA risk score went up over time had a greater risk of SCA as opposed to those in whom it stayed static or regressed. So we have to think beyond traditional medium and long-term approaches, think of short-term prevention, and also try and better understand the dynamic nature of SCD going forward. And this is again something where we need to see how better to improve the resuscitation strategies as far as the EMS organizational aspects are concerned. And lastly, not to neglect the third part, which is resuscitation, because the families of dissidents need the answer as to what is the subsequent risk for relatives, and also the survivors need support in terms of psychological and other ways so that they're able to return to their normal life. So we have to focus on the development of effective rehabilitation programs geared towards dissidents as well as the post-SCA survivors. So to conclude, we have looked at kind of the prism of the circle of sudden cardiac death in order to encompass all aspects before, during, and after the event, and we have to holistically tackle all of them in order to make an impact in the near future. So we have to use a multidisciplinary approach and perform high-yield research with international collaboration to be able to make an impact. Thank you for your attention. Happy to take any questions.
So, Kumar, great talk. Questions from the audience? See, Kumar, there is this 23-year-old fit male consults you to find out what he should do. He's 3 years elder who had collapsed and died. So what are the tests you think you would make him to undergo? And what are the tests you would discuss that it might actually also add some value? The must tests and the tests which might add value, but you are not forcing him.
Yeah. So a very difficult question, I should say, because I think this is one of the scenarios precisely where we are talking about where we struggle to give answers. So the person who died, the absence of an autopsy in that person would represent a big problem in addressing what to do for this next person. So people have looked at, if in the absence of autopsy, even if you can do something more simpler. For example, they're investigating the value of just dried blood spots, even in situations where you have difficulty in performing an autopsy, or even taking a small sample and storing it appropriately. In such situations, even if you can just take a blood and have a dried blood spot, later on it could be potentially analyzed for known mutations. For example, if it was something as simple as this elder person had a clear-cut RYR mutation for CPVT, then you can simply test this sibling for that and give them a clear answer. You have this or you don't have it. In the absence of any such information at all, I think you have to start with a clear clinical workup. That's always at the heart of everything. When we talk to geneticists, they say, first tell me the phenotype. What are you looking for? Just as somebody asks us for the ECG, we say, what is the clinical data, right? So we need to start with a proper full clinical workup, and I think the very basic tests are a ECG and an echocardiogram. And then if we are really searching deep for answers, then we have to look at other things like exercise testing, maybe things like a provocation, drug provocation, and then further to see, depending on what information you're getting, to see if you are able to propose further things like genetic testing and all. Because the problem is when we do blind genetic testing, many times it throws up these so-called VUS with which we don't know what to do.
So I think you agree that it's very difficult at this point in time. We do not have many tests where the validation has not been considered. But as you said, clinical workup and some basic tests might pick up. Great talk. Any more questions? Yeah. Right.
Thank you.
Thanks, Kumar. So I see the master in subcutaneous ICD on the screen. At least I am privileged to see him there. Dr. Saxena.
Good afternoon.
Hello.
Good afternoon.
Yeah. So we are here to learn from you sub-Q ICD. For whom and why? So I think it's got a recorded version, or yeah, okay.
Correct.
Good to have you, and you are at home.
Thank you,
Dr. Narasimhan and Dr. Daljit, for inviting me to this wonderful conference. Over the next 10 minutes, I'll talk about subcutaneous ICD. Now, we have been using transvenous ICDs for over 3 decades now, and the main problems with the transvenous ICD are, one, of course, there is high failure rate of the ICD lead, which could be 10 to 20% by 10 years. And secondly, most of the problems with the ICD are related to the fact that we have to place a lead inside the vascular system. So whether it's acute complications like hemopericardium or pneumothorax, or chronic issues like lead failure, lead endocarditis, venous occlusion, etc., they are all related to placement of lead inside in the vascular system. And this is spread across the manufacturer, so it's not confined to one particular manufacturer. The subcutaneous ICD was designed to overcome these problems related to the lead placement. The device is entirely in the subcutaneous space. The can of the device is placed in the hollow of axilla and the mid-axillary line, and the lead is tunneled along the subcostal margin, and the defibrillation coil is placed in the parasternal area. There are two sensing electrodes on either side of the defibrillation coil, which together with the device can form the primary vector, secondary vector, and alternate vector, which are utilized to detect cardiac signal and diagnose arrhythmias. The potential advantages of subcutaneous ICD are that there is no need of venous access, and therefore it avoids lead endocarditis and other problems associated with the lead extraction, and of course it is better suited for younger individuals, and because it saves the site for transvenous ICD in case it is required in future. The potential disadvantages are that there is no bradycardia pacing support, there is no ATP, and it cannot be upgraded to CRTD. The functioning of device is straightforward. The first stage is signal detection, and as we can see, the subcutaneous ECG is very similar to the surface ECG. After the signal is gathered, it passes through a 4-stage double detection algorithms which assess the morphology, and basically they are designed to reduce oversensing. And once the heart rate is confirmed, and it goes through arrhythmia discrimination, and once the diagnosis is confirmed, the therapy is delivered. This is the data from a pooled analysis of IDE study and effortless registry, where it was shown that it works the efficacy is quite good, comparable to transvenous ICD. The 98.2% episodes were terminated within the 5 available shocks, and 3-year approximate inappropriate shock rate was around 13%, and there was a all-cause mortality of 4.7% over 3 years. So in the initial phase, the inappropriate shock rate was higher, but now, of course, as we will see, it has substantially come down. This is the data from a meta-analysis of case control studies, and we can see that the lead-related complications are really very less compared to the transvenous ICD, only 0.14% compared to 1.02% in the transvenous. The system failure rate and the infection rate are similar. The inappropriate therapy was also similar, but the reason for inappropriate therapy was different. The subcutaneous ICD is very good at arrhythmia discrimination, and most of the shocks, inappropriate shocks, were related to the oversensing. Now, this was the first head-to-head trial, the Praetorian trial, comparing transvenous and subcutaneous ICD. The primary endpoint was device complications and inappropriate shock rate, and the secondary endpoints were device-related complications, lead-related complications, inappropriate shock, and mortality, etc. Now, the research showed that the primary endpoint was quite similar in transvenous and subcutaneous ICD. There was no difference statistically in complications or inappropriate shock rate. The mortality was also more or less similar, slightly lower with the transvenous ICD, but not statistically significant. The complication related to the device were also similar. There were less with subcutaneous ICD, and the investigator estimated that it will become significant in about 8 years. But this is where the subcutaneous ICD really shines. That is a much lower incidence of the lead-related complications compared to the transvenous ICD. The overall inappropriate shock rate was also somewhat similar, maybe slightly numerically higher with the subcutaneous ICD. And the reasons were also very similar to that, what I showed earlier, that the arrhythmia discrimination was much better with the subcutaneous ICD, but there were more instances of cardiac oversensing with the subcutaneous ICD. But overall, arrhythmia, this inappropriate shock rate was similar. Now, this is a study called Untouched study, where they have studied primarily the inappropriate shock-free state. And what they found was that over a follow-up of 540 days from implant, the inappropriate shock-free rate was 95.9% compared to the performance goal of 91.6%, which is highly significant. And this was even better in patients who received a generation 3 device with a smart pass filter. So the investigators concluded that SICD is non-inferior to transvenous ICD for incidence of inappropriate shocks in the primary prevention population. And this slide very clearly highlights how the inappropriate shock rate has gone down. This was the main concern with the subcutaneous ICD initially, but the development of various algorithms has shown that that the inappropriate shock rate has come down significantly to in the same level around 2.5%, and compares very favorably with the transvenous ICD. This is a meta-analysis which shows the lead-related complications, and we can see that that's the main strength of subcutaneous ICD, that the lead-related complications are much less compared to the transvenous ICD, while the inappropriate shock rate in most of the studies now is similar in both transvenous and subcutaneous ICDs. So what do the guidelines say? The 2017 AHA-ACC guidelines, they have recommended subcutaneous ICD for patients who have inadequate vascular access or are at a high risk of infection. And of course, there should not be any contraindication in the form of bradycardia or requirement for ATP or CRT. And in other patients who meet an indication of ICD and there is no contraindication, it is reasonable to implant a subcutaneous ICD, provided there is no contraindication. And the latest 2022 guidelines from European Society of Cardiology, they also have similar recommendation that a subcutaneous ICD should be considered as an alternative to transvenous defibrillator in patients who have an indication for ICD, but should not have a contraindication to subcutaneous ICD like a bradycardia or requirement of ATP and resynchronization. The current concerns with the subcutaneous ICD are mainly the lack of pacing capability, which is by design, of course, a lower battery life compared to transvenous ICD, and sensing issues in some patients, and of course a bigger size because higher DFT. So in future, we expect a smaller device with better longevity, more programmability, more diagnostics, and of course, there is a possibility of providing pacing support and ATP and CRT through a leadless pacemaker. And this is something that is already in the works and probably will be available very soon. This is published a case report where we can see that there is a ventricular tachycardia going on, which is terminated by ATP provided through leadless pacemaker. So what are the take-home messages? Well, what we can say is that the subcutaneous ICD has evolved significantly and is now comparable in terms of safety and efficacy, comparable to the transvenous ICD. It may be preferred in patients who have venous access issues, patients who are on hemodialysis, patients who are immunocompromised, and those who don't require ATP, like those with channelopathies and hypertrophic cardiomyopathy, etc. Patients with previous device infection or lead failure are another suitable. They should be avoided in patients who is now comparable in hypertrophic cardiomyopathy, who have a wide QRS, who currently need or may require CRT in future. And similarly, patients who have bradycardia and may require pacemaker support in future, they should not be given subcutaneous ICD. And of course, patients who have already documented monomorphic VT, where ATP is required, it should not be given. So I think I will stop here. Thank you very much. I'll be happy to take if there is any question. Thank you.
Thank you very much, Dr. Saxena, for that very succinct talk on SICD. Any questions from the audience? Just one question from my side. Generally, when the SICD was initially started off, people were mainly implanting it, as you said, for younger patients, channelopathies, where the main expectation was VF. But I think world over now, I see a lot of implantations happening for non-ischemic cardiomyopathy, even sometimes ischemic cardiomyopathy also. How do we really anticipate the lack of need for ATP in these patients? Is there any pointers towards that?
Yeah, very difficult because it's not even recommended by the guideline that one should do an EP study to see if there is any inducible monomorphic VT. I think for primary prevention population, it may be considered. And basically, as we think more about it, we realize the complications related to the lead are significant, especially those patients who get infection. So patients who are immunocompromised or patients on dialysis, etc., they can certainly be considered for this. And I think that is all I can say. But you're right. I mean, that's a concern that some patients may require monomorphic VT subsequently and may have to be upgraded to a transvenous ICD.
I think with the ongoing already trials of Empower, hopefully that's concern is going to be taken care of soon. Any other questions? We'll move to the next talk in that case. Thank you, Dr. Saxena. And we have now Dr. Daljit with the role of catheter ablation in ARVC and HCM.
Thank you. So after talking about the role of ICDs in the patient with ventricular tachycardia, we are moving on once we have given an ICD, if the patient goes into VT storm or if the patients are having lot of shocks, can we do the next line of therapy, which is the ablation? So why we are talking about hypertrophic cardiomyopathy and ARVD here? We all are aware, like after ischemic cardiomyopathy, the common inheritable cardiomyopathy we all see in clinical practices, hypertrophic cardiomyopathy, which is highly variable phenotype. Like you may have a patchy scars, you may have epicardial scars, you'll have intramural scars, you may have 1/3 of the patient who are coming up with the apical aneurysms. You will have ischemia going on because it's a thick myocardium. Whereas apart from hypertrophic cardiomyopathy, ARVC is a cadre where the patient, unless develop a complete full-blown disease, the diagnosis is decreased. But the thing with ARVC is, it's more predictable. We know where is the scar. It's epicardial to endocardial disease. The disease starts first in the epicardium. And we all are aware as a cardiologist, there is a triangle of dysplasia. So you have a peritricuspid region involvement, then you have a diaphragmatic surface of the RV involvement, then you have an outflow tract involvement and the septum of the RV side, which is spared. Why I'm talking about all these things? Because for us as an electrophysiologist, we should be having an idea from which area the scar is there and from where we have to ablate these cases. Dr. Henry spoke about imaging in these patients. So if you have an idea where is the disease, you can go at that site and it improves the outcome of your ablation. So I'll just show some case example. This 55-year-old male hypertrophic cardiomyopathy, he had an apical aneurysm. He was in VT storm, and because of the VT storm, he developed severe LV dysfunction. He was almost an incessant VT on multiple antiarrhythmic drugs. And you can see it's a very, very wide QRS. And so when you have a very wide QRS, and we spoke about epicardial VT yesterday, right? So the intrinsicoid deflection is very wide. There's a pseudo delta. So this looks like an apical coming from the epicardial region. And this patient had an apical aneurysm. So we know that where to go for your ablation. And he was getting multiple shocks daily, and his battery life got drained in just few months because of this VT storm. So you take this patient on table and you start mapping. This patient was an incessant VT. So you start mapping. I may not go into the detail because now we have a interventional cardiologist sitting in the crowd. But yes, we try to do activation mapping in these patients. We try to search for the channels where you should be going and ablating these cases. So you search for the channels, for example, for an electrophysiologist, you feel that this is a good channel, but you see that your PPI minus TCL, that means it's not inside the circuit, it's a concealed entrainment, but it's a blind loop because your PPI post-pacing interval minus tachycycle length is very long. So you should not give away this site. You have to search near this area. So when you do entrainment, the problem with entrainment in these patients is you take a lot of time. Secondly, the VT may change from one morphology to another. And when you pace multiple times, patient becomes hemodynamically unstable and you may have to cardiovert. So once you know the substrate, so one thing you can do is, I think yesterday someone showed very nicely that you can give xylocaine in this patient and you can decrease the number of VT so that you get some time to do substrate mapping during this. So we know this all gray area is the scar area, and you know that you have to search for the channels in this scar. So you're searching for the channels in this scar and all the areas. Now once you start searching for the channels, although you are not able to see, now there is no multipolar catheter. We were talking about multipolar catheters which picks up very tinyness of the signal, but now my catheter size is little bigger. So within the dense scar, I should start pacing and start searching for the channels. You're not able to appreciate any signals, but once you start pacing at this site, you can see it's conducting with a very long latency. That means I'm sitting within a channel which is taking a long time to come out, and this may be a potential site for the isthmus. So all these kind of channel in that small aneurysmal area, you start searching and start ablating. But what happens when you go for an epicardial, you ablated few areas, but whenever you ablate in the epicardial region, yesterday we were discussing, I'll remove this laser. Yesterday we were discussing, so it's an apical aneurysm. Your phrenic nerve runs here. So when you have a phrenic nerve runs here, you cannot ablate here. So you have an option. Either you go through the coronary vein, and like Dr. Sachin showed yesterday, like when you go and put an alcohol, if you are lucky, if you have a branch here. But if you don't have a branch here, you can have another option, like you put one more wire. We have already left one more wire. Whenever you take an epicardial access, we leave one more wire so that you have another access, and you cover that area with the balloon. So once you cover that area with the balloon, the phrenic injury will not happen. And with certain systems, when you are ablating, Abbott allows that when you are ablating, and you can keep pacing and ablating, and you make it sure that there is no phrenic there. So when you keep pacing and ablating, one, you're sure your phrenic is not getting injured. Second, there is a loss of capture. So you're sure that your lesion is created. And the post-ablation, the patient who was an incessant VT, who was draining his battery, is now his sinus rhythm. This is very important because now the device recalculates the battery life. The patient was considered for another pulse generator change. So when the device recalculates the battery life, it prolongs the battery life also. So you're decreasing the number of shocks, you're decreasing the number of hospital admission. So now your technology of the ablation, since yesterday we are seeing a lot of cases, has improved drastically. 2-3 things. This is another patient, this is not the same patient, who was again having an apical aneurysm. So you have a smart touch technology, like you know your contact is good. And I think Dr. Narasimhan was talking about, if your catheter contact is not good, you can give apnea. You can see you have given an apnea. So doing under general anesthesia, these cases are really, really helpful. Like you can give 20 seconds of apnea, make sure your contact is good, and your contact is good and your catheter position is stable. You can create a very nice lesion. So once you release the apnea, you can see a lesion is created. So when you give general anesthesia, this is helpful. This is another case. So you create all these lesions only within the scar. You are not going into a healthy area. So you are not compromising on the function of the heart. So we have done some cases. We have published our data of 14 cases of ablation in hypertrophic cardiomyopathy, and we realized that lot of cases, as I spoke, that because they have a very patchy areas of scar, lot of them require epicardial ablation. In a series, almost 90% required epicardial, both endocardial and the epicardial ablation. This is a next example of a patient of the arrhythmogenic cardiomyopathy. This guy is a 32-year-old male, ARVC. He was in VT storm. So what was happening? This patient is from Sri Lanka. So he underwent 3 device changes in 4-5 months because of his VT storm. So multiple. So that's not the therapy actually. You cannot keep on doing pulse generator. The more number of pulse generator changes you're doing, more is the chances of infection here, and you're compromising on the quality of the life. They will have a lot of hospital admissions. So he was on multiple drugs at different time point, different combinations, and this device also reached ERF. And you can see that per day they are getting a lot of shocks in these patients. So this is a typical ECG pattern of you're getting an epsilon wave. You can see that kind of elevation, and you can see that there is a fractionation in V1, V2, V3. And this patient had already developed RV disease, very dilated RV. So as I spoke, ARVC is an epicardial to endocardial disease. It involves epicardium first and then endocardium. So you cannot go and just ablate endocardially. So these patients, invariably they require epicardial access. So you have to go epicardial. This is a huge RV. It is occupying whole of the anterior part of the thorax. It has pushed left ventricle posteriorly. So you have to take epicardial access. And here we are aware, we understand where is the scar start. So endocardially you have placed a duodecapolar, and for us as an electrophysiologist, you can see peritricuspid region, you are getting these kind of abnormal signals. So we call it as late potentials, which can give rise to. So if you see on signal average ECG, that's the reason you get epsilon wave on V1, V2, V3. These are the areas which gives rise to re-entry. So with your multipolar catheter, you can see here, these are the all very late activating area which gives rise to the blips on the or epsilon wave in your ECG, surface ECG. So you mark this area and you can see this is an epicardial map of this patient. So with a voltage setting, standard voltage setting which electrophysiologists keep is 0.5 to 1.5, you can see all is gray. It's all completely involved, and you are getting only islands which are little surviving areas. So you mark all these areas, then you map endocardial, and this tiny hole which is seen is the position of the lead where the defib lead was lying. And then, as I said in the previous case, you did mapping with your multipolar catheter, but as soon as you take your bigger catheter, which is the tip is 3.5, you don't see any EGMs. So you should not give away those areas. You have to start pacing. This is for us as an electrophysiologist. You should start pacing at these areas, and it is still capturing. So why you are not able to see these EGMs is because the catheter tip is bigger. So you did mapping with a very small size catheter, which is each electrode is 1 millimeter with inter-electrode distance of 1 millimeter. And now I'm taking an ablation catheter with the tip is 3.5. So your directionality also changes. But now I know where is the scar. I know where were the abnormal signals. I know where I have to move. So that helps you to, once you know the baseline disease of the patient or imaging of the patient, you know where you have to map. So same thing, you're not able to see any signals, but these are the areas which are the potential isthmus, because you can see when you're pacing, it is decrementing, and after decrementing, it has stopped conduction. So it's a potential isthmus which is a slowly conducting channel. As we know, the mechanism of arrhythmia is a re-entry. So you need one area of very slow re-entry, one area which is normal, so it resets the re-entry and starts VT. So you ablate all these areas and then you perform your induction. So once you perform your induction, you start with just 2 extras and you are again inducing one non-sustained VT. And then we know which is we can again start mapping, search that area, and because it's a non-sustained, we call something called, you can do pace mapping within the scar area, and you ablate the area. We got a pace map, is you can see this is again a late potential. You ablate that area, and with 2 extras nothing is getting induced, so you can go to 3 extras now just to make it sure like you have done your work. So the 3 extra you have again induced a little different morphology of VT, which is a slow VT, which is now hemodynamically stable because you have modified the scar extensively, and now you can map it nicely. So once we start mapping, you again search for the area which is the slowly conducting area which is giving rise to the re-entry, and you pace and you confirm that when you're pacing that you are deep within the isthmus, and even if I have terminated at that site, you can see that it is deep in the isthmus because for an electrophysiologist it's a concealed entrainment, and once we have terminated, this is the signal at the site where we were doing entrainment. And when you start pacing, same thing, you are slowly capturing, and then there is a decrement and there is a loss of conduction. So you ablate that area, and the post ablation again you give 3 extras and there is nothing. So this patient, like, you have to do pulse generator, and the pulse generator change, it's more than 3 years of ablation, and there is no VT over 40 months of follow-up, and you keep them on some drugs, but you need not give them a lot of antiarrhythmic drugs. Some antiarrhythmic drugs you can give. So this is another patient which I was talking about. This is again ARVC patient. So this is an endocardial map, and this is an epicardial map. So you can see this all red area, this all epicardial map it's all scar, whereas endocardial, your anterior wall is free, but your peritricuspid region is having a scar. This is another different patients who are having a diaphragmatic region scar and peritricuspid region scar where you ablate in ARVC. This was a patient who came with single morphology VT. No genetic test was done for this patient. Thinking of single morphology, you take them on the table, and there is no epicardial access. You didn't take epicardial access, but you see endocardial, you have again peritricuspid region scar, and you have an outflow tract scar, And this you can see a left anterior oblique view. Your septum is completely healthy. So this again tells you, when you take these patients for the procedure, again tells you you should be suspecting something, because there's a particular distribution of the scar which you should be thinking about, that what is the underlying disease, even if you are not able to diagnose before taking patient on the table. So this image I took from, because one of our patient who underwent cardiac transplant, this I took from our surgeon, Dr. Naresh, who was having ARVD or having a very, you can see the RV, you can see it's not contracting, it's completely slowly changes into the fat. It's complete fat, there is no muscle there. And it's a genetic test, this patient is an ARVs, and you can see this RV, many times when you see a heart, we were doing dissection in the morning, you can see islands of fat, right? But here you cannot see any muscle in this patient, it's everywhere, it's a fat. And if you can see from endocardium to epicardium, this ventricle is all changed into fibrofatty, and you are having only islands of muscle here. And even LV was getting involved in this patient. And it's very nice. If you see this is a free wall, this is an anterior wall. You're seeing islands of muscle, and everywhere there is a fat. But when you go on the septum, this I've opened towards the septum, when you go towards the septum, still you have still muscle. So I think septum is the area which gets involved very late. So this was it was a nice opportunity to see the anatomy of this heart. I'll stop here. Thank you very much.
Thank you, Daljit. Thank you, Daljit. It was a very impressive series of VT ablation for the incessant ventricular tachycardia in tough substrates like HCM and ARVC. Absolutely great series. A couple of questions from my side. In your ARVC series, did you see the disappearance of the epsilon wave in any of the cases?
No. I think we are seeing patients when they reach you, the disease is already progressed. It's a full-blown ARVC.
Right.
So if you take it's not like Brugada. Brugada, you see disappearance of Brugada pattern. There is no big structural heart disease.
Yeah.
Only when you take them for mapping, you see some late potential, but echo will be normal, everything. These are the patients, the heart is such a big thing, so I don't think you'll...
No, actually, we have not reported, but a bipolar ablation in ARVC causing perforation and tamponade. At the same time, the next day, the epsilon wave disappeared, and he didn't have VT further. All right, so now how often you adopted bipolar ablations in these both substrates?
Not in ARVC, I think, because ARVC ventricle is thing. Every patient you are going epicardial, and then we ablate endocardial also, and the chamber is very thin, I think. But yes, HCM few cases, especially the first case which I showed you, few cases we can think of because they are intramural circuit. Especially, I was not involved in any of our HCM cases where I've done a bipolar ablation, but sarcoid patient I've done bipolar ablation. One patient we did in the septal, one patient we did in the free wall. But absolutely you're right, HCM, if you have because it's very thin intramural circuits, you're not able to reach, you can think of bipolar ablation.
Yeah, I
if
think
someone can add on to that.
I think when the HCM is associated with the apical aneurysm, I think that's the best substrate to deal with these incessant VTs. But the substrate anywhere else in the hypertrophied heart, we don't have much experience, but whenever we have done, we always did either a simultaneous unipolar or bipolar ablations, both endo and epicardially. Dr. Narasimhan?
I think other thing is, if we add 2 patches on the back, instead of putting on the thigh, if you bring your patches on the back, and if you add 2 patches, that also is helpful in few patients.
Yeah, very interesting, and this is a very tough substrate. It takes a long time to get rid of all the late potentials. As Daljit showed, when you're mapping with a single catheter, you hardly find any potentials. But if its space capture is there, you need to target them for ablation, number 1. Number 2, we have had 3 bundle branch re-entries in a cohort of about 17 or 18 patients with HCM. For some reason, these patients we have had in post-aortic valve replacement also, the next substrate is HCM. I think Muthaiya is going to present, or he withdrew that case in want of time. Third is young children. We have ablated 2 kids, repeatedly going into VF, almost listed for transplant from different states. couldn't manage and other things. So we were also skeptical initially, but when we went there, there's a Purkinje trigger, which was triggering the VF. So the trick there is in the patient who have this, to maintain the blood pressure, we use phenylephrine to increase the afterload, and then go into, because the cavity becomes too small for you to map. It's a challenging subset to map and ablate.
So, ladies and gentlemen, you agree with me that it was one of the best of the sessions on sudden cardiac arrest. The expert Kumar and Deepak and Daljit and even our Anil Saxena, they all presented their experience very well. So thank you, organizers, for giving us this opportunity to listen to them. And now we leave the space for the next session.
Thank you very much. And we move on to the next session, which is important about, we implant a lot of devices. Device implants are going up. And we have very, very illustrious faculty. We would like to request Dr. Sridevi, Dr. Sadiq Azam, Mamta. Dr. Mamta is there. And Dr. Mamta is joining online. And Dr. Praveen Srikumar to come over and take over, please.
Speaker. You can.
We've been having sessions on ablation and lead extraction. Now we'll follow it up with CIED. Now I'll call upon Dr. Ramchandra for giving a talk on which pacemaker for which patient.
Thank you, Dr. Narasimham and Dr. Sridevi, for inviting me for this talk. So when I heard this topic, I thought that we're talking about different types of pacemakers. We're talking about different modalities of pacing, and also about different indications for pacing. So we have all these types of pacemakers: temporary, permanent, transcutaneous, wired. In fact, the first pacemakers were transcutaneous. Single, dual chamber and biventricular, rate responsive pacemakers, anti-tachycardia pacemakers, different modes of pacing, conduction system pacing, lot, heart, of course, the other speakers talking about it after this. Autonomic modulation, which is not really a pacing modality, but cardiac contractility modulation is again a sort of pacing modality to improve left ventricular function. So the most important thing is myocardial infarction. A lot of us actually miss pacing when it is needed, because we apply the same criteria that we follow in our chronic patients in our MI patients also. So basically, because we have two fascicles on the left and one on the right, if any two fascicles are damaged, we should pace. For example, if there is a fresh RBB and a LHB, the person needs a temporary pacing. Or there is a pre-existing bifascicular block or a new LBB with prolonged PR, they need pacing. So basically, prolonged PR in acute MI situation is very dangerous, because it may mean, especially with the anterior wall MI, it may mean that all the three fascicles are conducting slowly. In sequential AV pacing is very important in patients who are hypotensive, especially if there is a left ventricular diastolic dysfunction or left ventricular hypertrophy. So this is something that many of us don't do regularly. In post myocardial infarction, permanent pacemaker, also the indications are slightly different. For example, if there is even a short Mobitz type 2 or a transient complete heart block and later on a persisting bundle branch block, he needs a permanent pacemaker. So if a person has right bundle branch block and there was a history of a transient heart block, he also most probably needs a permanent pacemaker. Of course, you can do a EP study. But these are some of the things that we regularly miss pacing. For example, 2 days back in our ICU, we had a patient who had LBB, a fresh LBB, post-MI, and there was a very short episode of right bundle branch block also. But nobody really realized what was the importance. Nobody paced till this person actually went into heart block, arrested, and all that happened. So it's very important that we apply these criteria in acute MI situations. Endocardial versus epicardial pacing. Epicardial pacing is important whenever we are giving a patient to the surgeon and he needs pacing. Especially it could be a congenital heart disease, no venous access, open shunt, which might predispose to embolic infarcts, recurrent device infections, inadequate veins in CRT or during cardiac surgery. There's this long-term controversy about VVI versus VVIR versus dual chamber DDD pacing. For example, many of us, for whatever we think cost constraints, would simply put a VVIR in a patient or maybe a AAI in a patient with sick sinus syndrome, thinking that we could save some money. But there have been a lot of observational studies, crossover studies, and then randomized studies also that have shown better quality of life, exercise capacity, less AFib, less stroke, less heart failure, and death with DDD pacing. So that's the reason you can see this is a busy slide, but whether the indication is sinus node dysfunction or AV block, most patients ultimately land up with DDD pacing. Only in chronic AFib, maybe you will do a VVIR, but otherwise most of them will land up with a DDD pacing. Now, what about pacing in sinus node dysfunction? As you know, pacing in asymptomatic sinus node dysfunction has really no prognostic implications. So it's only when they have symptoms we put a pacemaker. The recent guidelines say that if there is a 6-second pause, then even if the person is not symptomatic, maybe it's better to put a pacemaker because that might predispose them to VPCs and ventricular fibrillation, and that sort of very long pauses. The DAN-PACE study showed that DDR is a better pacing modality than a simple atrial pacemaker because there is a 0.5 to 2% chance of developing complete heart block per year in these patients. So many of us, what we do is in these patients with sinus node dysfunction who need pacing, during the implant we pace, and if the person is conducting, if the atrial pacing is conducting down to the ventricle up to a heart rate of 130, we would simply put a AIR. But so according to this study, it's always better to put a DDDR in patients with sinus node dysfunction also. Of course, you should try to see, you should see that you don't pace the ventricle unnecessarily. AFib ablation in tachybrady syndrome, you can either ablate the AFib or you can put a pacemaker. But really none of them has been shown to be superior to the other. What about anti-tachycardia pacing? There is a trial called the Minerva randomized control trial which actually showed that preventive atrial pacing, which is the 3 modalities of pacing plus anti-tachycardia pacing plus algorithm to minimize the ventricular pacing, decreased AFib, hospitalization and death, a combined endpoint by almost 25%. So there are particular types of ATP which are actually have been found to be useful. So it's not that all anti-tachycardia pacing devices are hopeless. CRTP, of course, the indication is whenever there is a pacing needed in LB dysfunction. So you have class 1 where there is LBB, and non-LBB is usually a class 2. Either A or B depending on the QRS durations. In CRTP with atrial fibrillation, same indications as in heart failure. But atrial fibrillation is a very common cause of a non-responder to biventricular pacing because it decreases the degree of biventricular pacing. As you know, anything less than 99% biventricular pacing will severely decrease the impact of CRTP. So if biventricular pacing is less than 95%, you can ablate the AV node or you can use AV noding blocking drugs. It's easier to ablate the AV node. In atrial fibrillation with fast ventricular rates needing AV node ablation, what would you do? Whether you would put a CRTP or you would just put a dual chamber pacemaker. If there is LV dysfunction, CRTP definitely improves morbidity and mortality. If there is no LV dysfunction to start with, there is definitely improvement of symptoms if you put CRTP. Of course, now we have left bundle branch pacing, which is a very easy modality and which most of us do in preference to CRTP. So coming to left bundle area pacing versus his bundle pacing versus other pacings like septal pacing, RVOT pacing and others. The left bundle area pacing is a very easy modality and most centers now do it in all comers, which means every patient that needs a pacemaker gets a left bundle area pacing because it is so much easier. The thresholds are better, both short and long time. The sensing issues are not there, so there is really no far field A sensing and other such issues. No RV backup pacing is needed. AV node ablation is much easier in case you want to put it in a patient with atrial fibrillation and ablate the AV node later. But the guidelines still, because there are not enough trials, give it a class 2A indication in unsuccessful CRTP and class 2B indications if the EF is more than 40% and the anticipated ventricular pacing is 20%. As you know, RV pacing cardiomyopathy occurs in 12.5% of all pacing. And the good thing about left bundle branch pacing is that, as you know, 50% of the LBB is intrahesian and 95% of these can be corrected. But when you do LBB pacing, even more of these can be corrected. Even the slightly more distal ones can be corrected. And the other good thing about these pacing technologies is that they are most probably better than CRTP for non-LBB situations. For example, a very wide right bundle branch block situation, these could be better than a CRTP. TAVR is something that's done more and more frequently. It's predicted that 50% of all cardiac interventions, cath lab interventions, will be structural in under 10 years or 5 years. So TAVI will be a very common procedure. So as you know, heart blocks happen in 3 to 25%. The most common cause of heart block is a pre-existing RBB because your device impacts the left side, and if already the right side is damaged, the heart block can be very common. So the pre-existing RBB, a short membranous septum, calcium in the LVOT or in the mitral annulus, narrow LVOT compared to the valve that you're putting, self-expandable valve, implantation height, the lesser you put it into the LVOT, the lesser is the chance of heart block, balloon inflations. So all these things predispose to heart blocks, and we should know all this when we are doing the TAVI. But 1, 2 or 3 things is that if there is a conduction system problem, you have to wait for more than 48 hours before you take a decision. For EPS, you need to wait for 3 days. And for a Holter, you usually need a 5-day Holter. So this is the way you proceed if there's a conduction block after TAVI. If there's a persistent high degree AV block, you anyway put a permanent pacemaker. You wait 48 hours and then put. If there is a pre-existing RBB, any sort of further conduction disturbance, you have to put a permanent pacemaker. Because like I said, the right side is already gone and something bad is happening on the left side. If there is a new LBB with QRS more than 150 or a PR more than 240 milliseconds, means it looks very gross and bad, then you wait 48 hours and after 3 days you can do AP study. At discharge, you can put a 5-day Holter and send the guy. And if he has any issues with high degree AV block, you put a pacemaker. Otherwise, you can just leave him like that. And if there's a pre-existing conduction abnormality that has worsened, which means the PR has become it has increased more than 20 milliseconds, or the QRS has increased more than 20 milliseconds, you can again do the EP study plus or minus the Holter. The other indication for a pacemaker is hypertrophic cardiomyopathy. This is done when you have exhausted other modes, so it's a class 2B indication. The shorter the AV interval, the lesser the LVAT obstruction, but most probably this is because of a decrease in cardiac output also. So optimization of AV delay is very important, and many times you have to actually increase the PR by either drugs or by doing AV node ablation to get proper results. But here again, of course, the left bundle branch pacing should be very useful. Sarcoidosis, a permanent pacemaker, even if there's a transient heart block, because this is a chronic disorder, and if there's any LV dysfunction, or if you think that the person is predisposed to tachycardias, it's always better to put a CRT-D whenever there's an indication for pacing in these people. The other type of pacemaker is a leadless pacemaker. The advantage with leadless pacemakers is there is no pocket infection, there are no lead problems. Retrieval is also not difficult. The usual indication, most of them, if you look at all the centers, 2/3 is in atrial fibrillation, where you have put this as a VVI pacemaker. 1/3 is when you have infrequent pacing requirements, like vasovagal syncope less than 40 years. As you know, in young people with vasovagal syncope, a normal pacemaker is not indicated. So here you can put one of these pacemakers. Paroxysmal AV block, sick sinus syndrome with syncope, wherever the chances of pacing, the long prolonged pacing is very less. It happens only very infrequently. Those places you can put the leadless pacemaker. So permanent AFib, multiple complications with PPI, if they are there, you can do it. Anticipated difficult upper venous access, like in chronic hemodialysis patients. Expected higher infection rate, advanced age, non-cooperative patients, psychiatric patients you can put, or in some patients with congenital heart disease. You have this Micra AV approved in 2020. This is a single device that uses the same accelerometry techniques that are there in most pacemakers, so that it can actually know when the mitral valve is opening, when the aortic pulmonary valves are opening, and it can also know when the isovolumetric systolic phase and isovolumetric relaxation phase is happening. So from this, it can actually calculate and give AV synchrony in more than 90% of patients. So this is something that we can use. I think if the cost goes down, it could really be useful. It can be used with a subcutaneous ICD also. There are other devices like the WISE CRT, which is a very small device that you can put endocardially, because as you know, endocardial pacing might be better than epicardial pacing in patients with LV dysynchrony. Now we also have this recent study, Budapest CRT upgrade, which shows that no matter what the duration, if after you put a DDD, if there is left ventricular dysfunction, you should not wait till the battery is over. You should change, upgrade it immediately to a CRT or a CRT-D. Thank you.
I think we can take one or two questions if there is. Yes, I think we can continue to the next topic. Next is Dr. Anup Gupta. Would invite, he'll be talking on avoiding complications during device implant.
Thank you very much. And thanks, Dr. Narasimhan and Daljit, for inviting me. What I've been asked this afternoon to talk for next 10 minutes is avoiding complication during device implant. So it's a very important topic because, see, the previous session, lead extraction and all was coming. And these are important things, like, if you're doing your job pretty good at the outset, so, you're not leading any of the loopholes, so, you're done with the thing, and probably you will be very happy at the end of the day. So the incidence, it varies with the complication, the definition and the length of the disease. The Danish registry recently has shown almost 10% of patients will have at least one complication within 6 months. And again, which kind of device you're putting, if it is a CRT-D or a IICD, probably the complication rates are more than the pacemakers. And what are the major complications? One is the device-related infection, which is almost like 0.74%. and the lead-related complication, which again is around between 2 to 5%. So patient selection and optimization of the implant procedure, that's the most important to avoid all the complications. So what are the unwanted complications which you see during the CR implant? One, again, is like, you can land up in a pneumothorax or a hemothorax. So the most important thing is when you're taking a vascular access, you should be very, very sure where exactly you're doing. Cephalic cut down is the best thing to avoid all these complications. Nowadays, if you're doing an axillary vein or extrathoracic subclavian, then again, it's a very, very important. Skin necrosis, suture line failure, or lead erosion, again, these are superficial things. Lean and thin patient, quite often we see in our part of the world. That's very important. If inadequate fixation, lead displacement, again, is a common thing. If you are not doing a proper implant, particularly with a bigger lead like ICD and all, you can land up in a ventricular perforations. Later part, skin erosion or extraction of the generator, and sometimes the psychiatric illness, like, the Twiddler syndrome. That again, we don't have any control over those kind of patients, but now the bigger device, they do have 2 anchoring sutures. So, you can put both the anchoring sutures and you can avoid that thing. Venous thrombosis, again, quite very, very rare we see, but then again, some of the patients, they get venous occlusion after the lead placement, and they come back with the swelling of the left arm. So that's again need to be addressed. So if you're not doing, or you're not comfortable doing a cephalic cut down, so the other thing is, you do an extrathoracic puncture. Both ways, you can do a venogram, and you see, like, where exactly you are puncturing, you should be outside the rib. That's very important. And if you've got a big axillary vein, so you can puncture the axillary vein also. So if you're doing an extrathoracic puncture, so chances of pneumothorax is almost negligible. So you don't land up with that thing. Many a times what happens, you land up doing a blind puncture, and with multiple punctures, what you can do, sometimes you can have a erosion, or there's a leak in the vein, and even there's a significant spasm of the vein. So, getting an access, particularly the extrathoracic punctures, getting an access becomes very, very difficult. The same patient, like, after first puncture could have been taken extrathoracic, but, after that, there's hardly any vein remaining. So, you cannot take any puncture. So, you have to go intrathoracic and take those kind of punctures. Pneumothorax, if it is only a needle puncture, sometimes it's a very, very small leak, and you get away with the things. You don't do anything. Give oxygen therapy maybe for 48 hours or maybe 72 hours, and it resolves on its own. If suppose you have taken an intrathoracic puncture and you have implanted the sheath inside, in that situation, you may land up with a big hemothorax. Then you will require a needle suction, or probably you have to place a vein also in that situation. This is very important, and particularly if there are fellows and the new implanters who are performing any CRM, whenever you are inserting the sheath, many of the people, they try to block the sheath with the thumb or the fingers. Don't do that, because the thing is, see, if you leave it open, so what will happen, you land up with the ear embolism. 90% of the time, nothing happens with the ear embolism. It dissolves with giving an IV fluid and all. So, 90% of the time it dissolves on its own, the pneumothorax, the ear embolism, but you should be very, very careful to avoid that kind of thing. These are the things, like, when they come back to you maybe after 1.5 months or 2 months, so this is not good. This could be a very early, so this is like in a pocket swelling. And the mistake most of the time, you do like, insert the needle and try to aspirate the hematoma or whatever it is. Never do that. Never do aspiration. If you really are worried about thing, open it, clean it up, again see whether you have left any of the bleeder inside the pocket, cauterize that pocket, and then come up. This is again for the fellows and all this thing. Make sure your pocket is very deep enough. See, in this situation, if you see the lead sleeve is quite high. So, it probably the first implant was not really good, and even there's a erosion of the device from the pocket also. These are the superficial infection. Again, very thin patient, thin skin, female patient, you can have these skin kind of things. So, you should be very, very wise enough to take what kind of suture you really want to do. So, interrupted suture in these kind of patient, and deep suture. Don't take superficial sutures. Deep sutures, they will really work. These are ghastly things, erosion of the devices. So, again, these are not good. So, what is the preparation? The most important preparation, if suppose you are doing yourself only, in that situation, make sure that you change your gloves. Once you prepare the skin, or you put double gloves, discard the previous glove, and then do. In our lab, we are not using any povidone iodine nowadays, so it's all chlorhexidine, and that again is an alcoholic solution. So the infection rates are definitely less. Pocket hematoma, it increases 7-fold by infection. So the most important thing, should not do any aspiration. There's no role of hemostatic agent. Many of the surgeons, and they say that, put hemostatic agent inside the pocket or put a pressure bandage. That never works. Even, putting a dynaplast, I believe putting a dynaplast is a source of infection because there's a lot of gum and all this thing. Even there's a lot of skin necrosis happens. Use cautery, judicious use of cautery. You have to manage oral anticoagulant. It could be vitamin K antagonist or a NOACs or antiplatelet if the patient has got coronary artery disease who is already got a stent on dual antiplatelet. So you have to manage those kind of things. And the most important message, take-home message is, it should not use heparin as a bridging therapy. Many of the patients who have got a metallic valve on oral anticoagulation, stop it, the people stop, they put him on low molecular weight heparin or heparin, then they perform the devices. Those are the patients that come up with a pocket hematoma and you are really worried. This is a debatable thing, antibiotic prophylaxis, but again, trust me, giving antibiotic 1 hour prior to the procedure, that means that makes a lot of sense. Otherwise, giving a prolonged antibiotic for 3 days, 2 days, 7 days has got no meaning. The other thing, people, they try to do a lot of irrigation of the pocket with a local antibiotic. Again, that doesn't really work and it's not recommended. So single shot antibiotic, whichever you want to give, cefazolin group is the best. 1 hour before the procedure and you're done. You don't have to give any more antibiotic. This again is important, anticoagulation protocol. So what you really want to do, if the patient is on warfarin or acetylcholine, make sure the day you are doing the procedure, the INR should be less than 3. It should be in therapeutic range between 2 to 3. You don't have to stop warfarin or acetylcholine to perform your devices. If the patient is a high risk, like has got a mechanical valve, atrial fibrillation, don't stop. If you think that is a low risk patient, probably the patient has got a valve in the aortic position or the frequency of atrial fibrillation less, in that situation you stop anticoagulation for 2 days. Again, if the INR is less than 3, go ahead and do that thing. Coronary stent, depend when the stenting has been performed. Within a month, don't stop dual antiplatelet. Perform the device on dual antiplatelet with judicious use of the cautery. If it is more than a month, continue the aspirin. Probably if you are giving ticagrelor or you are giving Pacigrel, in that situation you stop that thing. So this is small videos. This is again meant for the fellows only. See, this is how you should use. And my recommendation again, you should not use any knife or any scissor for your making a pocket. It should be only cautery. And again, don't use cutting in the cautery. It only should be fulguration. Just do fulguration because again, if you are using cutting, what you will do, you will cut the fat. It will produce a lot of fat necrosis. And again, fat necrosis is one of the source of pocket infection. And make sure that, when you're going and when you're doing this thing, it should be in one plane, right up to the muscle. So, you go with the one plane, don't enter in the multiple plane. The moment you see the muscle and make a pocket there. The other thing which people make mistake, they make pocket with a blunt dissection, like with the fingers and all. Never do that. See, again, if you are making a blunt dissection with the fingers, chances of hematoma is very, very high. You will definitely damage a lot of capillaries and arterial inside the pocket, and that will not really help you out. The other thing is, once you make the pocket, so this is what, once you get the muscle here, just make there, it takes hardly 2 minutes, it may not be more than 2 minutes. And if you see here, you will not see a drop of blood also. So, if you don't have any drop of blood, so probably your pocket is absolutely dry and you're fine with that. The other important thing is the radio-opaque gauze piece. So never ever put a betadine gauze piece inside, because see, if you're putting a betadine gauze piece inside, you will not be able to assess whether there's any bleeder inside or not. So just put a dry gauze piece. Just put a dry gauze piece, and when you're taking out this thing, if it is absolutely dry, your pocket is absolutely dry, nothing's going to happen. That's very, very important. So lead fixation, again, your lead should be apart. Fix the lead with a knot of 8. That is what people say surgical knot. And all your leads should be separated out. All should be separate with each other. So, the lead should not be all together. Skin closer, there should not be any tension on the skin. So what again I say, like from your incision line, the pearl generator should be below the incision line. That's very, very important. And now you have got an exostatic dressing. So, you can put an exostatic dressing. That's very important. Tyrex, if you are doing a redo procedure, or if you think that patient has got a chronic renal failure or patient has got a malignancy, and you feel that, patient is a very, very high risk subset for infection, in that situation, probably you can use a Tyrex pouch. which again release the antibiotic in the pocket, minocycline and rifampicin. So that's very, very important. So this is one infection part. The second thing is the lead problem. So, this is what nowadays, even in our IHRS group, a lot of discussion was going on, like, self-retraction of the screw. So the most important thing what I've observed is, people make rapid turns and they over torque. So, they make 15, 20 turns and they are very rapid. So that is how the screw comes back. So, in the second day or maybe on the same day, you will see that screw has retracted back and probably the lead has displaced. So go slowly. Whatever the recommendation of the company, if it is a 6, give 6. If the recommendation is 8, give 8. No, don't give more than that. Other important thing is the lead fixation. So, if you have not fixed the lead properly, your lead is going to come back. So, your fixation of the lead with the sleeve, with the muscle should be very, very good. If you have not fixed the lead properly, it is going to come back. So, fixation of the lead, and again, lead is your choice. Whether you want to put a passive lead or the active lead is your choice. Majority of the centers, they are putting active lead nowadays because its implant is easy. And then if suppose you want to explant, it's again is a easier thing. So, fixation of the lead, of the active lead fixation, as well as the lead fixation in the pocket is very, very important. So the concept again is like, perforation, RV perforation happens with the screw-in lead. It's not like that. Even the tine lead can go beyond the RV. And again, there was a discussion in the previous session, like, what is going to happen. Trust me, like, you pull the lead back, majority of time, more than 90% time, nothing happens. Although you have to keep your OR ready and tell the surgeon that, the patient may require surgery for RV perforation. But now these never happens. These never happens. So this is one, like, again, this was a psychiatrist wife, and this is a classical twiddler. So, if you see here, it's all crumpled. So, people keep on playing with the device, clockwise, counterclockwise. So, the device comes back. So this is what now the company, they have come with, the good thing is that they have got two anchoring, like, one medial and one lateral. So, if you anchor the device properly, it is very difficult to twist the device. So, you can avoid that thing. So, twiddler syndrome, again, is a psychiatric problem, and you have to convince the patient, the family, like, don't touch the device, don't do the thing. Couple of things about the CRTs, although it's a long talk, so, I'm not going to touch CRTs and ICD. So, a couple of things about the CRTs. So, once you cannulate the CS, make sure you should not do a forceful injection. The moment you do a forceful injection, what you are going to do, you are going to perforate or you are going to dissect the CS. So, your injection should be very, very gentle. Nowadays, we don't prefer to do a venogram inside the CS if you have got a very good vein on a levo phase or the cornice sinus. So, we don't even prefer to do injection, but it should be very gentle. Don't do very hard injection. The other again, the thing is that, if suppose your vein has got stenosis, don't be very, very aggressive. Don't try to dilate at a very high pressure. Many times, even I have used sometimes cutting balloon to get rid of the stenosis. But, sometimes what happens, you land up in a perforation of the vein. So, again, these are very difficult. If you have a perforation of vein during the LV lead implantation, it's very difficult. Although, this can be closed on table by either injecting a glue or particles. So, you can inject that and you can complete a procedure also. The other thing, which again is a discussion point, like, if the patient has got a very big cornice sinus vein and the lead is coming out every time. So, many people, they try to anchor it with a stent and all. I will never recommend, never ever put a stent in a LV lead, because see, if there's an infection or there's a malfunction of the lead, if you want to take out the lead, you cannot take it out. So, do active fixation. It could be bipolar. Nowadays, bipolar leads are not available, but you can put a active fixation quadripolar lead. Please use active fixation lead rather than putting a stent to anchor the thing. So, which are the high risk subset? Old age, high body mass index, smoking, poor nutritional status, or a decreased platelet counts. Complication during the device implantation could be major and minor. Minor, we are not worried about the thing. Major, we are worried. And most important is infection and lead this thing. So this is how you manage. So if it's an infection, so try to treat the infection. If it is superficial, try to treat that. Use Tyrex if suppose a redo procedure, a very high risk procedure. Initial implant should be very, very good.
Dr. Anup,
again, yes, this is my last slide. And the lead fixation and active fixation should be the good. Thank you very much.
I think the next session is online by Dr. Karthikeya Bhargava.
Good afternoon, and I thank Dr. Narasimhan and Dr. Daljit for inviting me here. I think my presentation is already there with you. Good afternoon, everyone. So my task for next 15 minutes or so is to present on pacemaker troubleshooting in the post-operative period. And before we go to pacemaker troubleshooting per se, let's revise the pacemaker code. Typically, the pacemaker code that we presently use has the five letters, of which the first three are the most commonly used ones. The fourth letter denotes the rate modulation, and the fifth one denotes the multi-site pacing. The first letter denotes the chamber space, the second the chamber sense, and the third is the response to sensing whether it is triggered, inhibited, or none. So typical examples of pacing mode that we use in our clinical practice is VVI or VVIR or VDD mode, and typically in dual chamber pacemakers, DDD or DDDR mode. DDD-RV mode typically represents biventricular pacing as we use in our cardiac resynchronization therapy device. Now, in a patient with a dual chamber pacemaker, there are four different phases which can happen for each complex, each QRS and P wave complex. And these could be ASVS, that is both atrial and ventricular events are intrinsic. It could be atrial paced and ventricular paced, that means both atrial and ventricular events are paced. It could be atrial sensed or ventricular paced, where the atrial event is intrinsic, whereas the ventricular event is paced one. And it could be atrial paced and ventricular sense, typically seen in patients with sick sinus syndrome, where the intact AV conduction allows for atrial paced event to conduct to the ventricles. Now, when we talk about pacemaker troubleshooting, it can have a lot of things, including undersensing, where the event which should be there is not seen by the pacemaker. Could be oversensing, where an event which does not exist is seen by the pacemaker. There could be loss of capture when there you have a spike, pacemaker spike, but does not result in atrial or ventricular depolarization. There could be failure to output, that is, the pacemaker does not fire where it should have, if normal. There could be pseudo malfunction, that is, abnormal ECG recording or abnormal feature seen when this is a normal pacemaker operation and due to usually some complicated or complex algorithms. And finally, pacemaker mediated tachycardia is a special form of rhythm problem which can seen in dual chamber pacemakers. In patients who get a pacemaker implanted, there is a long list of complications, but typically I will be focusing on pacemaker troubleshooting, wherein you have some technical issue with the pacemaker programming, or some abnormal algorithm is operative, resulting in complex electrocardiogram. And if you look at the causes of pacemaker malfunction, it could be because of pacemaker system malfunction itself, where there may be problem with the lead, we may have dislodge, maybe intrinsic measurements may be smaller, the lead may have perforated, there may be insulation failure or fracture, or there may be loose set screw, which is typically seen in immediate post implant settings. Or there could be battery depletion or circuitry failure as regard the pulse generator is concerned, and typically they are not seen in the immediate post-op period. Most commonly in the immediate post-op period, there could be improperly programmed parameters, and it could be inappropriate sensitivity setting or output depending on the threshold or the measured intrinsic P or R waves. Or there could be long refractory period. Sometimes patient-related causes may result in some troubleshooting related issues, and these could be reduction in the intrinsic P wave or R wave amplitude due to acute ischemia, ischemic drugs, electrolyte imbalance, or there may be change in vector of the intrinsic wave due to ectopic beats, tachycardia, ischemia, or bundle branch block. Sometimes external defibrillation may alter these settings of the pacemaker. And then there could be pseudo malfunction, as I said, which mean normal pacemaker operation in the with operation of certain complex algorithms. So let's look at two examples. This is the first one, a 70-year-old gentleman with sick sinus syndrome who undergoes pacemaker implantation, and next morning he had palpitation and the following ECG is recorded. And in this ECG, we see that there is a fast tachycardia with most of the beats being intrinsic with irregular RR interval, but there are certain paced ventricular beats with left bundle branch block and left axis deviation preceded by a pacing spike. And so if one were to ask, what does this ECG show? Does it show ventricular undersensing due to a lead malfunction, some pacemaker reset, a normal pacemaker operation, or the one could be saying that I can't say without seeing the electrograms and the interrogation of the pacemaker. But let's see what does the pacemaker interrogation actually showed. Now it sees that the pacemaker is seeing certain beats which are sensed and detected by annotated by an S, and then there are other beats which are in the refractory period and which are denoted or annotated by sensed refractory or SR, and then there are certain beats which are pace beat which are denoted by P. Now this is actually operation which is happening here is the noise reversion mode, and because of the continuous sense signals, the pacemaker paces at the lower rate, and this results in apparent undersensing. It looks like that the pacemaker is not seeing any intrinsic event and it is pacing at its lower rate. However, it is the operation of the noise reversion mode which happens when there is continuous refractory sensing and results in pacing at the lower or sensor driven rate in rate responsive pacemakers. It is typically present in all pacemakers to prevent pacing, inhibition of pacing during electromagnetic interference or noise, and especially in a pacemaker dependent patient who may become symptomatic, but sometimes can be seen in patients where you have intrinsically fast rate, typically seen with atrial fibrillation, where the ventricular refractory period is such programmed that the intrinsic rate is occurring in the ventricular refractory period of the pacemaker itself. And typically we see and we can recognize it in such scenario if the intrinsic rate is very fast, and the troubleshooting, maybe you can reduce the ventricular refractory period so that the intrinsic events do not fall in the ventricular refractory period and are properly sensed and does not result in occurrence of noise reversion mode. Let's go to the next case. The 85-year-old hypertensive with normal LV function presents with weakness but no history of syncope, and this is the ECG recorded. Typically, we see that there is 221 AV block with the ventricular rate of 43 beats per minute and atrial rate of 86 beats per minute, and the conducted beats show right bundle branch block with possibly left anterior hemi block, and this becomes a class 1 indication of pacemaker in this symptomatic patient. And but after a few hours, the another ECG which is recorded shows 1-to-1 AV conduction, but with same right bundle branch block and left anterior fascicular block, and the rate here at both atrial and ventricular rate is about 70 beats per minute. And considering the indication, the patient undergoes a dual chamber pacemaker with the RV lead in the apical septum, and the immediate post-implant ECG shows atrial sense and ventricular paced rhythm at rate of about 84 beats per minute. And the next ECG the day after shows this. You see that there is marked reduction in the QRS duration, and you see large pacing spikes which are typical for unipolar pacing. The patient was programmed in unipolar pacing mode because the auto capture in this generation of devices works only in the unipolar fashion. But what is the cause of QRS narrowing the day after? Now this is because since the rate of the patient the atrial rate of this patient has lowered down to about 70 beats per minute. In fact, here it is about 60 beats per minute. And we know from this patient's history that at lower rates, patient has 1-to-1 conduction, but the rate when increases above 80 beats per minute goes to 2-to-1 AV block. So at this rate, intrinsic atrial rate, we expect that the patient is having intrinsic AV conduction with right bundle branch block and left anterior fascicular block, and with the programmed AV delay, this results in fusion complexes, fusion of the intrinsic QRS formation along with the paced wavefront, and this results in narrowing of the QRS because patient has intrinsic right bundle branch block and we have placed the lead in the right ventricle, and this results in narrowing of the QRS. Another term that we typically use in patients with similar ECGs is pseudofusion. Now, the difference between pseudofusion and fusion is that in fusion, the QRS starts with the pacing spike, and there is intrinsic depolarization also occurring at the same time. And so the ventricular activation occurs as a result of fusion of activation from paced wavefront as well as intrinsic conduction over the AV node His-Purkinje system. In pseudo-fusion, however, the QRS is of totally intrinsic conduction, and the pacing spike just occurs a little after the QRS onset. That is, it happens because there is some time lag before the intrinsic QRS is being sensed, and by that time the lower rate interval expires and the pacemaker sends a stimulus. However, the paced stimulus does not result in any ventricular activation, and so if we remove the pacing stimulus from the QRS complex, it looks identical to the intrinsic QRS. So that is pseudofusion. Another term often used is pseudofusion, in which a QRS complex also has a pacing stimulus superimposed on it, but that pacing stimulus is from the atrial channel. So that is pseudofusion. Now, this patient happens to fall in the washroom when he was shifted to the ward and develops chest pain, which was traumatic. And as a result of the chest pain, the nurse records an ECG which shows now this. You see sinus P waves, QRS complex of right bundle branch block and left anterior fascicular block, but there is a large pacing stimulus which do not result in immediate ventricular or QRS complex onset. So you see that the QRS starts some time after the pacing stimulus, and that actually is intrinsic QRS, whereas the pacing stimulus does not result in any ventricular depolarization. So what should we call this? So this is loss of capture, and the cause is possibly due to lead perforation or dislodgement. And when we interrogate the pacemaker, we find that during unipolar pacing, there is no pacing at the maximum output. However, the bipolar pacing threshold is 2.25 volts at 0.4 millisecond, which is much higher than the initial threshold of 0.5 volts at 0.4 millisecond. So what could possibly have happened? Now we do the fluoroscopy and find that there is only marked or mild or very subtle difference in the pacing lead position in the RV. However, and hence the pocket is open for lead repositioning, and we find that the unipolar, when the RV tip is connected to the can or the pocket, there is no pacing even at maximum output. However, when we pace in a typical bipolar,
Dr. Bavaga, we are unable to hear you. There's some. They are lamenting.
Can you talk to the back end?
yeah, so I'll speak where you play the video. So during unipolar pacing in the through the pocket, there was no pacing at all, but bipolar threshold was about 2.25, and when we just paced from the anode, the threshold was 1. So maybe the lead moved a little bit or perforated a little bit so that the anode was connecting to the myocardium, but the tip was not capturing at all. It was away from the myocardium, and so we did the lead repositioning, and the patient was fine. So we go to the third case of 72-year-old gentleman with dual chamber pacemaker for complete AV block. Now, next day, complaints of palpitation, and we find that there is a tachycardia going on with pacing and in the ventricles and with a regular rate. And when we interrogate or do a freeze capture, we find that there is atrial flutter going on, but the marker channels show only one of the two atrial events, and this is because the alternate and they are blinded to the pacemaker due to a parameter called post-ventricular atrial blanking, and this results in alternate atrial events not being sensed at all, and so the pacemaker thinks that the atrial rate is half of what it actually is and tracks down to the ventricles, resulting in faster ventricular paced rates. Now, the ventricular post-ventricular atrial blanking was reduced from nominal of about 220 to 120 milliseconds, and then also the AMS base rate was reduced to 60 beats per minute, so that even if mode switch happens, the pacing does not occur at the nominal rate of 80 beats per minute. And after that, immediately you find that the atrial events which were blanked earlier go into the refractory phase and results in counting of atrial events correctly, resulting in automatic mode switch to the programmed rate of 60 beats per minute. So what are these blanking periods and refractory periods? Just a revision: ventricular refractory periods and PVAP are initiated by sensed or paced ventricular events. The ventricular refractory period is intended to prevent cell inhibition, such as sensing of T waves, and the post-ventricular atrial refractory period is intended primarily to prevent sensing of the retrograde T waves. The blanking periods are the initial portion of all refractory periods where sensing is totally disabled, and there is atrial blanking after an atrial paced event and post-ventricular atrial blanking after a ventricular paced event occurring in the atrial channel, which is the PVAB, and that is usually responsible for masking of the atrial flutter due to alternate atrial events falling in the post-ventricular atrial blanking period. Similarly, in the ventricular channel, there is post-atrial ventricular blanking, that is after an atrial paced event, and and ventricular blanking after ventricular paced event, which is again non-programmable to prevent the sensing of the pacing stimulus itself by the ventricular pacing lead. Now, going to the next case, a 56-year-old patient with hypertrophic cardiomyopathy and sinus node dysfunction undergoes a dual chamber ICD in 2006. The ICD replacement was done elsewhere in 2013, and post that, patient starts complaining of weakness, fatigue, and abnormal pulsations in the neck during walking. And the device interrogation done at our center now shows this kind of a rhythm. Now, the first channel is the surface ECG lead 3 with the channel markers. The second is the atrial EGM. Then there is leadless ECG from the device, the surface ECG lead 2, and then the ventricular EGMs. Now, you can clearly see that the ventricular EGMs are actually coinciding with the surface P waves, and the atrial EGMs are coinciding with the QRS complex, and as also are the marker channels. So typically, and if we do the pacing threshold test, when we pace the atrial channel, this results in capture of the ventricles, resulting in a QRS complex, whereas when we pace the RV through the device, it results in increasing the atrial rate and P waves following the pacing stimulus. So clearly, there is misplaced lead connections, and it is a rare entity, but it's actually unpardonable, especially in devices which have RF telemetry. All ICDs and CRTDs have RF telemetry, and even if the physician or the implanter has done it by mistake, it should be easily recognizable by the allied professional who is interrogating the device and assisting the procedure. And the only solution is opening the pocket and properly connecting the lead connector pins with the appropriate port in the device. I'll go to my last case. A 62-year-old gentleman undergoes a dual chamber pacemaker for complete AV block and develops palpitations a day after discharge. And a Holter tracing done shows repeated events of similar nature, wherein you see that the patient has an intrinsic rate which is in the normal range, and suddenly the rate becomes very fast with pacing occurring at faster rates. Now you see that it is initiated by an event which is marked by an asterisk, which is a PVC or maybe a junctional ectopic, and that results in retrograde conduction to the atria, which is then sensed by the atrial channel of the pacemakers, and then it is tracked to the ventricles, and then ventricular pacing occurs in response to this sensed atrial event, and this results in a kind of an endless loop, which results in this entity called endless loop tachycardia or pacemaker mediated tachycardia. Now, typically these pacemaker or mediated tachycardia or endless loop tachycardias occur at the upper tracking rate of the pacemakers and at or below the upper tracking rate, and you find that these can be initiated by PVCs or junctional ectopic beats or any event that results in transient AV dissociation. Now, if we talk about theoretically, pacemaker mediated tachycardia is any rapid ventricular pace rhythm that can occur with dual chamber or biventricular pacemakers, and that is whenever there is atrial tracking. And typically, patients who have atrial flutter or atrial fibrillation track to the ventricles at faster rate is also a pacemaker mediated tachycardia. Whereas if it occurs because of retrograde conduction of a ventricular event to the atria, which is then sensed and then tracked again to the ventricles, resulting in ventricular pacing and endless loop tachycardia, is a specific form of pacemaker mediated tachycardia, as is seen in the current example. And this typically occurs because of loss of AV synchrony due to a PVC, which results in retrograde activation of the PVC in the atria, which is then sensed by the pacemaker, and then that initiates an AV interval, and sometimes there may be prolongation of the AV interval to follow the upper tracking rate interval, and then this ventricular pacing synchronized to retrograde P wave results in endless loop tachycardia. So I think I'll end with this, and if there are any questions, I will be happy to answer.
Are there any questions to sir? So if not, we are going to, thank you sir, thank you for being with us. And so we'll go to zero fluoroscopy device implantation by Dr. Preetham Krishnamurthy.
Thank you for the opportunity for presenting this topic. I would like to keep it brief for the want of time. So, what is there a real need for zero fluoro device implantation? As a unit in Ramachandra, we have been practicing the zero fluoroscopy EP procedures for more than 2 years now, and we have been doing successfully more than 60 cases so far. But with respect to devices, it's still an unexplored area. The fluoroscopy exposure to the patient, operator, and the paramedical staff is of the paramount importance that we need to develop a program of zero fluoroscopy with devices. But at this point, do we really need a zero fluoroscopy? Most of the procedures require a very modest requirement of fluoroscopy. In fact, it's possible to complete most of the time a well-planned procedure within 50 milligrays. And by using 2 to 4 frames per second, most of it sufficient. But there should be always a scope to improve and reduce the fluoroscopy, and we must evolve to a point where we can use it as zero fluoroscopy. And zero fluoroscopy should always be attempted, especially in pregnant patients planned for procedures in the first trimester, or in a place where cath lab is totally not available, where we may have to do it in remote places, where most of the equipments that we can use for zero fluoroscopy are portable, can be shifted. So zero fluoroscopy should be done only when unavoidable. It should be kept really simple, no complex devices. First step is to rule out a left SVC to CS, and if required, a right-sided implant should be provided to identify the left SVC. Then, if a complex anatomy like patients with CCTG or anyone with a complete heart block, young patient, these are some of the groups of patients. In pregnant patients, we anticipate presenting at the middle age group with complete heart block who may require a device implantation. We may consider doing cardiac MRI, which can be integrated with the existing 3D anatomical systems like the CARTOMERGE, ENSIGHT systems. So, breaking down, the prerequisites will be good imaging, can be transesophageal, transthoracic, intracardiac, and an electroanatomical mapping would be an adjuvant to ease the device implantation. The important components of the device implantation would be the access, tracking the lead, positioning the lead, and providing the adequate loop. The foremost will be taking the access. We prefer to take a ultrasound access, and this is any probe covers. This regular arthroscopy covers are used for in our lab, and it's possible to take a guided ultrasound guided access, which I think in most of the labs now we are following. It increases the safety of the access, reduces the complication. Similar access can be done for the axillary vein. It is important to understand the ultrasound structures of the axillary artery and vein. Vein is a compressible structure, more caudally located, and this helps to identify. And most often we need to take it more laterally to avoid a intrathoracic puncture. The probe to be used must be a high frequency, a small footprint. It's also possible to use it within the pocket. So making a pocket and taking a puncture does not preclude a axillary vein access with ultrasound. It is always possible to do within the pocket, provided the appropriate sterility is maintained. It's also better to use a micropuncture access vascular kit, reduces the complication risk, especially when we are not sure initial stages where when we are going to an axillary vein access, we are not sure whether we can be confident to take the access. This is one of the examples where a left bundle pacing was attempted with zero fluoroscopy, and the next step would be to take an electroanatomical mapping. The impedance-based systems are better in this because we can change the catheters, and lead also can be tracked in electroanatomical mapping systems. So here a decapolar catheter was used to map the entire subclavian, brachiocephalic, SVC, RA, RV, IVC. And then the HIS was marked, the left bundle aspect where the W pattern could be obtained or the lead 2, lead 3 reversal could be marked, was marked as an appropriate choice of the left bundle area pacing. And the lead was tracked to the bipolar configuration. Here we need to know that it is difficult to track an electroanatomical mapping with the unipolar configuration. It will look like a dot, and it's difficult to identify where the lead would be. A bipolar configuration, we can identify both the cathode and the anode, and it would be easy to track. Here, most of the time, like in screwing the left bundle pacing, we need to remove the electrodes. While removing the electrodes, we will not be able to visualize the leads in the electroanatomic mapping, and hence direct visualization with echocardiography would be required at the time of screwing. This is one of the recent papers published in Circulation 2023. This is from the ICE LBB AP study, where they have attempted doing left bundle pacing entirely using the intracardiac imaging. This helps in a better visualization of the postero-basal aspect where the exact area of the left bundle has to be screwed. Here the Holmes view to see the right atrium, right ventricle RVOT, and then it is the ICE probe is pushed into the RV and clocked to see the postero-basal aspect. Here helping to exactly anatomically identify the usual site of the left bundle area pacing and screw the lead. So I would like to end the presentation with a case example where we did in the AIG, a 26-year-old female, 10 weeks pregnant, HOCM, recurrent episodes of syncope, not willing for termination of pregnancy, and she had in Volta multiple runs of NSVT and VT, and required a dual chamber ACD implantation. Similar to what I previously described, we did a detailed electroanatomical mapping using a decapolar catheter, marked the appendage, the sites of the RV apex, apical septum, and the SVC and VC to track the leads. Using the intracardiac echocardiography, we used a long sheet. A long sheet would be preferable to go for chambers which would be difficult to approach without fluoroscopy. And here we used a Merit 25 centimeter sheet, went into the RV, and using the intracardiac echocardiography, we positioned the lead at the apical septum and confirmed the location with the electroanatomical mapping. And then used a tine lead to get into the right atrial appendage. And then we adjust the loops according to the lead length. Just push the loops enough to provide adequate lengths. And this was the final position of the right atrium and right ventricle leads. So concluding, the zero fluoroscopy for devices is to be planned only for unavoidable circumstances, better to avoid in complex anatomy. A liberal use of anatomical mapping and echocardiography increases the success rate of implantation. Thank you.
Any questions that we can take for the whole session?
Thank you.
If not, I think we'll wait.
If there are no questions, we'll conclude this session and we'll go on to the next session. I call upon Dr. Anup Gupta. Yes.
Daljit, you can call everybody in so we can start. So, good evening. So, after tea break, last session for this evening, and the most interesting thing, CSP Symposium. And the first talk will be on ECG pattern of activation in pacing, his bundle, left bundle area, and left circle pacing, Dr. Vijay Raman.
Dr. Narasimhan, Chairperson, thank you for the invitation. Right. So when we first started doing his bundle pacing for patients with AV block, was quite interesting to see that we can reproduce the normal morphology that you see at baseline with his bundle pacing. And that was fairly easy to understand, straightforward. And subsequently, when we started doing it for infranodal AV block, patients who have HV blocks, then we were even more interesting to find that you can correct these conduction abnormalities, correct the underlying right bundle branch block, correct both distal conduction also in these patients. And so along with this, we learned different patterns of his bundle pacing. So you see the changes from non-selective his bundle pacing, where you have fusion between right ventricular capture as well as his bundle pacing. And there's output-dependent transition from non-selective to selective his bundle pacing. And not only this, you can also see transition from non-selective his bundle pacing, where there is initial delta wave, but very rapid subsequent activation, and then transition to right ventricular pacing. So all these transitions are very straightforward. You can see it with his bundle pacing. Unlike in left bundle branch pacing, these transitions are often harder to identify, but nonetheless, it's critical to know these things. And then there are patients who have only selective his bundle pacing, where you're capturing only his bundle, despite pacing at high output or not. And these patients usually have pretty good his bundle current of injury, as you can see here. And these patterns are easier to understand, but this change is a little bit more complex when you have patients with underlying conduction disease. So with these conduction disease can be either right bundle branch block or left bundle branch block. In this example, patient with fairly wide right bundle branch block, and here you have selective capture of the his bundle and correction of the right bundle branch block. And at a lower output, you only have capture of the his bundle without correction. So it's the same exact morphology. And this is reasonably easy to identify. And similarly, in patients with left bundle branch block, you have correction of the left bundle branch block in a selective fashion, no fusion, and you have no correction at a lower output. And these things can get different when you have non-selective capture. Sometimes it can be confusing. So here's a patient with a wide right bundle branch block. His bundle pacing at a higher output corrects the right bundle branch block. It also captures the right ventricle, so there is non-selective capture with correction. At a lower output, there is non-selective capture of the his bundle, but without correction of the right bundle. As you can see, the incomplete right bundle branch block, it's partially corrected, not by recruitment, but more by fusion of the right ventricle. And then at a lower output, you still have RV capture, suggesting that the previous morphology change was primarily due to partial correction by fusion of the RV and his bundle pacing without the right bundle branch block correction. And this can get a little bit, you can have the opposite of the same thing. You can have non-selective capture with correction, selective capture with correction of the right bundle branch block, and then selective capture of the right bundle alone. So you should be prepared to identify all different morphology changes that happens with his bundle pacing. gets a little more complicated when you have left bundle branch block and if the HV interval is a little prolonged. So in this case, you have a wider left bundle branch block, but pacing non-selectively, you see it looks like it hasn't really corrected. It's a fairly wide left bundle branch block morphology, still have these notched QRS complexes in V6. But most importantly, you can see the His to left ventricular activation time is significantly shortened if you compare it with His to stimulus to LV activation. That's about 70 millisecond shortening. But without this, just looking at this morphology alone, it may be very hard to identify that. But then there is output dependent change here. Now we have selective capture, but partial correction. So you still have some left bundle branch block morphology. And this morphology is actually an intraventricular conduction delay. So if you do left septal activation, this will be normal activation of the distal conduction system. So many patients may have mixed conduction disease, but pacing and a quick assessment of transition of QRS morphology helps you understand the type of disease. With the current options for cardiac resynchronization therapy, you have options of combining His bundle pacing with LV CS activation or left bundle pacing with CS activation. So it is interesting, but at the same time, it's very helpful if you map the His bundle quickly and pace and understand various transition that happens in these patients. But when you particularly don't have these transition, when you look at only 12-lead ECG, sometimes it may be hard. While thrush output dependent changes in morphology is the most helpful, but sometimes you can look at other morphological features in non-selective His bundle pacing. You should not have any plateau in lead 1 or V6. It should be a rapid activation. I'm sorry, these pictures are small. And when you have only RV capture, even though the QRS could look like a rapid activation, the stimulus to peak LV activation times will be prolonged. More than 100 milliseconds would suggest either no capture of the His bundle or capture of a diseased His bundle when the conduction times are very slow. And there will be a slurred pattern in lead 1 in AVL or V5, V6, similar to an incomplete left bundle branch block. When you look at activation patterns, selective His bundle pacing creates exactly the same morphology if you look at this ECG imaging type of activation. But non-selective His bundle pacing, you can see the LV activation is unchanged, but the RV septal activation is pre-excited. That's what creates our delta waves. So just understanding basic concepts of activation is helpful. And the previous speakers have talked about left bundle branch block and where the conduction disease is. This particular mixed population of patients who came for CRT and those who came for VT ablation, left septal mapping demonstrated about 2/3 of patients had what called as typical left bundle branch block. Despite having that morphology on surface ECG, only 2/3 of them had conduction disease in the distal His or the proximal left bundle. And the remaining third had normal activation of the His Purkinje system, so-called intact Purkinje activation. That is typical of an intraventricular conduction delay that His bundle pacing will not correct. So septal activation, you can see there's His, but no left bundle Purkinje activation during the left bundle branch block. And when you pace the His bundle, then you can restore conduction through the septal Purkinje system, suggesting that you're recruiting the previously dormant conduction in the left bundle branch block. So what does His bundle pacing do in terms of left-sided activation in patients with left bundle branch block? And how does it compare to biventricular pacing? So this particular study looked at ECG imaging and hemodynamic measurements in patients with left bundle branch block referred for cardiac resynchronization therapy. Here you can see surface ECG imaging activation of left ventricle. This is non-selective correction of the left bundle branch block, and biventricular pacing, simultaneously pacing RV and LV, resulting in artificial fusion of both. But nonetheless, his bundle pacing created significantly shorter QRS duration, shorter LV activation times, and reduced ventricular dyssynchrony index in the same patients compared to biventricular pacing, and resulted in greater hemodynamic improvement. This is the reason for most of us attempting his bundle pacing or left bundle branch pacing in patients requiring CRT, because you can do a much better electrical resynchronization and much greater hemodynamic improvement. It's a very nice slide from Shanmugha Sundaram, who looked at activation maps on the right and left side in patients with left bundle branch block, and then subsequent his bundle pacing, showing activation, complete normalization of left-sided activation compared to baseline left bundle branch block when you do left bundle branch pacing, as you can see in this particular example. So now let's look at some of the ECG manifestations of left bundle branch pacing. This becomes critical, and unlike his bundle pacing, left bundle branch pacing is a lot more complex in terms of understanding and appreciating the various changes, because there is no single morphology that tells you this is clear left bundle branch pacing. That led to early adoption of different terminology. And the term left bundle branch area pacing came into vogue because sometimes we couldn't tell which one is LV septal only pacing and which one is left bundle branch pacing. So when you have clear evidence for left bundle branch capture, only then we call it left bundle branch pacing. And when we have the features of deep septal, LV endocardial pacing, but no evidence for left bundle branch capture, then we call it left septal pacing. Unfortunately, there is different shades of left septal pacing. There is mid septal pacing, deep septal pacing. So a lot of it leads to confusion. But our goal should be to ensure that we have left bundle branch capture, especially if you're using it for cardiac resynchronization therapy. So let's go through some of the criteria for left bundle branch pacing versus LV septal pacing. This is what distinguishes when we call left bundle branch pacing versus LV septal pacing. So in patients who don't have left bundle branch block, these criteria becomes fairly straightforward. Most importantly, you need to have anatomical location of the lead in a deep septal location. We traditionally would like to keep it 1 to 3 centimeters from the distal his bundle, but you can get to the LV septum, distal left bundle branch, more apical location, but those are harder to distinguish at this point. But almost all of these patients, except for a small percentage, will have unipolar pace QRS morphology with the right bundle branch conduction delay pattern. You can have various shades of it in different QRS morphology, as you can see. But just having this pattern alone doesn't confirm left bundle branch capture. 95% of patients who have left septal left bundle branch pacing will have this morphology, but 5% may not have that. And if you don't have a left bundle branch block, you ought to see a left bundle branch potential. But presence of a left bundle branch potential doesn't confirm left bundle branch capture. Just like his bundle pacing, just because you record a potential doesn't mean you capture it, because you may need much higher output to capture it. So, but what do you need is you need direct evidence for left bundle branch capture. And the most accepted golden standard would be to see transition, clear transition from either non-selective to selective left bundle capture, or from non-selective to LV septal capture morphology. In the first transition, the stimulus to peak R wave times in V5, V6 will not change, because you're still, the early rapid activation is through the left bundle fascicles. When you have LV septal capture, there is a delayed activation of the lateral wall, so peak R wave times will change. The local electrograms will change, but those are very hard to interpret, unlike in his bundle pacing. One other criteria that Dr. Wong proposed is one of the most misunderstood criteria. So often you say patients should have short and constant peak R wave times during at low and high output. But if you're in LV septum, at high or low output, if there won't be any change, and R wave times maybe 80 milliseconds, that's not a proof. What he meant was, during advancement of the lead, when you're pacing from deep septal, there's a R prime in V1, and when you pace at a low output, that peak R wave times will be longer, and pacing a high output, it should suddenly shorten. And at that point, you advance the lead further deep, then there should be a shorter and constant R wave peak time in relation to what you got from deep septal pacing. So that is the actual number, not just short and constant R wave times. In early in our left bundle pacing experience, we always used the His bundle pacing lead in position, so we could measure the His activation time. So if you have no left bundle branch block, so pacing the left bundle branch should get to the retrograde His within 35 milliseconds. 20-35 milliseconds is the usual time. And if you see that, that's a clear evidence. And when you lose left bundle branch capture, that His activation time will get prolonged by another 20-30 milliseconds, sometimes even 40 milliseconds. So that change is also helpful in identifying. If you happen to map the left septum, which is more of experimental, you will see left septum activation as we showed earlier in the example. And program stimulation is one method one of my colleagues, Marek Jaszewski, showed, but that's a difficult criteria to prove. Often you need to demonstrate selective left bundle capture, but using the differential pacing by either single or double extra stimuli. And this is the one bad criteria we had early on proposed, peak R wave times of less than 80 milliseconds or 75 milliseconds. That's an arbitrary number. Depends on where in the septum you're pacing. If you're high up, 80 milliseconds may not still be a good number. And if you're very apical position, you may have 50 milliseconds even from pacing from the RV septum. So that is something you have to keep in mind. And that's a helpful criteria. It's a relative criteria to look at different things. So again, anatomical position is important. Looking for R prime morphology is important. Identifying a potential is helpful. But more importantly, if you see injury current on the left bundle potential, invariably you will have left bundle capture. So that's helpful. In deep septal placement, you can confirm by either angiogram, or you can do, you can connect the ring electrode, and if you see ring electrode injury current, that means your ring electrode is deep in the septum, unipolar measurement. That would be helpful. And your pacing at high and low output is always helpful. So non-selective left bundle branch pacing. And usually you will have no latency after pacing. QRS local activation will be, local electrogram will be pulled into the pacing signal. Peak R wave times are good at low output. When you go to selective left bundle branch capture, you're only capturing the conduction system for activation. And stimulus to QRS, there should be a latency. And you would see often a discrete electrogram. This becomes complicated. There are multiple components of LV septal myocardial fascicles. Sometimes you can capture part of it, and the electrogram changes may happen irrespective of the fact that there is no selective capture. So something that's difficult to interpret, unlike in His bundle pacing, it's very, very clear. So again, going through the same criteria. So this, when you're pacing at 3 volts, you don't have R prime, but at 8 volts you have R prime and peak R wave time is shorter. This is what the abrupt shortening of R wave times. And then once you advance the lead deep into the septum, then you have at high and low output, even when there is non-selective, selective transition, the peak R wave times remain short. And this is one of the criteria that's commonly used, but you have to use it appropriately in these patients. This becomes a little more complex when you have left bundle branch block, because some of the criteria that we used are not present because there's no challenging to find potential because there's no conduction through the left bundle. So all the other criteria in terms of anatomic location, the QRS morphology, and one additional way to look for left bundle branch potential is you can pace the His bundle, correct the left bundle branch block, and then demonstrate left bundle potentials. Or sometimes you can see PVCs as you advance the lead, you stimulate the left bundle branch fascicles, and you can see those PVCs with potentials, or you can have spontaneously conducted beats that may have potentials. But again, the most important thing here, that's why these findings are critical to know when you have this transition in morphology. So looking for these morphology changes, these are very subtle changes. I think Shanmuga will talk about some of these criteria. And if you have septal mapping, you can find it. And all of the other criteria are similar. And early on, we came up with a number of 90 milliseconds, and that's again an arbitrary number. That's no proof of left bundle capture. So you got to use combination of other factors to confirm that you have left bundle capture, especially if you're going to use it for cardiac resynchronization therapy. So let's go over some of those ECG changes. So left bundle branch block, and you can see in many patients with complete left bundle branch blocks, the left bundle potential can often be at the end of the QRS. And when you pace the His bundle and correct with a complete left bundle branch block correction, especially if you have selective correction, this is a non-selective correction, you can see the potential much more clearly. In this case, it's somewhat an assumption, but then transition during threshold testing is important. And here, even though the LV activation time is shortened by 95 milliseconds compared to the baseline of 140 milliseconds, the QRS morphology transition is helpful in identifying when you have left bundle capture or not. Here's another patient with left bundle branch block. So during His bundle pacing, you correct the left bundle branch block, and you should demonstrate left bundle branch potential. And that's helpful. Again, it's helpful to confirm you are in the left bundle branch area. That's not a proof that you have left bundle branch capture. Again, you need to see transition. And you can do program stimulation. In this case, actually a nice transition from having the typical non-selective left bundle pacing to myocardial only capture. So that's helpful in identifying that you have conduction system capture when you're pacing. The problem for transition is that only about 70% of the patients have these transitions. Many times, both left bundle and LV myocardial capture thresholds are identical. That's why program stimulation or differential output, or keep the output at 1 volt and adjust the pulse width, and you can sometimes see the transitions. And this is left septal mapping, showing when you have LV septal pacing, the activation of the LV septal myocardium is from base to apex. Unlike when you have selective capture, it's usually from apex to base, and there is then demonstration of left bundle potentials in. And then when you have, whether you pace at high or low output, selective or non-selective, there's always activation of the left fascicular system. That's helpful. And this is similar. I'm just going to skip this. And when we don't have any of this evidence for left bundle branch capture, then you call it LV septal pacing. So the reason why we don't use R-wave peak times is that there is significant overlap. If you look at R-wave peak times in patients who have confirmed non-selective left bundle pacing and LV septal only pacing with no capture, there's a significant number of patients who have common R-wave peak times. So if you just go by, let's say this is 80 milliseconds, there's about 20–30% of patients with LV septal only pacing will have less than 80 milliseconds. And you can also have significant number of patients with left bundle branch capture, but longer peak R-wave time. So its individual number is not helpful, but in this small series of patients, Marek came up with high specificity. I believe that 74 milliseconds is not good enough in many patients, especially women with, even with normal His bundle pacing, you can get peak R-wave times of 60 milliseconds in some patients. So you need to utilize all of the factors, compare with baseline, compare with His bundle pacing, then it's a lot more helpful. So this is a very early paper as we were beginning to understand a lot of these things, and now I don't use it all the time. It's helpful to some extent, but you have to use your judgment, look for more concrete evidence to get you confirmation of capture. So for left bundle branch block, we came up with a slightly different criteria. Our option is to correct left bundle branch block with his bundle pacing. In our experience, all you need to do is capture the his bundle and correct single beat at a high output. So we'll pace at maximum output, and you can correct the left bundle branch block and measure what your stimulus to peak LV activation time in lead V5 or V6 where you have dominant R waves, and then compare it with left bundle branch pacing. Here you can see with same patient with the proximal left bundle branch pacing, you have peak R wave times of 78 milliseconds. And when you have LV septal only pacing, you can still see nice peak R prime left bundle branch delay. Overall QRS duration between non-selective left bundle pacing and LV septal pacing is same. No difference in QRS duration. But peak R wave times are 103 milliseconds. So you're giving up 25 milliseconds of LV pre-excitation. So that's the amount of dyssynchrony you can correct if you have left bundle branch capture. So that's something you're leaving it on a table. It's almost like a very bad biventricular pacing. So you got to shoot for left bundle branch capture if you're going to do cardiac resynchronization therapy. And here's another example of a patient with left bundle branch block. His bundle pacing, peak R wave times of 96 milliseconds, LV septal pacing, 90 milliseconds, but left bundle branch capture, 67 milliseconds. So again, you have about 20 plus milliseconds of LV activation that we are leaving on the table. So when we compared this using delta R wave time, so compared to what you get with his bundle pacing and to what you get with left bundle branch pacing, we found that you need to have an 8 millisecond was the optimal ROC curve. Again, this was on a small series of 42 patients. But average, we find that at least 10 milliseconds is the number you need. The more distal you go in the septum, the larger the difference should be. Because if you're more proximal, minimum of 10 millisecond difference. But the more distal you go, the R wave time should be 10, 15, 20 milliseconds. So just again, that number is also not 100%, but it's much better criteria to help you. And there are various forms of pacing. You have his bundle pacing, right bundle branch pacing, and all of these are differently defined based on QRS morphology. And you can look at left bundle potential to QRS duration, and that helps you define where you are in the left bundle branch. If it's between 35 and 25 milliseconds, you're in the proximal left bundle. Further down, that interval is less than 25 milliseconds in fascicular pacing. And here's an example of pacing in the proximal left bundle branch. His bundle, you have the HV interval is 30 milliseconds, and at a high output, you capture the his bundle, and your peak R wave times 83. As you come down on the output, you only capture the right bundle, retrograde conduction through the left bundle. This is what we call as right bundle branch pacing. And at a lower output, you have selective right bundle capture with partial left bundle branch block morphology because delayed conduction through the. So these observations have led to defining another form. When you're beyond the his bundle and the proximal right bundle, you see these changes. And then same thing with left bundle branch pacing. Here is the proximal left bundle branch pacing with the left bundle potential of 30 milliseconds. But when you are distal in the fascicular system, your potential to QRS duration is shorter, and your peak R wave times also will be shorter. In LV septal pacing, you don't have any of those things. Ultra high frequency ECG has been used to define dyssynchrony sometimes, but this is confusing for me because this is measuring dyssynchrony between RV and LV. So overall, if you have in his bundle pacing, overall synchrony is maintained in the left side and even the right side to a large extent. Myocardial capture, there's a significant difference. But when you use this in left bundle branch pacing, you can see in mid-septal pacing, you have the least dyssynchrony. QRS duration can be okay, but when you do left bundle branch pacing, you have greater LV synchrony, but the cost of RV dyssynchrony. But we don't know what is the cost of this RV dyssynchrony in heart failure patients. So far, we haven't seen reduced hemodynamic improvement. So this ultra-high frequency ECG measures are not so much helpful if you're trying to achieve maximal electrical resynchronization on the LV side. Again, LV septal activation has helped us understand a little bit more. In this particular example from Rod Tung's group, you can see that activation, QRS, whether you have selective left bundle branch pacing or non-selective left bundle branch pacing, QRS duration doesn't change too much, but your activation pattern changes slightly. And pacing from different sides of the left bundle fascicular system, from proximal to distal, you can see that the LV activation times shortens as you go distally. So it's important to remember where you're pacing from. And you can pace very distally and capture only LV septal myocardium, and you can have a short RV peak time. Is that good enough? I don't have enough evidence to tell you that's not good enough, but measurements is not good enough. You can't use that to accept that you have great left bundle branch capture because you have a short R wave times. And again, this is another elegant study looking at hemodynamics and ECG imaging. His bundle pacing and left bundle branch pacing provides the best LV activation times and improvement in total ventricular activation time compared to biventricular pacing, and proportionately greater improvement in hemodynamic systolic blood pressure and compared to biventricular pacing. And similarly, when you have non-selective left bundle pacing, and then you have without anodal capture, the QRS morphology is different. And when you have anodal capture, then the QRS morphology is better. But what does it do in terms of improvement in ventricular activation times? It improves your overall total activation times. LV activation time is unchanged whether you have anodal capture or not. But it doesn't seem to improve hemodynamic benefits by having anodal capture. So just early on we thought anodal capture and correcting the RV dyssynchrony may be beneficial, but more acute hemodynamic studies are now showing that it may not be beneficial at all. So in conclusion, conduction system pacing results in varying ECG morphological changes and activation pattern. And these changes depend on the site of capture, the tissue that you're capturing, whether there is underlying conduction disease. Understanding all of these patterns is essential to achieve optimal conduction system pacing in an individual patient. Thank you.
Wonderful. Any questions or comment?
Dr. Vijayaraman is always enlightening. It's the 100th time I think I'm listening to your talks. His bundle pacing results in the greatest reduction in the biventricular activation time, the best of the synchronization. It has this ability to correct the bundle branch disease. We do not have tools, we probably do not have patience to pursue there. But I'm sure you have certain set of patients where you would continue to spend more time on that particular group of patients. May I know which is that group?
So, great question. I was able to do his bundle pacing for a lot of patients at the expense of a percentage of patients who have high thresholds, and some of whom may develop higher thresholds in follow-up. But with the left bundle branch pacing available, with good synchrony and all of those things and low thresholds, our acceptance of his bundle pacing's limitations have gotten, we don't want to accept any of them. But still, to answer your question, AV node ablation patient is one group that I persevered to get his bundle pacing. and I probably will get it in 85–90% of patients with AV node ablation. Always go for hispanal pacing. I believe that some improvement in tools are coming. The leads are probably longer screw, better steroid. That may change some of our practice. So those who have AV nodal block and normal HV intervals, and those who have AV node ablation, I would still prefer to have hispanal pacing. And then those with right bundle branch block, hispanal pacing will be my first choice to attempt before going to left bundle branch pacing.
Only one small question. So, the commonest of the features, what one looks at, you know, in centers like in our country, when somebody does the conduction system pacing, typically it's a left bundle area pacing. It is the occurrence of the QR and looking at the R wave peak time. But you convince us very well, it is not that, it is much more, because the septal pacing, where your LVAT can be really, really long, as compared to the selective left bundle, which could be 30 to 50 ms, and you shouldn't be going home unless you achieve that. It's a good theory. Where is this proof in a large group of patients where this particular criterion was used and demonstrated that this is better than the CRT?
So you mean stricter criteria?
Yes.
Yeah, unfortunately, it's not there. So even I'm part of publishing a large series, multiple centers. It is hard to ensure uniformity in all of the centers. Part of it is the criteria has evolved over a period of time, and people have started using different criteria. And the problem is it's challenging. It's unlike hispanal pacing, left bundle branch pacing is challenging. You need to take more time to convince, prove yourself. And that data needs to be collected meticulously. So not every center is doing it. Yeah. Just like bi-V pacing, you could place the lead anywhere you need to, wherever your vein takes you, and still that showed good outcomes. So the law of averages shows that majority of us get there. Not all patients get left bundle capture, but despite that, the overall outcome is still better than bi-V pacing. But I think it can be even better than that if we all persevere to get left bundle capture. That's
Thank you so much.
Sure.
Question. But the scar is in the myocardium is going to decide, right, whether this left bundle capture is going to deliver the clinical improvement. Where there is a scarred myocardium, you may not be able to trust the left bundle capture only to give you the clinical result.
Yeah, that's, so while I try to do conduction system pacing as a first line, I have a low threshold to jump to bi-V pacing, because bi-V pacing is still a great tool. So if you have scar and activation pattern is very delayed, or you get to the left septum and the left bundle system is diseased and you don't get rapid activation, it's time to move on to biventricular pacing, because it's still a great tool. I think Shanmugha has a lot more experience on looking at scar with MRI and choosing which type of patients you can successfully perform left bundle branch pacing. If you have mid-septal scar, posteroseptal scar, then those patients may be harder. The success rates are lower. If you see that, if you want to avoid wasting time, you can go straight to biventricular pacing in those patients. I hope I'm not taking too much time. If I do, please stop me, and I'll move on to the next talk I was supposed to speak. The future of conduction system pacing. These are my disclosures. I'll start with case presentation. These are my old experiences. 70-year-old patient, coronary disease, mild LV dysfunction, right bundle branch block, had paroxysmal AFib ablation, but still has more AFib. Sinus node dysfunction, and this was ECG at baseline. This is what led me to focus more on his bundle pacing early on. But what would be a normal step in these patients? Dual chamber with RV pacing, bi-V pacing, his bundle pacing, left bundle branch pacing. So any one of these are common options currently. It's all right. They're all within guidelines. conduction system pacing of IV is a 2A guideline now. But this particular patient had his bundle pacing. And what was striking for me was immediately after his bundle pacing, this patient's LV dysfunction corrected, and the dyssynchrony went away, EF improved to 50+%. And so there are many patients, even with right bundle branch block, with some LV dyssynchrony that improves because they're all conduction system disease-related dyssynchrony. Here's another patient with chronic left bundle branch block, EF of 42%. Sinus node dysfunction, proximal atrial fibrillation. And again, these are 10, 12 years ago, where options of his bundle by IV were not written in stone yet. But you could have used any one of these as choices, but I chose to do a dual chamber pacemaker with his bundle pacing, corrected the left bundle branch block. Once again, EF improved, T-wave memory changes went away right away within 4 weeks, and EF normalized. The reason for doing all of this was we learned over the previous decade that right ventricular pacing has a lot of adverse consequences. That was the main reason trying to go into either biventricular pacing or conduction system pacing to improve physiology, reduce all of those adverse outcomes. Again, this particular slide is very helpful. We all look at pacing-induced cardiomyopathy as a small percentage because a lot of argument was made, oh, well, I do hundreds of pacemakers with RV pacing, nobody develops a problem, or a very small number develop a problem. But what you see as a change in EF, drop in EF below 50 by 10%, is a tip of the iceberg. You have all the other changes that happens, worsening of pre-existing LV dysfunction, heart failure, and atrial fibrillation, and all the other things that we are unable to measure in time. So if you look at all of this, that incidence may be as high as 50% in terms of adverse events of RV pacing. We lived with it because we didn't have a better choice those days. Now you have better choices. And this was an observational series. We looked at 2 different hospitals getting his bundle pacing versus RV pacing. At that point, 5-6 years into our experience, we were able to get about 90% success in all comers. And so we were able to show a difference in death of heart failure hospitalization. But as we talked about, his bundle pacing has its limitation. So then came the left bundle branch area pacing, thanks to Dr. Wong, who came up with this brilliant idea. And that led to many of us in adopting left bundle branch pacing, and a lot more physicians adopting left bundle branch pacing because it's practical and easier to do. At least in the bradycardia population, it makes a huge difference. Here's another patient with chronic left bundle branch block. Came in because he had intermittent heart block, but LVEF was low for 20 years. And not because he had an MI, had coronary disease, but never had an MI. And again, our choice at this point had moved on from his bundle to left bundle branch pacing because of good thresholds. And you can see this particular patient, again, his bundle pacing corrects the left bundle branch block. We're happy, so move on to left bundle branch pacing, demonstrate that there is transition from non-selective to selective. That helps us confirm that there is left bundle branch capture. You can optimize AV delay, and you can have fusion LV left bundle branch only pacing and normalize the QRS. And this particular patient immediately normalized their LV activation pattern and improved ejection fraction. Again, there is a good number of patients who have left bundle branch block induced dyssynchrony that by providing conduction system pacing, we can rapidly correct them and also prevent worsening of heart failure in the future. And that's quite helpful. And as a result, we also saw that in patients who need bradycardia pacing compared to RV pacing, left bundle branch pacing gives similar outcome improvement with conduction system pacing. So then the question is, how often do you have true heart block that can be corrected with conduction system pacing? We looked at a continuous series of 333 patients. Almost half of them had so-called infranodal AV block or HV block, and a vast majority of them were clearly proven to be intraHISian because they had narrow QRS with HV block or they have split his potentials, or you can correct them with his bundle pacing. Or if you go on to do left bundle branch pacing, you see escape rhythm with potentials with left bundle to QRS duration being shorter than 35 milliseconds. The true incidence of infra-Hisian block, that means distal His disease, was only seen in 4%. How did we diagnose? Similar to HV block, we were able to see left bundle to ventricular block here, as you can see. This is left bundle potential. And pacing the atrium, we had 2-to-1 block, but block below the left bundle branch fascicles. Or you can have patients who have escape rhythm with the left bundle potential to QRS fairly long. This is about 95 milliseconds. This is a patient with diffuse conduction disease. And thankfully, these patients were very small. Even in these patients, LV septal pacing may be better than RV pacing. But if they need resynchronization therapy, these patients should undergo biventricular pacing. Because it was bradycardia indication, all of these patients underwent conduction system pacing, and we were able to achieve conduction system pacing or left bundle branch area pacing in about 97% of the patients. Then we looked at these patients in long-term follow-up, mean time of about 18 months. There was no difference in clinical outcome between his bundle and left bundle pacing. So at least it gives us more confidence that in these bradycardia patients, left bundle branch area pacing may be as good as his bundle pacing in terms of preventing death or heart failure hospitalization in the medium term. We don't know what happens in the long term, but that's something we should follow and understand that better. As a result of this, our hospital system, which has about 5 different hospitals, about 10 electrophysiologists, and almost all of them undergo conduction system pacing. I have to answer Dr. Pandurangi's question that most of them do left bundle branch pacing, and I'm the lone outlier doing some his bundle pacing. For practical ease and not having to worry about long-term threshold issues, that is the way of doing. And as we saw earlier, in cardiomyopathy patient, left bundle branch block, we can correct significantly. I'm sorry to use the same slides here, I'll skip this. And the reason to use conduction system pacing is that conduction system pacing results in greater ventricular resynchronization. And can that translate into outcome, better outcome? This is a 15-center, multi-center study. Shanmuga was part of this. And we were looking at 1,778 patients. In the absence of large randomized trial, this was the way we wanted to look at. And most of them, half of the institutions had conduction system pacing as a first line, and the other half bi-V pacing was a first line, and they would cross over in patients whom they failed. About 10% in each group had crossover to the other side. But nonetheless, this is an on-treatment analysis. There was significant reduction in death or heart failure hospitalization. So proving that conduction system pacing has added value on top of biventricular pacing. And this benefit was even more magnified in patients with left bundle branch block, because this is the group that benefits most from biventricular pacing. And even in those patients, conduction system pacing has, left bundle branch area pacing has better outcome. And this was associated with greater improvement in LV ejection fraction in all comers, as well as in those with left bundle branch block. Echocardiographic response, echocardiographic hyperresponse. There was a significant number of ischemic cardiomyopathy patients in this group. Despite that, these patients all improved significantly. And one additional finding that we looked at is there a sex-specific difference in outcome? We know very well that biventricular pacing does greater improvement in women compared to men. What we found was almost all of the difference between bi-V pacing and left bundle branch area pacing was in women. There was no difference in outcomes between men who underwent left bundle branch area pacing versus bi-V pacing. So women win much bigger in terms of resynchronization therapy, whether it's biventricular pacing or left bundle branch area pacing. Another important thing we thought about and looked very carefully into is what happens to the rhythmic outcome, because there was some experience in finding that bi-V pacing may increase arrhythmogenicity in a certain subset of patients. So we looked at this rhythmic risk, and interestingly, we found that the time to onset of sustained VT-VF was significantly better in patients who have conduction system pacing. So there may be another advantage. And even if we exclude patients with prior history of VT-VF and looked at patients who got primary prevention biventricular or cardiac resynchronization therapy, that incidence also was significantly less. And another important finding was if you look at patients who had no history of atrial fibrillation, the new onset atrial fibrillation also was significantly reduced in patients. So giving us more solid hypothetical evidence that conduction system-based resynchronization therapy may provide additional benefits in terms of reducing arrhythmic events. Over the last 10 years, we have had several observational and a few randomized clinical trials showing evidence for improved outcomes in, with CSP in CRT patients. And we try to use, while BIV is still super established gold standard for CRT, how can we use conduction system pacing to guide our CRT? And this has become our main mantra in our institution in terms of using conduction system pacing for CRT. If you have a narrow QRS, ought to attempt his bundle pacing if they need ventricular pacing and low EF, and his bundle pacing should be the option. And our goal is to get a threshold less than 1.5 volts. And almost always I want to see his bundle current of injury. That means I know my thresholds will be good and thresholds will be stable. If we cannot get that, then we go on to left frontal branch area pacing. On the other hand, if you have a wide QRS patient and your goal should be to attempt his bundle pacing first, not to permanently implant, but to confirm the type of conduction disease, prove that it's left frontal branch block, prove that it is complete left frontal branch block, not mixed conduction disease. In that case, then get left frontal branch pacing and confirm that you have left frontal branch capture. If you don't have left frontal branch capture, or you have a very long stim to peak, suggesting more additional conduction disease, then consider adding left ventricular lead or go into biventricular pacing. Here's an example of a patient with incomplete correction of the left bundle branch block, and then you combine left bundle with LV pacing to achieve either LOT CRT, or you can do his bundle plus LV pacing to achieve heart CRT. So we tested this hypothesis in a randomized clinical trial, 100 patients, BIV pacing. Sorry, this moved on. BIV pacing in 50 patients, randomized heart CRTs, basically conduction system guided pacing. BIV pacing was successful in 82% of patients, and 9 patients crossed over to his optimized pacing. In the heart CRT, it was successful in 96% of the patients, and 2 patients crossed over to biventricular pacing. And then looking at intention to treat analysis, the primary endpoint was change in LV ejection fraction from baseline. We had 12% improvement compared to 8% with biventricular pacing, which was statistically significant. The other endpoints were no different between, in terms of primary safety endpoint were similar, no major adverse events. Secondary composite endpoints were similar, and change in LV ejection fraction above 5%, the so-called echocardiographic response, was numerically greater but did not reach statistical significance, 80% versus 61% in this group. And the results were similar in patients with left frontal branch block. We know that there's a lot of changes in guidelines now. I'm not going to go through, as a previous speaker talked about some of the guidelines from the 2023 physiologic pacing options, where to use BIV pacing, where to use conduction system pacing. At best, we have some class 2A indication and class 2B indications, both for bradycardia and CRT population. But the next step would be, the future would be to move on to get evidence to prove that conduction system pacing should be the first-line therapy in all patients, whether it's bradycardia or resynchronization therapy. We are not there yet, but there are a lot of large randomized clinical trials that are ongoing. I'm part of this so-called left versus left trial, which is a 2,100 patients looking for death or heart failure hospitalization superiority over biventricular pacing. We are done with the initial preliminary phase. The funding institution is not industry, it's a PCORI. It's a patient-center oriented new kind of institution. They've released $2 million for us to do 60 patients, which we completed ahead of schedule. And then they released the rest of the $30 million to complete the trial over the next 5 years. But it's going to take another 5 years to get us the results. Meanwhile, there's a lot of other medium and smaller sized randomized clinical trials. The interest is huge, and the capability for many of us to do these trials and answer the questions is there. So I'm hoping to see more clinical trials, both from India and abroad, that'll help us to get there. I'm going to skip this particular slide. This is futuristic, telling you that I think we'll move on to have conduction system pacing guided therapy for all of our patients needing CRT. And there is another future, which is where industry is more interested in. There's YCRT, which is a leadless cardiac resynchronization therapy. And there's already people who have done combining leadless pacemaker with YCRT and even placing the left ventricular electrode into the LV septal region. And that has better acoustic windows. And so those things are feasible in terms of getting to the next level of totally leadless cardiac resynchronization therapy combined with EV-ICD or sub-Q ICD. So the days of leads may be over, but the cost of it is what is going to be holding us back. Hopefully we can get there. So I'll stop saying that conduction system pacing is feasible and safe. I think it's more elegant in its simplicity and our ability to repair the conduction system problem rather than replace it with artificial and suboptimal pacing. So let's get physiology back in electrophysiology. Thank you very much.
Excellent, excellent talk. Couple of questions from my side. Any crossover from left bundle area pacing to his bundle? Like, you're showing your algorithm, like when you fail the left bundle area pacing, so go to left RV septal pacing or a bi-V pacing. So any scenario or any situation where from left bundle you have moved over to his bundle pacing?
Yeah, there are patients where scar left bundle branch pacing is not possible, or large atria, large ventricle. The current tools don't allow us to get good support to get. My lab staff will often complain, why do you diss the hiss, which used to be our Twitter hashtag. So we'll go back to his bundle pacing fairly quickly and try to get good threshold, especially in patients with narrow QRS. In patients requiring CRT, if we struggle or if we know it's IVCD or if we have septal scar, we move to bi-V pacing as a first choice rather than struggle with conduction system pacing.
And second thing, if suppose you do a AV node ablation and you don't have any escape rhythm at all, so you're comfortable with the his bundle pacing, or you're going to give additional left bundle area pacing or a septal lead in that patient?
Yeah, so for a long time I was using his bundle pacing alone or his bundle plus CS in CRT recurring patients. But at that time I was able to accept this rise in threshold, but now with the left bundle branch pacing available, my practice is do his bundle and a left bundle as a backup lead.
Thank you. Any question from audience, or we moved?
So 60-year-old non-ischemic cardiomyopathy and LBBP, classic indication for a CRT, has no enhancement on gadolinium, no LG on MRI, and a 7-day ELR shows a non-sustained VT with 4 or 5 beats. What is the way to go? CRTD or LOT CRTD or CRTP alone?
So in the US, we have indication for ICD, and it's probably a problem of excess, so we routinely do CRTD. But Shanmu is leading the way. He did a nice study called Madurai left bundle branch pacing study answering the exact question. And so hopefully he'll follow them long term. So 1 year data showed that the incidence of arrhythmia and things were low with just a dual chamber pacemaker in those patients. And that's a perfect scenario. He's going to be able to answer, I guess. But in terms of outcomes, sustained VT or death, that's what we need to look to prove that you don't need an ICD. So he needs long-term follow-up. But right now, you don't have randomized study. So this would be a perfect scenario to do randomized study in India, whether you need an ICD. And Europeans have moved away from doing ICD for many of those non-ischemic cardiomyopathy patients. I think ICD is an overkill in many of these patients. You can do dual or CRT pacemaker, and if your ejection fraction doesn't improve or normalize, 6 months, a year down the line, then consider upgrade, because why provide extra cost to the patient? Thank you again. Apologize for a longer time.
No, thank you very much. It was wonderful. So next talk is method and maneuvers to identify conduction system capture during left bundle area pacing. Shanmuga.
Thank you, sir. Some of my slides will be overlapping with Vijayaraman's slide, where he has discussed about the ECG patterns of conduction system pacing. So we know that there is a lot of confusion in left bundle branch pacing. The terminology itself has a lot of definition. So we have a left bundle branch pacing, which we mean that we are capturing the conduction system. And we have yet another terminology called left bundle branch area pacing to make it as a simple procedure, where even the left ventricular septal pacing was also included. So a lot of fallacies are there in left bundle branch pacing. Remember, none of the criteria have mentioned QRS duration as an essential one. And presence of QR doesn't guarantee that you have captured the left bundle. Neither absence of QR won't rule out that there is no left bundle capture. And there is no absolute number of LVAT or RV peak time that could predict that you have captured the left bundle. So with his bundle pacing, it is obvious. It is like a difference between the cat and the tiger, where you'll be able to differentiate between his bundle pacing and septal pacing. But with left bundle branch pacing, to differentiate it from the LV septal pacing, you have to really use a microscopic camera to find out that black mole, so you can differentiate this left bundle branch pacing from LV septal pacing. So we have criteria. Broadly, we can classify them into ECG based, which Sir has discussed in the previous discussion, and the second one is electrogram based, where you may have to have the EP system to document this criteria so that you can confirm the capture of conduction system. So let's talk about some of the important criteria. So first and foremost is the RBBB conduction delay. So we are capturing the left bundle, we are pre-exciting the left ventricle, so obviously you need to have a right bundle branch conduction delay in the surface ECG. Remember, almost 1/3 of the patient with LV septal pacing can also have this RBBB conduction delay. So it's not a very specific criteria to be considered as a confirmation pattern for capturing the left bundle. So another important thing which we often neglect is presence of terminal S wave in lead V1, which signifies that you are into the LV septum and not into the left bundle branch fibers. So in almost 5% of the patient, despite the lead being positioned over the left bundle, you may not be able to see that QR pattern. So what we did was we have analyzed those patients where the QR pattern was not there, and we tried to do a decremental pacing. So when the output was reduced from a high output to low output, we could regenerate that QR in lead V1. So this is probably a little confusing thing, because QR pattern can be considered as an essential criteria. So this happens many a times when you have the lead proximally positioned closer to the distal his. Because of retrograde conduction, you may not be able to see the typical QR, or maybe because of associated interfascicular connection, where quickly the connection can move on from left bundle to the right bundle, though the real etiology of this QS to QR or masked RB pattern is still not known. So always try to perform high output to low output pacing when you are in the right spot and still you are not getting a QR pattern, so that you can unmask the QR when the output is reduced to low output. Left bundle potential, so it is essential to document left bundle potential in all those patients with non-LVBB morphology. So when you don't have a left bundle branch block in the native sinus rhythm, so you have to have the left bundle potential so that you can confirm, or probably it can give you an idea that you are in the left bundle area. So these potentials can be classified into two broadly. So type A, where once you deploy the lead, you'll be able to see the potentials, a giant sharp potential preceding the local ventricular electrogram. But at least in 30-40% of the patient, the potentials may be concealed within the negative current of injury. We can see here the first signal, which immediate implantation. There is a QS in the local ventricular electrogram. It is nothing but the local current of injury where the potential is submerged. So when you wait for 5-10 minutes, you can see the potential gradually evolving. At the end of 15 minutes, you can see a sharp, beautiful potential preceding the local ventricular electrogram. So this you must consider, especially when your lead is in the right position, you have a good current of injury, you have a good QR pattern, but still if you are not getting, especially when you are getting a transition, but still the potentials are not there, it's better to wait for 5-10 minutes to see the potential resurging from the negative current of injury. Like discussed in the previous session, if you have a baseline left bundle branch block and when you have either a temporary quadripolar catheter or a second 3830 lead, pace the His bundle, try to correct the QRS morphology so that you can regenerate the left bundle potential on your left bundle lead. So R-wave peak time. So sir has extensively discussed about the importance of measuring the R-wave peak time. So you should have a decrementation, like when you go from the right side of the left side of the septum, there will be a sudden decrease of at least 10 milliseconds as the lead moves in, and you have to show that it is short and constant at low and high output. So numbers, arbitrary numbers, it depends on which patients you are targeting. In patients with normal LV function, Wang has suggested 75 milliseconds, and in patients with LBBB morphology with cardiomyopathy, 85 milliseconds can be taken as a criteria. So these numbers are arbitrary. Rather, we have to aim for a short and constant LVAD by pacing at high and low output. So output dependent QRS transition. Sir has extensively discussed about the output dependent QRS transition. So here, the principle is we are deploying the lead over the myocardium with the conduction system fibers. So the lead is capturing two different substrates, the myocardial fibers as well as the conduction system fibers. Both has different conduction properties, both has different excitabilities and refractoriness. So once you reduce the output from high to low, you may see that at some particular point of time, one of the substrate may lose the conduction. So this will be reflected on the surface ECG as a transition QRS morphology. So we have a lot of different transition pattern available, selective to loss of capture, non-selective to selective, non-selective to septal capture. But among these four different patterns, the most commonly seen in day-to-day practice is non-selective to selective or non-selective to septal. So non-selective to selective occurs when your lead is banging the left bundle. So as your lead is really subendocardial, just below the LB subendocardium, deployed over the left bundle fibers, you'll be able to see this non-selective to selective QRS transition. So local electrogram will tell you the crumbled local electrogram during the non-selective capture will get separated, so you'll be clearly able to see this pacing artifact on the local ventricular electrogram. But more importantly, the surface ECG will give a lot of clues. The V1, there will be a transition from QR to RSR, or so-called the M pattern. And more distinctly or more visibly, you can see a distinct S wave in lead V6. So if the patient has a pre-existing S wave during non-selective capture, the amplitude will increase by at least 50%, or if there is no S wave during non-selective capture, there will be appearance of S wave. On AVR, you can see it will have a terminal rounded R wave configuration, which may sometimes be difficult to appreciate. Non-selective to septal, again, there will be a loss of R wave as the output is reduced from high to low, because your lead is probably little away from the left bundle, and only at high output, the lead is capturing the conduction system, and at low output, it is predominantly of LV septal capture. So you'll have loss of R wave, you can have a prolongation of QRS duration, and more rounded configuration of the R wave with prolongation of R wave peak time. Let us assume these three different scenarios. Let us see which of these can be excluded or which among these can be included as a left bundle branch capture. So when you see non-selective to selective capture, your lead cannot be anywhere else apart from banging the left bundle, so this can be accepted. So when you see this non-selective to septal capture, and if the transition is occurring at less than 1 volt, effectively telling that your left bundle branch capture is occurring at at least till 1 volt. So this can be accepted. But when you have a non-selective to septal transition at more than 2 volt, that means that less than 2 volt, you have loss of conduction system capture, you have prolongation of the LVAD. That means that your lead is still away from the conduction system. You may have to go still further in. So this third category of patient needs at least 1 or 2 additional turns to enter into the left bundle zone. So V6, V1 interpeak interval, so though the terminology looks cumbersome, so it's very simple to understand. So if you understand the basic concept, so V1 is the RV peak time of V1 can be taken as a surrogate of RV activation, and V1 RV peak time in V6 can be taken as a surrogate of LV activation. If there is a non-selective capture, so we know that when you capture the conduction system, the left ventricle will be activated first and the right ventricular activation will be delayed. If there is a selective capture, the left ventricle will be activated still further earlier, but the right ventricular activation will be pushed further away. But when you have a septal capture, both will be pushed away. So it will indirectly imply that there will be a near simultaneous activation of both the right ventricle and left ventricle. So when you measure this difference, when there is a non-selective capture, since LV occurs first, followed by RV, so you will have a positive V6, V1 interpeak interval delay. It will be more than 33 milliseconds. But when there is a selective capture, the RV activation will be still further pushed away, so the duration will be prolonged, so it will be more than 44 milliseconds. So shorter the V6, V1 interpeak interval duration, the lesser the chance of capturing the left bundle. It is more of a LV septal pacing. Program deep septal stimulation, so this is little cumbersome, so you can do it, just pace from the lead tip, do the program stimulation and see the change in QRS morphology, change in QRS axis, and the change in RV peak time once you reduce the coupling interval. Template or fixation beat, as the lead travels rapidly from right side to left side of the septum, you can see PVCs getting generated. So these PVCs are called as template or fixation beat. The morphology changes as the lead traverses from right to left. So once you get a PVC of a QR pattern, so that confirms that you are somewhere into the LBBB area. But when you get a PVC with the M pattern, you can see the last generated PVC with a typical M in lead V1. So these are the PVCs which directly comes from the left bundle. We call it as an M beat. So this can be considered probably as a marker of selective left bundle branch capture. Almost, it has a sensitivity of almost 100% and specificity of 96% to confirm selective capture of left bundle. So probably once you see this PVC of this M pattern, you don't have to give any further rotation, and you can name it any criteria for left bundle branch capture. So it will be satisfied once you get this PVC of M pattern. Though a lot of criteria are available in day-to-day clinical practice, we'll not be finding time to see all these criteria to say whether we have captured the left bundle or not. So we go by the simplified criteria, see whether you are getting a pre-excited left ventricular activation pattern. So V1 should have an RBBB delay. So in 5% we know that it may not be there. So do high and low output pacing, unmask that RBBB delay. And any one of the other following criteria. So output dependent QRS transition, either non-selective to selective or non-selective to septal. And a short and constant LVAD. So if you have any one of these criteria satisfying, then probably that will confirm that you are probably into the left bundle. The presence of potential, because many of the times the lead still can pick up the far field potential away from the left bundle. So this cannot be taken as a conclusive evidence for left bundle branch capture, but this will tell us that probably you are going in the correct direction. So you can get the measurements of LVAD to see whether you have reached into the left bundle or not. So to put it together in a nutshell, so these are the things which probably you can take it as an endpoint for giving further rotation. This is the most frequently asked question: when should we stop giving rotation when you are doing the procedure? So when you see this non-selective to selective capture transition, that means that you are banging the left bundle. You don't have to give any further rotation. Short and constant RV peak time, especially with an abrupt decrease of less than 10 milliseconds, again you are in the left bundle. Presence of M beat, so even before going for the measurements, when you are generating PVCs and we are getting this M beat, that will tell you that you have reached the left bundle. You don't have to give any further rotation. The absolute value of unipolar impedance varies between lab to lab because it depends on a lot of other variables. But in our lab, so if we are nearing 450 ohms, we don't give any further rotations. That almost confirms that you are reaching the LV blood pool. And this concealed potential, it's the one which I have shown in the third, fourth slide, where the potentials will be really concealed inside the negative current of injury. That again tells you that you have injured the left bundle, there is a good current of injury, so further rotation is going to give perforation. So among this, probably this non-selective to selective capture transition can be taken as a gold standard criteria, and we go by this criteria. So nearly almost 95% of our patients will have this non-selective to selective capture transition. So to conclude, it's essential to capture the conformation of for a conduction system capture so that the patient will derive maximum resynchronization benefit. And the majority of the criteria are based on difference in the excitability and conduction pattern of the His-Purkinje system and the myocardial fibers. So dynamic pacing maneuvers will often help us in confirming that we are capturing the left bundle and not the septum. Thank you.
Are there any questions for sir? So you'll go ahead with the, okay.
Shanmuga, do you operate differently when you do the procedure in Madurai versus when you proctor at an unfriendly place? Are your criteria?
I go by the same criteria. So when you get this non-selective to selective transition, I think you don't have to check for any other thing. You definitely, the capture will be confirmed. So that depends on whether you are doing with the EP lab or without EP lab. So when you have the EP lab, you can do all the pacing maneuvers to confirm it. But when you don't have an EP lab, we may be simply having a 12-lead ECG or a TMT machine which will be running in front of your eyes, where you can just go very hardly by seeing whether the LVAT is two small boxes or not. But yeah, so doing without EP labs, especially in patients with underlying cardiomyopathy, I think better we have to rethink twice before doing it without EP system.
Great talk as always, Shanmuga. One question is this generation of the PVCs, how uniform is it? Does it depend on the rapidity of your rotation? Because I personally observed that I couldn't get PVCs in some of the cases. And secondly, with the stillet driven leads which are coming up where we are giving, I think, more slow and controlled rotations, do you find a difference in the occurrence of PVCs or MBEAT?
Yeah. So PVCs are, of course, definitely there is a learning curve in generating the PVCs. Our first article in 2020, we have quoted 56% incidence. And the second article, if I remember better, I've quoted some 88. So now it is 95. So definitely there is a learning curve in generating the PVCs. It purely depends on the rapidity of the rotation which you are going to give, because only that rapid rotation is going to irritate the myocardium and it's going to generate the PVCs. So that generation maybe for a beginners or who is going to just start the program, it may be difficult, but the excellent alternative modality or alternative technique is to do continuous pacing. So that can be very well done with styler-driven leads, where you can continuously pace, you can see the QRS morphology changing, you can see the impedance trend which is going on. But that can be even done with the lumenless pacing leads. So they're going to come out with the revolving connector pin. So once it is available, probably in a matter of another 6 months or 1 year, so that problem of the PVC generation will settle. So till then, probably we can use the other criteria to see whether we are capturing the bundle or not.
Thank you.
So if there are no questions, then we can go with the second talk, sir. Complications of CSP and how to avoid them.
The complications, we know none of the scientific discoveries are without any complications, and even the CSP is not immune to that. The complications can be broadly classified into those procedural related and those related to anatomical challenges and follow-up issues. So we are deploying the lead inside the septum. So anything inside the septum and including the septum is more prone for injury when you are doing left bundle branch pacing or the so-called deep septal pacing. So this is one of the cases from Vijayaraman Search Center where the patient had a hemodynamic compromise and later diagnosed to have a big septal hematoma. So luckily the patient was managed conservatively and the septal hematoma resolved over a period of 2 months' time, and so majority of the septal hematomas which we tend to hear on the reported in the case reports, they tend to resolve over a period of time, and nothing aggressive management is required for these sort of patients. Even this giant hematomas was managed conservatively. And we had a very, in our very early part of our experience, we had a aborted MI, the ST elevation occurred in anterior leads. We could hypothesize that maybe because of some septal artery injury producing intense vasospasm, or because of some air entering into the left-sided circulation. So that would have probably produced. So we did a coronary angiogram immediately, but still we could not find any abnormality. So probably there is something to do with the arterial circulation in the septum, so which might tend to get injured and produce this sort of complication. So we tried analyzing the troponin values just because we are tunneling the myocardium, and we just want to know how bad the septal injury is when you are doing the deep septal pacing. But luckily, what we found out was the amount of troponin release was less than a conventional SVT ablation. So that means that the amount of injury is very negligible, probably you can take it. But how to avoid it? So the idea is to avoid doing it. So when you go closer to the His bundle, when you are very closer, higher up in the septum, just within a centimeter below the His bundle, the arterial branches will be crowded. So if you are deploying the lead there is a high chance of injuring in the arterial circulation there. And better to avoid multiple attempts, because multiple attempts is going to give multiple injury in the surrounding myocardial tissue that might again predispose the patient for developing the hematomas. Coronary venous sinus visualization, this is probably more of an iatrogenic thing. So when your sheath is very well opposed to the septum and you are doing a forceful injection, probably the septal dissection will occur, and that will track into some of the coronary sinus veins, and which in turn will drain into the coronary venous sinus. So this can be better avoided by limiting the sheath angiography. So if you want to know the depth of the lead, that can be better assessed by seeing the electrical parameters, pace QRS morphology, and a simple post-procedural echocardiography. Sheath angiography can be restricted only for those patients who are really requiring it. Even if it is required, it's better to give a gentle push to the lead so that the sheath will come back, and then give injection so that you will not create the septal dissection, so which predisposes for the septal hematomas and the venous sinusoidal visualization. So micro dislodgement, this happens especially majority of the beginners when they are, because here we are deploying through the sheath. So when you are removing the sheath, there is a high chance that you may micro dislodge the lead, and the micro dislodgement can be easily diagnosed by checking the parameters after removing the sheath. So what we observed was the unipolar impedance will jump up. For example, if it was 550 when you deployed the lead, and if you are seeing after removing the sheath, if it is 700, many of the times you may see that you might have created micro dislodgement. And even there, the pace QRS morphology will differ. The left bundle branch capture threshold will go up. For example, when you had a septal non-selective to septal transition at 1 volt, so after removing the sheath, you will be having this non-selective to septal transition at 3 volt. So what we adapted was we tried removing the sheath very rapidly. So this initial, I didn't cut the idea. So the initial hub of that sheath, whether it is with a Medtronic or a bot, so that will be a little tough. But once the tough part is done with a careful dissection, but once that is done, and the remaining half of the sheets can be removed very rapidly, and we can see the lead remains as it is. And so this I have translated for even the CS leads. I've tried it in CS leads as well. I did not displace the CS lead. So this is one important strategy which will help us in minimizing the micro dislodgements. Septal perforation, this is probably one of the most feared complications in the beginning, but so when you understand the electrophysiological properties of it, you will be able to diagnose it on table, and it's a simple strategy. Just remove the lead from the site and put it at a new site. The most important parameter is to look for the current of injury. In fact, the first thing we look for once after deploying the lead inside the septum is to look for the current of injury. If it is absent, you might have perforated. If it is present, that means that your lead is still inside the septum. So once you are perforated, the main idea is to remove it from that site and put it at a new site. So we are working with the fluoroscopy. We don't have a 3D system to confirm that we are entering into the new site. So how to confirm it with a 2D system that you are going through the new site? So one is by fluoroscopic landmark. You may be little above or below that old site, but it's very difficult to predict. But we can do a pace mapping. So for example, if the first site had all 3 positivity, inferior leads, all 3 positivity, the next site should have a different QRS morphology in the inferior leads. So either it can go up or come below. For example, the second site can have a 3 AVF negative and 2 positive. That means that you are probably going to target a new site. And the most important thing which we always see is the PVCs. Since the same operator is going to deploy the lead, the same amount of force will be required to deploy the lead. So if there are no PVCs, the previous first attempt you are generated PVC, in the second attempt if you are not generating any PVCs, that means that the lead is probably going through the same site and it will have a specific hyper movement. If you give one turn, the lead will go twice inside the septum. So those sort of hyper transmission of the rotation will tell you that you are going in the same site, so better avoid that and put it in a new site. So septal behavior, you have to understand this septal behavior to avoid future complications, because there is one important variety of septum which we have observed in 3.5% of the patients, what we call it as a cheesy septum. So here it occurred in normal LV function patients. All these patients had a normal LV function with AV block. We didn't find any scar in the septum, but we didn't do MRI for these patients because they had normal LV. But these patients, when we give just 1 or 2 turns, the lead was just floating from RV into LV across the septum. So these septums, there is something to do with the septal texture, which probably is responsible for this hyper movement of the lead. The main problem was we had almost 9 of such patients. The initial 2 patients had dislodgement on the very next day. So after that, we have deferred doing the procedure in the remaining patients. We identified it by seeing the lead traverse time. So lead traverse time is nothing but the duration required for the lead to move from the right side to the left side in the LAO view. So that was 8.5 seconds for the normal septum, and it was 3.5 seconds for those patients with the cheesy septum. So if you find scar, so this we can pre-predict it. If you do a cardiac MRI, if the septum is scarred, so then probably you will see this third response where the lead will not go, it will just simply buckle. So it is very important. So better to avoid doing this deep septal pacing or left bundle branch pacing in patients with this cheesy septum, because you will find dislodgements more frequently. Anatomical challenges, you may have spine disease where you will be difficult to identify the septum. So you can do CT angiography here to see whether you are really opposed to the septum or not. This particular lady was having a really kyphoscoliosis with an LBBB morphology. So we had to do some sort of conduction system pacing to correct the QRS morphology. And in kids, we may find it really difficult, but this was one such case where really the patient required a CSP because of pacing-induced cardiomyopathy. That was the baseline LV, where the ejection fraction was just 17%, and we could do a single-chamber resynchronization therapy with the left bundle, and this was after 2 years where you could see the ejection fraction was really improved. So here you have to adapt your strategy. You have to pre-plan it because the septal thickness was just 6 millimeter. So here it's better to deploy the lead little obliquely. So what we did was just gave some 1 or 2 turns to get the screw in, then I lifted the sheath little up so that the subsequent turns deployed it little obliquely, so the additional length was deployed to account for the stability of the lead. And right-sided implants will be challenging. The current tools are not really meant for doing right-sided implants, but still you can do it. So you have to again adopt your strategy, go into the LV and pull back the sheath and give a specific counterclockwise torque so that you can deploy it. The support will not be as good as from the left side, but still you'll be able to do it. So initial few cases we were giving that 90-degree bend for that SVC subclavian junction, but after that we realized that that probably is hindering that counterclockwise torque. So in subsequent cases we went straight away without giving the 90-degree bend. We could do the procedure. So this is one thing which is very important these days. We quite frequently use the left bundle branch pacing lead for sensing the ventricular arrhythmia. So we had 30 of such patients where the left bundle lead was used in either a lot ICD or lot CRTD for ventricular arrhythmia sensing. So what we found out was 90% of the patient had appropriate arrhythmia sensing, and in almost 11% there was an inappropriate detection of ventricular arrhythmia. So luckily all these arrhythmias didn't receive any shock therapy, and this occurred in one patient, in only one patient with a specific variety of an ICD, and it all occurred because of a T-wave oversensing. So now too much is also not too good, because too much of sensing is going to produce oversensing. So we had to adjust sensitivity to avoid this T-wave oversensing. So when you are planning the left bundle lead as a sensing lead for ICD, it's better to choose a device with a good T-wave discrimination algorithm so that you will avoid this inappropriate sensing in the future. So late perforation, there's a lot of complications still occur during the follow-ups. So you have to follow these patients carefully in the clinic. So this was one case reported from Dr. Parikshit where the lead went into the LV cavity and it was actually pacing the papillary muscle. So bipolar pacing didn't show not much of difference, but the unipolar pacing, there was a complete loss of capture. So that gives again the importance of doing both unipolar pacing and bipolar pacing during follow-up, so that you will not missed this late perforation complications. So dislodgement still occurs. So our series, the 4.5% loss of conduction system capture can occur either because of micro or macro dislodgements. The extraction is the big query. So we had extracted up till 2 years, and sir has extracted a 3 years old lead. So probably only the future, when the lead dwelling time is going to be more than 8 or 10 years, then we'll know the real difficulty in extracting the 3830 leads. But at least now this lead can be easily extracted because the dwelling time is, on an average, is just 3 or 4 years. With the stylet-driven leads, a lot of other complications were reported, like helix fracture, distal conductor fracture, septal coronary artery fistulas, all this because of the bulkiness of leads. But we had a case of a complete ring fracture, distal conductor fracture from a 3830 lead after 2 years. So this only tells you that the job is not done within the, just once you finish the procedure, you have to follow the patient carefully in the cath lab to look for all the future complications. So it's very essential to confirm that you're capturing the conduction system even during follow-up, because at least 3 of my patients for whom I did a LBBP correction for LV dysfunction had come back with recurrence of LV dysfunction when the patient had loss of conduction system capture. So really I had to optimize the parameters, and in fact I had to redo the procedure in 2 of such patients to again resynchronize the heart. So it's very essential to have a strict device clinic to follow this patient so that you can pick up the complications early and give them a treatment. Thank you.
So for the want of time, we'll allow only one question if there is any.
Shanmugh, excellent talk. Question is, once you have a septal hematoma, does it mandate removing the lead, and how do you manage, like the thresholds in a septal hematoma, how stable it would be?
I think I'll pass on the question to Vijayaraman sir. He's here.
Just one more thing to you, Shanmugh, that the septal transverse time, there would be a lot of inter-operator and intra-operator variability. So this 3.5.
So this was done by a single operator, so there's no worry, and counted by a single observer. So there's no inter-observer, inter-operator variation.
We'll move on to the next talk, which is stellate-driven reads for conduction system pacing by Dr. Ullas Pandurangi.
I wanted that also is okay. No, but I want to have the same. All right. So let's talk about stellate-driven leads. When is a question. When Medtronic stool fail, the intraventricular septal behavior, or the definition of the scar or a fibrotic septum, were based on the performance of the Medtronic sheath, which is weak, which is kinkable, and there is a lead which is very floppy, doesn't have a strength, and is lumenless. So just because when you used this Medtronic sheath and you were not getting inside, don't despair. So that's number one. You have not done CSP before. My advice is pick this up. You know why? You have been always dealing with some stiffer stuff, not kinkable ones. And you're going to have leads which have been your friend for a long time. They have a stellate, and you can drive with a stellate-driven lead more confidently. So this is indication number 2. Indication number 3, if you are like me, and that is you like variety. They are sturdier. The sheets which deliver the stellate are sturdier, they are bulkier. so no interventricular septum can buckle. It will just bow. The penetration is easier, and I think the bulk and the stiffness when it comes to the septal pacing is important. Delivery sheets as compared to the Medtronic, as I said, they are stiffer, but also they come with a larger outer diameter, and hence the inner diameter is also provides the room for the stiletto-driven lead. The sheets of all the companies, they also have given you choices with respect to the curves and with respect to the length. So you really have a lot of choices if you're going for stiletto-driven leads with these sheets. There is another issue when it comes to the lumenless lead, for example, 3830, or some other leads, and that is something to do with the long-term prospects about the performance of these leads. And what is that? That is called the hinge length. There is certain region along both the inner and outer conductor. There is a region which is vulnerable for a kink. So when it comes to, for example, the select secure is the largest of the hinge, and these two have a small, and the tendril, for example, abort, has no single hinge. All right, so the point here is you have these three, which are probably better. I do not know how does it translate into the future performance. The hinge is much, much less, and then if you have not penetrated the septum, covering this hinge point, you may end up in having some problem in the future. Even if the anodal capture is there, it does not reflect that it has really gone into the septum. So when you are using a lumenless lead, beware that you are dealing with a lead which has a longer length of a hinge. And hence, you have this kind of a vulnerability, even with Boston or a Biotronic, and the abort seems to be a little more firm. When it comes to the lead, there is a problem with this stiletto-driven leads. The helix material is platinum iridium alloy among this, and then the Medtronic, I think the platinum titanium helix alloy makes it, I think, sturdier. Because whenever you are trying to reposition and are pulling it out from penetrated into the septum, it is very, very hard to see the Medtronic helix getting distorted. However, the stiletto-driven leads are more vulnerable for distortion whenever you are pulling it out from inside the septum. There's another issue, and then that is the so-called the length that is available for slitting. The Medtronic lead is quite long, and then it is quite easy to slit. Whereas the length of the lead, the stiletto-driven leads and the sheets of these companies, they give, the length is much less. So you got to be a little careful while slitting. That is a little bit of a challenge in the first few cases. And the recommendation by all the three companies which sell this stiletto-driven leads for the conduction system pacing, they ask us to prepare the lead outside, expose the helix outside, and then get inside, which I do not practice, because it is possible with the helix retracted and just at the tip of the sheath, when you touch the tissue, you will be able to record the local electrogram, and you could actually do pacing studies. So it's not necessary to protrude the helix in vivo. The greatest advantage, and that is what gives you more confidence when you are using the stiletto-driven leads, is the ability to continuously monitor all the electrical parameters continuously while you are deploying the lead, bringing out the helix, pushing it inside the septum, is because you can have that alligator clip at the cathode on the stellate which is inside the lead. So you can go on looking at where are you just before penetration into the septum, and as you go, you would continuously see what is going on with the morphology, what is going on with the impedance. I think this is the greatest of the attribute for the stellate-driven leads. There is a safety that is there when you need to exactly stop. I think this is a safer way of doing conduction system pacing. Actually, the Abbott is, I think they are phasing it off. The Agilicis Pro, but still, I think if whenever that is available, I ask the company, and then I actually pick up this, which is kind of a bulkier, which is is a deflectable with only a primary curve, but you can make reshaping of the distal curve into a secondary curve. Whenever I think I am not getting the his bundle capture with the non-Agilicis Pro sheets, I go for this. This is always there in the lab. It's because this is the one which has the greatest of the strength, and then of course you have got a bulkier lead, and I think this is what is I think more convenient if you are a fan of his bundle pacing. The stellate-driven lead sheets could also be used for in case if you are forced to do it from the right side. Well, it could be more easily reshaped outside the body. And there are many, our interventional cardiologists have taught us how do you make a curve either with the steam or putting it in the hot and the cold water. And I think it maintains that curve. And this is a lot ICD from the right side, which is with a good result. So the stellate-driven leads with the sheets, it is absolutely safer and then probably more convenient even from the right side. Then there's one more point about the so-called helix getting retracted when you are penetrating into the septum, which is actually correct. It should be happening because these leads are not supposedly to be used the way we are using it for the septal pacing or a conduction system pacing. So when you are pushing the lead with the helix protruded, when you start rotating the body, helix starts coming inside. And hence, you require something known as a helix fixation tool. Boston does not have a helix fixation tool. However, Biotronic has, this is actually for a stellate introducer, which could be used as a helix fixation tool. I will show you, this is not only for the Biotronic lead, this could be also used for the Chandril and Ingevity leads. You can rotate to bring the helix out and give extra turns and push this onto the proximal silicon here, and then you can convert the entire the lead as a single unit. So when you push that onto the silicon ring, it becomes single unit, and there is no fear for the helix to come inside. The helix retraction is unlikely. I have a problem with Abbott helix locking tool, which they have recently introduced. Is because if you use the way they say, they push it inside and then bring the helix out, I have consistently noticed that it starts rotating backwards. It's not a good feeling. So I cannot use this for protruding or extruding the helix. I want the clip to be used for the helix to be extruded, and maybe you can push this over that. So this the turns come back, which is not a. So I use biotronic stellate introducer to make the helix fixation tool for all of them. As I was saying, this lead repositioning may cause more often with the stellate-driven leads. I think there is some problem with the strength of this. Invariably, all of them, you have the helix distortion, and because these leads are not isodiametric, meaning the body is a larger profile than the helix, if you start rotating the body into the septum, you end up in crimping of the insulation. I'm not very sure how is this going to be reflecting about its performance in the long term. So helix distortion is okay, but if it has resulted in the crimping of the insulation, I think the performance can be an issue. Next, well, occasionally Medtronic sheath have created septal hematomas, but the septal hematomas and like this, the tendril or the solia, because of its stiffness, I think you need to be a little more careful when you are pushing it hard against the septum with this, because they are quite sturdier. And then in your desperate attempt to get it into the proper position, you may end up in having this kind of a septal perforation or getting into the intraseptal veins or into the pericardium. So you may have to be aware of it. Recently, there is this interest in the defibrillator lead for a left bundle area pacing. For example, with the introduction of the CPS locator 3D from the Abbott, which has come out with a larger, the inner diameter, which is 7.3 French, which could accommodate the DF1 or a DF4 Durata lead, which is just about 7.2 at the coil. So you have got 0.1 millimeter space, and then you can use the same CSP locator. And some people have done this, but what I advise here is, for whatever the desperate reason you are using it, please do not push the body into the septum. I think you should stop at getting only the helix at into the septum and look at the parameters, look at the impedance, and look at the morphology, because I do not want the coil also to get inside the septum. So this is that Durata lead, which could be done, and then we have done few cases like this, but then there are issues. It is not recommended to be done routinely. Don't push the body into the septum, and stellate-driven leads, sometimes it is possible to put at the septum, and then the helix could get into the septal area. Maybe it can capture some of the left bundle regions. So for example, this is the stellate-driven lead for the conduction system pacing without the sheath. This is a Medtronic device. And you can get some good QRS morphology, but what is important is you need to be testing the R waves, and you need to be doing a defibrillation. As long as you have not done this, I do not think we should be doing this kind of adventure. So this is all I think I should be saying about the stellate-driven leads. Thanks.
Thank you, Las. Wonderful talk. Any quick comment, or we are already late, so we can discuss during dinner also with the Las.
Yeah, I'll be in Chennai.
Thank you, Las. So we have 3 interesting cases. So Ashish can present his case first.
Yeah, I think we are towards the end of the program, but I'm sure there is some enthusiasm left.
So last year I have had this opportunity to collaborate closely with a center that does pediatric work, and I did this case there. Dr. Snehal Kulkarni is the chief of the services in that pediatric hospital. So this is a case about a 9-year-old child weighing 18 kilograms who has a congenital heart disease, that is a large ASD and pulmonary stenosis and a congenital complete heart block. And obviously the structural heart disease took a priority, and the child got a ASD device closure and balloon pulmonary valvotomy was done. And this continued for 6 months, when finally the child was symptomatic for bradycardia with giddiness, and it was decided to do the pacemaker. The ECG clearly reveals the complete heart block with a narrow QRS escape rhythm, and the child had a normal LV systolic function, and the RA-RV were still in the process of remodeling. There was still some dilatation. How would you do the pacing in this child? You have various options. You can pace RV endocardially or at different places in the conduction system. All of this is probably already discussed earlier. So we have these following options: either do a single chamber VVIR pacemaker, but the downside is the possibility of a pacing induced cardiomyopathy in long term because of the wider QRS when you have a high percentage of RV pacing. You could then therefore consider doing the single chamber pacemaker with conduction system pacing, because the ejection fraction and the dysynchrony tends to be less and probably would mitigate pacing induced cardiomyopathy. I'm not too much in favor of a dual chamber pacemaker at this stage because of the lead concerns in the long term and the venous occlusions that you would face downstream. And at some point in the time, the European recommendations, European guidelines led by Angelo Oricchio did recommend CRT or bi-V pacing for congenital complete heart block, but that little seems to be too aggressive in the absence of LV systolic dysfunction. So do we have evidence to consider conduction system pacing in this group? Probably there are a few studies, one which is from Moore, published 2 years back, where grown-up congenital hearts got conduction system pacing. They were predominantly patients with congenital complete heart block and not having any LV systolic dysfunction. And there is a study from Wang Long who did about 16 patients with, and they were real children, so pediatric pacemakers for congenital complete heart block. So these two groups, the rest all studies are pretty small. So two of these groups have studied grown-up congenital hearts and really in the pediatric age group. And majority, as you see, have done a left bundle area pacing with a good success rate, and there have been very low incidence of complications while doing that, and a follow-up of about less than 2 years. So it seems that it is feasible to do conduction system pacing in the pediatric age group. Now this has not been so well reported in the trials. In fact, children had been excluded from the trials of conduction system pacing, but it has a potential of improving the hemodynamics as compared to conventional pacing. And probably there is a growing evidence that we would take up conduction system pacing even in the pediatric age group and in children with congenital heart disease. So we proceeded to do this, and we used the Medtronic hardware, and at the end of the procedure we had a reasonably good outcome on the ECG with a QR pattern in V1, LVAT of 75 and a QRS width of 90 milliseconds, which probably would be considered very much acceptable. The thresholds were good, the impedance is slightly higher than what is recommended, and there was probably not anodal capture because only the terminal part of the lead was within the septum. So this is the EP part of this case where the block is predominantly proximal, so the HV is normal. That means you could probably achieve a good conduction system pacing, just to highlight that. And this is the ECG. So it was purely ECG based rather than EP based, and you can see that the lead V1 shows clearly a QR pattern. Just to show you the fluoroscopy, and here I would particularly stress that it is good to do those venograms or
septograms to decide how much of the sheath is penetrated, how much of the lead is penetrated into the septum. In the second cartoon, few more turns were given to get the lead inside. And this ECG that is obtained at the end of the procedure, where the QRS width is nicely 96 milliseconds with a QR pattern in V1, would probably suggest a left anterofascical pacing. Fair enough. And we could also maintain a loop in the right atrium because, as you know, the Medtronic lumenless lead is quite lengthy, and therefore you can give this loop, which is preferred in the children. A TE online can help you to monitor the procedure and the extent of penetration, although we didn't do that. But this is just an echocardiogram to demonstrate the penetration of the lead in the short axis and the 4-chamber view. Now, the criteria of where you are pacing might differ than what has been elaborated in the adult studies. So, in an adult patient with a normal heart, you can probably at the end of the procedure say whether it is left anterofascicular pacing or left posterior pacing or left bundle branch pacing or non-selective pacing or deep septal pacing. These criteria are not established in patients with congenital heart disease. And probably the only guide you can take is from the septogram, where you can penetrate till the distal part of the ring electrode is touching the septum, because that would be 10 millimeter from the tip of the helix. So ECG may not exactly guide you, at least the QRS morphology, particularly when you are dealing with complex congenital hearts. How about the ECG criteria? Do they guide you? Now, there are a few probably observations, I would say. So shorter LVAT is good, while 75 milliseconds has been recommended in adults. In children with structurally normal hearts, Wang Long found average LVAT of 61 milliseconds, and in congenital hearts it was 73 milliseconds. So summarily, you might expect a lesser LVAT than what you get in adults. And the V6 V1 interval, which we discussed in one of the previous presentations, which in adults of 44 milliseconds is reported as average, would probably be about 47 or so in one of this study from Moore et al. So ECG guidance can be slightly different in pediatric population or patients with congenital heart disease than what has been reported in adults. But once again, we have talked through these presentations that these values are not absolute, and there are other criteria which we should look at. So whether there are some tips that can be offered in terms of pediatric pacing is the only point that I brought this case for. Is you should probably measure the thickness of the proximal septum well before starting the case, because that is where you are going to penetrate the septum. And the best way to identify the site, Shanmuga has often said that putting the quadripolar catheter to record distal his is your marker, and from there on 1 to 1.5 centimeter or 2 centimeters you should start trying for your left bundle area pacing or drilling the lead. But in pediatrics, you can additionally use RV angiography to kind of locate the septum, less often done, I guess. And doing a electroanatomical mapping would probably be reserved for complex congenital hearts and would be not a routine thing to do. Sometimes the atria are large, and therefore you may have to reshape the C315H sheath to reach the septum. And one of the trick that is offered by this particular author, Jeremy Moore, is that you can use one of the CS sheaths so that you can cut the proximal end of this sheath, including the hub, and use that shape to reach the septum by putting your 315 sheath into this sheath. So these are probably some of the tips. Again, in pediatric, you may not really struggle to get the left bundle capture, but left ventricular septal pacing may not be really inferior in terms of long-term hard outcomes, as long as probably you get the ECG criteria of QR and narrow QRS. At this point in time, you might accept that and not repeatedly try to perforate the septum and redo the drilling again and again. To give you some idea of the extremes, probably the youngest child that has been done in the published literature is 33 months old, lowest weight 13 kgs, and the minimum IV septum thickness about 50 millimeters. So something about this may be considered as doable. Many times actually the conduction system pacing could be a right bundle branch area pacing as in CCTGA, and many of you must have heard earlier Dr. Nambudri's experience of doing this. He has published about 3 cases. And with DTGA with post-atrial switch again, so these are subsystemic, you are drilling into the endocardium of the subsystemic ventricle where you are actually capturing the right bundle. It's a thin structure and therefore you can expect that this procedure would be more challenging than your usual left bundle, which is a relatively broad structure. But these are two anatomies where you may actually be doing a right bundle area pacing. To end this presentation, are there concerns? I think they were all very well expressed in the presentations we had till now. Extraction could be a concern and the experience is not longer than 3 years. Leads have not been explanted. Particularly explanting the lumenless lead is another difficulty that could be there. Ullas, I think just now explained very well the weakness at the stress point, particularly in the stylet driven leads. The fulcrum there can be a point to break. The complex anatomies and physiologies could be challenging to achieve the same, and therefore we may have to accept deep septal pacing. So when it comes to say single ventricle, you might be exposing the lead to systemic circulation, and then whether the benefit of achieving a narrow QRS and kind of preserving the LV function or the single ventricle function would get the upper hand, and managing the LV lead lying in the or the lead lying in the systemic circulation with anticoagulation would be good enough is something to consider. And whether you would use this in some situations where you have RBP like in tetralogy of Fallot, that you narrow the QRS and bring about the RV synchrony. So these are some of the discussions that we may have to face in future when we take up pacing in congenital heart disease more and more. I think I'll stop here, and some people who have experience in this can also add to the present points. Yeah, thank you.
Thank you, Dr. Naba, for providing a very insightful discussion in this topic. I have only one question. Many times when we are doing a left bundle pacing and we have the lead in the right place, but we find that we are not getting the right typical pattern in the V1, and then we decide to leave it there and put an atrial lead. And when we do a ASVP pacing, we get that pattern back. So what do you think it is? It is purely because of the reduction in the injury, or is it because of an antegrade fusion?
No, I think antegrade fusion is something that we probably didn't consider important in these times till these publications came up, both in biventricular pacing as well as in conduction system pacing. It is a good idea that when you don't get the best of the QRS with your complete capture, in situations where you're not dealing with a complete heart block, it could be a good idea to have the antegrade capture fusing. This is particularly a good thing when you're doing the CSP for heart failure indication. Obviously for a Brady pacing indication, this will not hold true. But when you're doing it for a heart failure pacing indication, then it could be a good idea to see what AV interval allows you to give you the fusion and the narrowest QRS. But once again, the programming is going to be difficult, because with exercise and with different situations, the AV is going to vary, and whether what you get when the patient is resting and lying on the table as a good QRS, whether it remains all through during real life, is probably again difficult things to know whether it is all time going to be the same QRS as you get in a resting state on table. But correct. So getting the antegrade fusion with the conduction system pacing paced QRS should be taken help of to get the narrowest QRS.
Thank you, sir. We'll now invite our next speaker, Dr. Arun Gopi.
Yeah, so with all the positive sides of CSPs, I just present two cases which were an eye-opener for me in this arena. So the first case was actually a left bundle lead fracture in a person who was actually a super responder to left bundle optimized CRT. The story is all of a 59-year-old female, dyslipidemia, bronchial asthma, typically had left bundle branch block to begin off with, had preserved LV function, but then EF declined from 50% to 35%. Over time, typically the classical LBB-induced cardiomyopathy, normal coronaries, put on guideline-directed medical therapy with ARNI, SGLT2, MRAs, and beta blockers, continued to be symptomatic, so was taken up for the classical indication for CRT. This was the baseline ECG, shows an IVCD simulating LBB pattern with a QRS duration of 150 milliseconds. So baseline echo shows septum of about 9 mm, no scar, non-ischemic typical LBB cardiomyopathy. Had limited finances, so we went ahead considered a bipolar CRTP. So we taken up for a CRTP. There was a good-sized posterolateral vein, but once we got the lead in, we just couldn't get a narrow QRS with the lead alone, with the CS lead alone. So we went ahead and tried to optimize it with a left bundle lead as well. So Selectra 3D 40 sheath was used, and a Solia 60 lead was tunneled into the interventricular septum to achieve left bundle capture. And this is the fluoroscopic image of the implant, and this is the fluoroscopic image at the end of the implant. Everything looks quite good, and this is after the implant. The thresholds look good. 0.9 left bundle capture threshold, 650 is the impedance, R wave of 6.5. Everything looks good. So this female LBB non-ischemic cardiomyopathy, this is the post-pacing QRS, quite narrow QRS, a QRS of 100 milliseconds after the CRT, and as expected, the EF had a very rapid improvement, no significant MR, no significant PH. Everything looked well in lines for a CRT super response. And this is the ECG 2 weeks down the line on follow-up. Everything again looks good. QRS duration of 100 milliseconds, and clinically patient is asymptomatic now. Suddenly after 2 months, the patient comes back, and this is the ECG. We suddenly find something missing on the ECG. Patient is still asymptomatic, and we find that the LBB is back. The QRS duration is 144 milliseconds. EF has dropped, but she has still no symptoms of heart failure. And we suddenly find abrupt rise in the lead impedance to 3000 ohms. The left bundle lead impedance has risen to 3000 ohms, and it is not capturing. The impedance trends clearly shows that 2 months down the lane, there's an abrupt increase in the left bundle lead impedance. And then we take a fluoroscopy to understand what is happening. So this is the Solia biotronic lead, and at the hinge point, I think Dr. Ullas well alluded to the vulnerable point on the Solia 60 lead. You can actually see at the junction on the septum, the fulcrum. The fulcrum is actually at the vulnerable point, and this is where it actually fractured. This image captures it well. So there is actually a possible conductor fracture visualized by the lead movement at that fulcrum, just distal to the ring electrode at the entry point in the septum, possibly provoked mechanically by the septal contraction with every heartbeat. This happened 2 months down the lane after a successful CSP implant, and we suggested her a RV lead revision, a left bundle lead revision, but she was not willing for a subsequent procedure, so we left her with an RA-LV pacing. That is the right ventricle getting depolarized by native conduction, and left bundle getting the LV getting activated by the CS lead, and still she did very good on clinical follow-up with the RA-LV pacing lead. You can see still we have a narrow QRS and significant improvement of ejection fraction with this. So this lead, as per what we know from the manufacturer report, the rate of conductor fracture is just 0.01%. Stillet-driven lead with the curved delivery sheets for left bundle branch area pacing definitely has a high implant success rate owing to the additional stillet support. But mind you, compared to 3830, it has a larger lumen, 5.9 French versus 4.1 French. In this case, the pacing lead was implanted at a depth less than 12 mm, resulting in a constant movement of the part between the ring and the tip electrode. Probably the mechanical stress provoked the observed conductor fracture. Also, a more basal implant close to tricuspid valve might result in a higher degree of motion stress to this lead. Such a thing has been reported earlier as well in this case report, which was the only case report that time reported. Shanmuga reported one more case with 3830 lead. So there were 2 reported cases. That happened 6 months after the implant, despite having an uncomplicated implant procedure just like us. So here in this case, why it was presented is a left bundle branch area pacing is, we need to watch out in this scenario for newer complications as well. Stellate driven lead, deeper implantation depth more than 12 mm is advisable whenever possible. Covering the ring electrode either into the myocardial tissue, which will definitely protect the inter-electrode space and might avoid a mechanical stress-induced lead fracture. Other option is implanting at oblique ankle for sufficient implantation depth, or selecting patients in whom you have sufficient septal hypertrophy to allow a good depth. Whether it's a specific problem for stellate-driven lead or a lumenless lead also can have this, only time will tell us. But I mean, anyway, keep this in mind whenever you're implanting in shorter septums less than 12 mm and when the vulnerable point is becoming the fulcrum. The second case, again, I'll go fast on this. Here, actually, this was a left bundle area pacing for a person who had intermittent high-grade AV block with documented heart failure in the past. So it was a complete heart block in a person with heart failure with recovered ejection fraction, and so we thought of going in with a conduction system pacing. The procedure went absolutely well. A stellate-driven lead was used. Again, good result on table, normal lead parameters, connected to the pulse generator. The TPA was removed and we came out. This is the final fluoroscopic image. Again, everything looks quite good. This patient only had intermittent high-grade AV block, had intrinsic native rhythm when the implant was done. We shifted her to the ICU. The lead parameters all look good. The thresholds are quite good. You can see the left bundle threshold is 0.7. And this is the paced QRS ECG, has a typical QR. Everything looks good. 4 hours later, echo technician calls us saying that there's something abnormal. We look at the ECG. There's native intrinsic rhythm. We couldn't find anything abnormal. You can see, actually, you can see on the echo, I'll highlight the echo, a spear into the LV. This is actually the left bundle delayed perforation. It's actually happening 4 hours later. A left bundle delayed perforation. You can see the spear into the left ventricle. We take the patient back to the lab, and you will find the lead way into the left ventricle. We retract the screw back, and we did multiple times. It was almost like the cheesy septum described, very easily getting into the left ventricle, and so we went ahead with a conventional pacing, abandoned the option of doing a conduction system pacing. And this case was again presented mainly to highlight the fact that most often after conduct system pacing, we see on these echocardiographic images, the lead tip actually being hyperechoic on the septum. You can see the echo, the lead protruding on the septum. We need to remember that these patients always have a higher risk of embolic complications and strokes in future. So both these cases were just to highlight the fact that everything looks good with conduct system pacing, but some concerns still remain about the fracture in the first case and a delayed perforation happening in the second case into the LV. Again, we need to keep our eyes wide open when we do adopt newer technologies. Thank you.
Thank you, Dr. Gopi, for highlighting the Achilles' heel of conduction system pacing. Are there any questions? If there are none, then we'll proceed to the next speaker,
Excuse
Dr.
me, sir.
Devratta.
I just have one query. In the first case, initially RA-LV pacing was done, and the QRS was not narrow, so we proceeded with the left bundle lead.
Yeah.
And finally, when the left bundle lead got fractured,
we
went to
RA-LV
pacing, but
yes.
this time we got a narrower QRS. So how was that?
No.
Like any alteration was done or?
No, actually the first time when we did it, when we tested it, the QRS duration was, still it was 122 milliseconds. Once we did a conduction system, it was brought down almost to 100 milliseconds. And the actual narrowing happened after the programming. We allowed more of our native conduction. On table, when we were testing, we didn't allow so much of native conduction. And so that is why we had at least 140 milliseconds when we tested on table. Okay. That's why we went for a left bundle optimized CRT. In the long term, it just tells us that RA-LV pacing works well in a person with a typical left bundle branch block.
Okay. Thank you.
Thank you, Dr. Gopi. Now we invite our next speaker, Dr. Devratta Bera.
Thank you, respected chairperson and dear audience. Thank you, AIG team, for giving me this opportunity. When Dr. Daljit sent me the invitation, I found that I was the last man to present. But remember that Harbhajan Singh, sometimes you need him to bat through the last 4-5 overs in the final day of a nail-biting test match. So don't ignore the last person. To begin with the cases, brief 2 cases, very simple cases, not very complex like what Vijayaraman sir or Sanmuga has presented. So this is my first case, who is a 50-year-old gentleman with a non-ischemic cardiomyopathy and a complete left bundle branch block. There was no scar on the CMR, and this was the on-table ECG, as you see that, and during implantation we can see that I don't know, yeah, so now we can see. So during implantation we can see that there is a reasonable descent left bundle capture. In fact, we could show that there was a non-selective to selective transition. We could not show any left bundle potential, although the patient was having a complete LBBB during before the implant. So this was done for a resynchronization purpose. So the procedure was done well, and we had a dual chamber implant with one in the atrial lead and one the ventricular channel in the left bundle lead in the ventricular channel. Surprisingly, on the next day, what we find on the ECG is something just like a pseudo fusion. So the left bundle remained as intact as before. So initially we thought, is there an anodal capture? So, however, as you see that the pacing is happening in the unipolar mode, so most likely it was not anodal capture. The second thing we thought of that is our AV delay not adequately shortened. To begin with, the AV delay of the intrinsic AV delay of the patient PR interval was 160 milliseconds, so we kept the AV delay of 100 milliseconds. At this point, we thought whether there is a micro dislodgement after the successful implant, and this can happen. Sometimes you lost the left bundle capture. We tried to test the device on VVI pacing, and we found that the lead is still capturing well with threshold less than 1 millivolt. 1 volt actually, and then we thought that maybe the AV delay is not significantly short enough for resynchronization. His intrinsic conduction is beating or competing with the AV delay what we have set. So now the sensed AV delay we gradually shortened. This was at 60 milliseconds of sensed AV delay. This is at 50 milliseconds of sensed AV delay, and this is at 40 milliseconds of sensed AV delay. We found these are optimal, and finally we have kept this patient at 40 milliseconds of AV delay. And even with bipolar pacing, as you can see here, that there is a significant resynchronization on the ECG at least. There is a couple of concerns from the ECG. I have just highlighted a couple of leads where you see that the ventricular pacing from the left bundle is even coming before the completion of the P waves. So we are not sure whether this very short AV delay of 40-50 milliseconds is okay or not. Whether the diastolic filling will be compromised in patients where the LV function is already so poor. Echo shall help in optimizing this AV delay. I am not sure about this. I haven't gone through the literature whether that should help or not. But this patient clinically did well for next 2 days. And follow-up echo is pending because this procedure is done just 3 weeks back. So how to program AV delay? There is a very elegant article by Vijayaraman sir and group. So they have said that when you are putting the left bundle area lead in the ventricular port in a dual chamber device, you have to keep a very short AV delay. And they have said that the desired AV delay what you want, you deduct the left bundle to the ventricular EGM interval, which is around 20-30 milliseconds. Like HV interval is 40-50 milliseconds. So left bundle to V interval is usually 20-30 milliseconds. So if you desire a AV delay of 130 milliseconds, set the AV delay at 110 milliseconds or 100 milliseconds. So in this patient, like when we program CRTs, we keep dynamic AV delay or sync AV on, but then you set another AV interval, let's say shortest AV delay of 70 milliseconds. So in this patient, we have kept set a AV delay of 40-50 milliseconds. That means almost equivalent to setting a shortest AV delay of 70 milliseconds in CRT. So this should make sense. The other thing is, if the left bundle area lead is in the atrial port with a backup ventricular pacing, this generally we do when the patient is in atrial fibrillation. Then you keep a little longer AV delay, around 140-150 milliseconds, so that you have enough pacing from the conduction system lead without any myocardial capture, which will just act as a backup. If you have a left bundle area pacing in the atrial port and another lead in the ventricular port, again in the patients who have atrial fibrillation, you have two leads for resynchronization like a LOT CRT. There you actually optimize the AV delay depending on the ECG to get the best ECG and best resynchronization. Coming to my second case briefly, this is a 67-year-old gentleman with atrial fibrillation with complete heart block and recurrent presyncope. His LV function was 45%, and we planned for a procedure with a dual chamber pacemaker with left bundle area pacing with a RV backup lead. So the upper image shows that during implantation we have a decent result with a left bundle capture. Again, we could show non-selective to selective capture. The lower one in the bipolar pacing mode, we can see that there is an anodal capture, and once you lose the anodal capture, there is a selective left bundle capture. On the next day, what we find on the ECG is something like a sandwiching of QRS. When you have without this clinical background what I have given, if you implant a dual chamber pacemaker on the next day you find a sandwiching of a QRS complex, always think that you have incorrectly attached the leads to atrial lead into the ventricular port and ventricular lead into the atrial port. But in this case, we already knew that this was expected, that you have the initial pacing spike in the left bundle lead will lead to a QRS complex, followed by a V delay and followed by a pacing spike. But in this case, it was not because of the AV delay. What happened was there was a A pace followed by a V sense, and immediately there is a V pace. This is called ventricular safety pacing. High volume implanters like AIG, everyone knows that this happens, but for the beginners or fellows, you should know that when you are putting a left bundle lead and connecting it to the atrial port and a RV backup lead, this is going to happen. Almost universally this is going to happen, that you will have a ventricular sense as soon as your left bundle captures, and then there will be an end of the ventricular safety pacing window. You will have pacing because of the ventricular safety pacing. Initially I thought I'll keep this on because I wanted to keep the safety on, even if there is a loss of capture from the atrial port, that is the left bundle port, we should have a backup pacing. But after reading a little couple of articles, I understood that even if you switch off the ventricular safety pacing, you are safe, because if your atrial channel, this channel which is in the left bundle port, fails to capture, then what happens, this ventricular sense is not going to happen. So at the end of the AV delay, whatever set AV delay, you are anyway going to get the backup pacing. So you don't have to keep the ventricular safety pacing on to get a more confidence that, okay, I have a backup lead. Anyway, it is going to pace if you have a loss of left bundle capture. So there are a couple of things when you try to switch off ventricular safety pacing. That is, you have to switch off the atrial capture management to be turned off. Secondly, make sure there is absence of a true crosstalk. So for that, you have to pace the atrial port at the highest maximum output in the unipolar mode. So this was the final positioning. I was also wondering that whether these two leads, the backup lead and the conduction lead, are very close by, that is giving rise to the safety pacing, but this is not the case. It is anyway going to happen. This is a universal thing which is going to happen. So the short AP V-sense interval almost always falls within the ventricular safety pacing window, which varies in Abbott, it is around 64 milliseconds, and in Medtronic it is around 110 milliseconds. So at the end of, this was a Medtronic device, 110 milliseconds, you are expecting a ventricular safety pacing. And although this is not harmful, but it results in unnecessary battery drainage, and inactivation of this feature should be considered. However, at the risk of atrioventricular crosstalk, you need to exclude that there is a no true crosstalk presently available. Now, this feature cannot be inactivated in Biotronic devices where the ventricular safety pacing window is around 100 milliseconds, and this does not exist in Boston Scientific devices, which rely on a re-triggering noise window to avoid crosstalk. Now, there is another important advantage of switching off the ventricular safety pacing, because if you inactivate ventricular safety pacing, you will indirectly get the information about loss of your left bundle capture, because the percentage of APVP will tell you that much of percentage you are having loss of left bundle capture. Let's say 20%, you should expect a APVS 100%. If you have 20% APVP, that means you have intermittent loss of left bundle capture. So to conclude, and the final day of the test match, that programming optimal AV delay is cornerstone of successful resynchronization in conduction system pacing. Generally, it has to be short and fixed, turn off any dynamic AV delay. And when you are using left bundle lead in the RA port, in cases where there is a permanent atrial fibrillation, it is better to turn off ventricular safety pacing after confirming the crosstalk with high output unipolar pacing from AI from the left bundle port. Thank you so much for the unique opportunity, and I'll be happy to answer any question.
Thank you, Dr. Bera. Only one question, that when you do a traditional CRT versus a lot or a hot CRT, while programming the VV delays, do you have any different practices, or do you program the same way as you would do it for both of them?
You are talking about lot CRT or hot CRT, so, and you mean to say that one lead is in the left bundle lead in the any of the port, and to be honest, I have not done much of lot because of hospital policies and issues. I think the VV delay has to be adjusted again on based on the ECG, and again this connection, which port to be connected where, this is one important issue. Again, Vijayaraman sir paper mentions on that a lot, because our left bundle port cannot sense it. I think it's better to keep the RV port in the RV channel where the sensing happens, and the CS lead has to go to the left bundle port. So let's say you are using left bundle area pacing, that should go into the RV port. That much I can say. Daljit ma'am, any comments on this?
You're talking about, so you have a defibrillation and all, it doesn't sense from LV. Except for Medtronic, your Biotronic, your Boston, both senses from LV, but it doesn't utilize this for tachycardia therapy or tachycardia sensing. It uses only for safety, it uses only RV lead. So that's true. That's the reason we are not using his bundle lead into the RV port, right? Because sensing issues are there. So when the sensing issues are there, be clear, like you're putting left bundle lead into the your RV port.
Yes.
Left bundle lead into the RV port. Do we have any other questions? Thank you, Dev. Very much.
Thank you,
very nice cases, Dev, and I would
very
like
simple cases. You mean
no,
to say
no,
after the brainstorming throughout the day, you got some mental peace at the end.
Stop pulling my leg, Dev.
Thank you, thank you, thank you.
Thank you, Dr. Anup. Thank you, Chavan sir. Thank you, Chetan, and thank you, Mala, for being there. And we are not done yet. Although we are emptying from here, we are going to Westin. We have a dinner symposium in Westin. Last but not the least, we can collect certificates. We have a credit points, certificates from the registration counter while leaving this place. And we are starting the session there by 7:30. We are already late. Thank you very much. Thank you.